Indian Academy of Otolaryngology and Head Neck Surgery. With a special thanks to the...
Yeah.
Hello.
Yeah, Satish, the chairpersons are trying to communicate with you. Are they audible? Dr.
Yes, yes.
Manish Munjal and Dr. Satish Mehta.
I can hear you well.
Hello, hello, Satish Jain.
Yes,
Hello.
boss.
Yes, I'm Satish Mehta.
Hello,
And
sir. How are you?
Accompanying me is Manish Munjal.
So
We are
nice
both
of
the
you.
moderator for your session.
Both
It's
are
a
masters.
It's great privilege. And
Satish, इनको पहचानो.
Yeah.
Good morning, Satish.
Hello, boss. How are you?
Very good. His guest working. He's still
So
not got it.
nice to see both of you on screen, smiling. And it's a pleasure having, our day beginning with you masters. Thank you so much. And before we
Dr.
start,
Satish, that was Dr. Madan Kapre. He's on the front seat. You're looking at the chairpersons who are on the dais.
oh,
I had given the
Kapre sir has
microphone
come.
to Dr. Madan Kapre, sir. He wants to say hello to you.
Good morning, Satish.
good morning, Mr. President. How are you, sir?
Yeah, forget that part will be soon done and over with. But like your cap, very nice.
Thank you. Thank you, sir.
It is-
And now
And,
wait for the surgery.
Thank you.
Cap
And
is-
big thanks
cap is
to the...
typical.
Good morning, sir.
Good
Kusum here.
morning. Good morning, madam. How are you?
बस देख रहे हैं आपको.
So nice. So before we start, I would like to thank certain people who have done enormous hard work behind organizing this conference. Biggest thanks to Dr. Mohan Kameshwaran, the Mohan Kameshwaran, for bringing this, academic concept and propagating academics throughout the country. And the president, Professor Madan Kapre sir, and Vijay Krishnan sir, who is the most dynamic secretary ever. And for the organizing team, believe me, my heartfelt thanks to Dr. Rohan and his team, and special blessings from Sunil Kotwal sir for, making all the arrangements, all big arrangements in Jammu. You can't believe the way they have put in the hard work to organize this conference is something, beyond anyone's capacity. Thank you so much, Rohan and Kotwal sir, for making this happen. And for today's session, this is a live surgical session wherein we are going to demonstrate this list of cases. We are starting with the basics, as Rohan asked. We'll start with a case of sinus surgery, massive polyposis, then with a stepidotomy, then with a subtotal petrojectomy and cochlear implant, same stage for a case of cholesteatoma with bilateral profound deafness. Then we have some exclusive cases of angiofibromas with certain, difficult extensions, and I have been asked to demonstrate them. As a lot of people have picked up angiofibroma surgery and doing in their centers. So still they are finding, some difficulties and want more and more to see such cases. So today we have cases like the first one having all extensions, including orbit and cavernous sinus, and the second one with a massive skull base and cavernous sinus and huge parapharyngeal extensions. Then we have glomus tympanicum as well, and if time permits, we'll demonstrate parotid as well. So this session is going to, as Rohan asked, is likely to go on till 6 o'clock or so. Let's see how we go ahead. We have, I can see on screen, our Master Blaster, Dr. Ashish Bhumkar, also for our expert comments. Thank you, Ashish, for always being part of our academic. Very soon we are going to have Dr. Dharamveer Sethi from Singapore and probably Professor Eldo Stem from Brazil as well. So thank you all for giving this opportunity once again for this live surgical session. Now, coming to the first case, do I go ahead or anything you want to me to?
Yes. If you give a brief clinical history of the patient, that will be better connect.
Yes. So that's very important, boss. Why we are operating. This particular patient has a classical history of nasal obstruction, bilateral nasal obstruction, rhinorrhea, occasional, postnasal drip, headache, all classical symptoms of CRS, chronic rhinosinusitis. For months together, has taken courses of steroids with minimal relief in between. And we'll show you the clinical picture how patient is having grade 4 polyps occupying the nasal space and giving complete nasal obstruction. In spite of all, appropriate medical management. So that is a classical indication for functional endoscopic sinus surgery. Since you have asked for the clinical details,
Yes.
this is very, very appropriate to have asked. Reason being, CRS is almost always diagnosed on clinical grounds. Endoscopy and radiology further substantiates your diagnosis.
Absolutely right.
Why we are operating? When the appropriate medical management is not able to handle the chronic inflammatory process. That is too extensive to be handled by appropriate medical management, which has its limitation to give topical steroid and saline irrigation. We can't use oral steroids for long as they have their own adverse effects. So the goal of sinus surgery here, the indication and the goal for sinus surgery is three-pronged. One is to remove this inflammatory load. This is an inflammatory disease driven by certain cytokines. We have understood a lot about the cascade of pathway involved in causation of this disease. So the first goal is to remove the inflammatory load. Second is to, like what Professor Stamberger and Messerschmitt propagated and it still exists, that concept, establishing the ventilation and drainage for the health of the paranasal sinuses. And the third, which is more important nowadays to, fight with the inflammation, is to prevent recurrence, is to give opportunity or to give access for the topical steroids to penetrate. Because in the present context, the only weapon we have which works in the entire inflammatory cascade of CRS is steroid, steroid, and steroid. Nothing works. Biologics have come in role, but it will take time to establish themselves. A lot of studies are going on, long-term efficacy, adverse effects, pricing, everything is, under monitoring. So it will take time to establish, and maybe that is going to be the future to curb this inflammatory process at the molecular level rather than after treating after the clinical manifestation, which is what we see as a polyposis. So in the present context, we have a weapon, functional endoscopic sinus surgery, to deal with this situation with three-pronged indications. To reduce the inflammatory process to be tackled by the topical steroid later on, so the oral steroids are not needed in the future. Establishing ventilation drainage of the paranasal sinuses for their normal health, so the patient becomes symptom-free, and it gives access to the topical education. So the goal of surgery is to provide wide access for the topical steroids to penetrate deep into the sinus mucosa, which is actually the site of inflammation. So the goal of sinus surgery, once it comes to sinus surgery, is to execute in such a way that post-operatively your all sinuses remain patent, and whatever steroid you introduce by means of douching should be able to penetrate all paranasal sinuses. That should be our goal, and keeping in that mind, the sinus surgery is planned. So in this particular case, when we plan sinus surgery, we should have a fine section 3-dimensional CT scan. Generally, we ask the CT scan to be shot in finest section in DICOM format in axial plane, and then we can reconstruct with this software in all planes. So this is an amazing tool to have a full idea of 3-dimensional anatomy of the paranasal sinuses. And this is how we can reconstruct into fine section. You can see these fine section. Now this is 0.6 mm. Every movement I move, it moves by 0.6 mm. This is so fine so that we don't miss any smallest, finest of the anatomy in this region. This is very important. The reason being, this surgery has a very less safety margins. paranasal sinuses are so strategically situated that it is surrounded all around by skull base, orbit, carotid artery, optic nerve. So important structures all around. So we have to be very, very accurate in our orientation, in our surgical planning, intraoperatively as well. Even a sub-millimetric, disorientation can invite major problem, can invite disaster even. So one has to be very, very careful. And CT scan is one which gives you three-dimensional orientation in all planes. So it improves your safety quotient. If you read the CT scan thoroughly in all planes are required. We all know this coronal gives you maximum information in the same plane in which we operate. Easier to understand. But there are certain anatomical information are best given off by the sagittal plane like frontal sinus, skull base, all those. Axial gives better, information for certain structures like nasopharyngeal structures, like, even the frontal sinus, the osteometal complex, orbital anatomy, the entire length of the orbit in the interposterior plane can be, and relationship with the paranasal sinuses can be best studied in the axial plane, so on. So we should be able to read CT scan thoroughly in all planes. Here, I am not going in details of the CT scan because of the, as we have seen, we have list of cases. But yes, I will throw some light on the, the available positive findings. So how to go through? Say this. This is CT scan in the coronal plane. I am going behind. What you see, this normal anatomy, the nasal bone, frontonasal process, ala, cartilaginous septum, frontal bone. Then the pneumatization of the frontal bone appears with full opacification, bilateral full opacification of frontal sinuses. You can see big frontal sinuses with full opacification, and the intersinus septum looks like completely destroyed by the pressure erosion, by the disease itself, pressure erosion. Now you see this opacity coming in the nasal cavity, giving high deviation to the right side as well. This is all important. Even the treatment of the high deviation is very, very important right from the beginning, from planning to inform your patient and carry out. Reason being, if you don't treat this, this may become an obstacle in your post-operative douching, and that can invite synechia if you go through the narrow spaces and give raw areas. So even a smallest mistake can, result in failure. So you have to read everything and, follow everything and carry out accordingly. Then as we go behind, see this. This is frontal sinus with the floor. This floor is beak. I am going from anterior to posterior, and what I see is the beak. The moment the beak ends the frontal sinus open, that is what I am going to show you. For junior colleagues, there have been a lot of, controversies, a lot of difficulties people face in frontal sinus surgery, which I am going to make the simplest ever. You follow the beak. Where the beak ends has to be frontal sinus, whatsoever the, anatomical abnormality, anatomical variation is. We can see on screen Professor Dharamveer Sethi from Singapore. Welcome, sir. And we are all indebted to you for your teachings in sinus surgery, which we have been following for decades now. Thank you so much for always showering your blessings and teaching us. So, this is about the CT scan I was going about. So, this is very, very important for junior colleagues. Believe me, for any most difficult situation of the frontal sinus, if you follow the beak from anterior to posterior using 70 degree, where the beak ends, has to be frontal. Let's look into, all planes. See this. See this beak in the sagittal plane. See this beak in the sagittal plane. What I'm trying to say, this is the beak. This is your beak, which is the obstacle. When we come with the endoscope from here to look into the frontal sinus, which is so anterosuperiorly strategically located, making our life difficult in visualization of interior of the frontal sinus. Now see, with the 70 degree, this beak is the obstacle. Follow this beak. Follow this beak. Where the beak ends has to be frontal in any given situation. Whatsoever the anatomical variation is, that's what I'm going to show you to make your life easier rather than following X, Y, Z landmarks and making your life more and more difficult. So this is very, very important to understand the role of value of beak. So this is what we are going to correlate intraoperatively as well. So as we go behind, where the beak ends is the beginning of the frontal drainage pathway. This is what we have to pick up, what we have learned from CT scan, what we have to correlate intraoperatively. Then as we go behind, now see the frontal sinus has ended and this crista galli and the cribriform plate has appeared as we go behind. This is, we are going from anterior to posterior, and what we see this cribriform plate which is a horizontal and a lateral lamella which is further continuing as a thick frontal bone forming the roof. So this is frontal drainage pathway. After that ends is the cribriform plate. The beginning with the central part is the crista galli, and in this particular patient is a complete whiteout, complete opacification. All cellular septations have been partially destroyed, making like a cavity everywhere. See the lamina papracia, see the maxillary sinus complete whiteout. Nasal septum little deviated, high deviation. Even the turbinates have been, pissed off because of the pressure of the polyps. And see the turbinates becoming, the bone becoming, eroded, atrophic, not being visualized very well on CT scan. And as you go behind, what you see here, this is anterethmoidal roof. See this cribriform plate. What you see, this beaking of the orbit. This is medial rector, this is superior oblique. What you see is this beaking of the orbit. Workshop beaking of the orbit, and that leads to the anterethmoidal artery, piercing the lateral lamella here and entering the intracranial space. The moment we cross this, the posterior ethmoidal roof starts. That's very important point to, understand. The moment we cross it, the posterior ethmoidal roof starts. Let's see to, shatter your fear about the anterethmoidal artery. Let me take this point where exactly the anterethmoidal artery leaves the orbit and look into the sagittal plane. See in the sagittal plane. This is frontal sinus. That the posterior edge of the frontal sinus, anterethmoidal artery is more than a centimeter behind. So while working in the frontal sinus, that too with 70 degree, we don't have to, frightened about the anterethmoidal artery all the time, as it is far behind. Behind the frontal sinus is the anterethmoidal roof starts. Where the anterethmoidal roof ends, where the posterior ethmoidal roof starts, just before that, you will see the anterethmoidal artery, piercing the lateral lamella. So it is far behind. You don't have to, terrify all the time while doing the frontal sinus work regarding this vessel. So this is far behind. See the frontal sinus and where far behind is the artery. Then as you go further behind, see complete opacification, posterior ethmoidal roof, all common cavity, sphenoid sinus, opacified, more on the left side. And this is how the lateral recess on the left side, the huge lateral recess, that is pneumatization of the pterygoid bone. Look at the pterygoid bone on this side, pterygoid base. And see this pterygoid base is pneumatized in continuity with the sphenoid cavity, termed as a lateral recess of the sphenoid sinus. So this is the case today. I am going to start without wasting time as we had a little delay. So the first case is going to be this. I am going to demonstrate one side at least. Then next case will be stepidotomy. Then we'll have a subtotal petrojectomy with cochlear implantation. Same stage for a case of cholesteatoma with bilateral profound deafness. Then we'll have JNA with cavernous sinus extension, glomus tympanicum, and JNA with major skull-based cavernous sinus parapharyngeal extension. That's how our day going to be. So before we start, any questions, any suggestion, any query or anything you want me to show more on radiology?
Well, Satish, I will be interrupting you as soon as get the questions from the audience.
Anytime, boss. Feel free.
Okay, thank you. Carry on.
We can questions intraoperatively as well. Anytime you feel free to interrupt. So, any suggestions from anybody are always welcome.
Dr. Vikram is there to ask you something.
Satish, I just wanted to know, is there any particular sequence you demand from your radiologist for CTPNS study?
Yes, I mentioned, boss. We want 0.5 mm fine sections in axial plane
Okay,
in DICOM format. In DICOM format,
correct.
rest you can reconstruct on your software. We can't,
Okay.
your question is very, very relevant. The problem is the radiologist, why we are getting the CT scan done? Not for the diagnosis. We want for the anatomical details. The paranasal sinuses anatomy is so variable. There are so many, variable cells making our life difficult, making, prone to complications. And each and every cell has to be skull base, orbit, everything has to be seen thoroughly. We had given printouts to the radiologists earlier, with almost more than 300 points to be described. What exactly are the distances about the carotid artery, optic nerve, dehiscence, prominence, cell, onody cell, frontal cell, this cell, that cell, and number of things which we want, kind of cribiform variation, high deviation, everything. It takes hours and hours for the radiologist to fill that, and they simply refuse. And nowhere in the world the radiologist can, spare that much of time to report that. So the onus is on surgeon to, collect the information which is useful from surgical point of view by the radiology himself. So the onus is on us to derive surgically relevant information from the scans. That's why we order 0.5 mm in DICOM format, reconstruct and see in the dynamic fashion. You see 3-dimensional CT, that too dynamic. That's a good teaching tool also for the junior colleagues to understand the CT scan 3-dimensionally. So that's how we order our CT scan.
And any different protocol for angiofibromas and skull-based tumors, or it's the same,
Yes.
whether it is sinusitis or antrocornal polyp or...
Angiofibroma and polyps are different ballgame. Those are tumors where you need more detailed information by means of different sequences, by means of MRIs, by means of contrast studies, by means of angiographic studies. Here in PNS, this is pure inflammatory disease, and we order simple, non-contrast, plain CT scan, high-resolution CT scan, sub-millimetric CT scan without any contrast.
Okay. So my request to you is, if you could come out with a protocol-based, manual sort of something, which, the Indian Academy can share with all its members, so that, it becomes an easy reference source for all the clinicians who are especially members of the Indian Academy.
Sure. And this is very, very important point Dr. Khanna has raised. I tell you why. The reason being, suppose you're ordering a MRI for a tumor, skull-based tumor. What do you order? MRI brain, MRI skull-based. That's it. What radiologists will do? MRI takes time, Every sequence has to be shot separately in every plane. Like suppose the MRI order for JNA. I want T1 sequences in all planes, axial, coronal, sagittal. I want T2 sequences in all planes, axial, coronal, sagittal. I want T2 fat suppress to see the bone marrow invasion, the pterygoid marrow invasion. I'll show you in the JNA case. So T2 fat suppress sequences in all planes. Then I want contrast in all planes. Then I want angiogram, a 3D angiogram. Then you want diffusion weighted to differentiate between benign and malignant. So all these sequences are required. Now what happens if you don't order? Every sequence has to be shot separately. The way the sequences which I have mentioned to order in JNA, it takes more than 1.5 hours. Now, if you don't mention this, what the MRI guy, what the radiologist, the technician will do? You write MRI, PNS, skull base, whatever, or JNA, they will do 2 or 3 sequences and finish off in 10 minutes. And what ultimately, who is going to suffer? the surgeon as well as patient, because you don't get adequate information. Each sequence has its role in providing, some unique information which you want before. So you get ultimately inadequate information, and ultimately you get a sorry figure in terms of misdiagnosis, in terms of surprises during surgery and all that. So ideally, the onus is on surgeon to prescribe the desired scan for every other pathology you suspect. Every pathology you suspect, you have to, like for CSF, I will order CT scan with contrast to see meningitis, MRI with contrast to see meningitis, MR cystonogram to see T2 weighted, heavily T2 weighted imaging, 3D drive imaging to see fine sections, 3D flare to see inverse imaging to rule out, to differentiate CSF from sinusitis and other sequences. So the onus is on surgeon. If you write MRI brain, it won't give any information, any useful information, and the radiologist or technician will finish in 10 minutes. The MRI will be same, but what happens? We experience a lot of problems. Sometimes patient brings an MRI and then we order again. But this is not adequate. I have to get it, again to get more information. And the patient one time resist. I have already had the MRI, and doctor, you are, advising again. This is not fair. So this is kind of a thing. We have to have a universal protocol. Dr. Vikram Khanna, what the point you have raised is absolutely valid. It should be a uniform protocol among the surgeon to order investigation for particular, pathology. Otherwise, what happens? Patient brings a printout of CT-PNS, which is as good as useless for us. As good as useless. It cannot give fine section, three-dimensional dynamic information, and ultimately you can, be placed in problems sometimes because of that inadequate information.
Satish, hello.
Yes, boss.
Manish here.
Yes, boss.
For benefit of colleagues or juniors, could you just specify where to order a bone window and a soft tissue window? What is the relevance of that?
Yeah. Boss, your point is again valid. In this DICOM format, you don't have to ask for bone or soft tissue window separately, With this software, you can reconstruct the bone and soft tissue window on your own. You don't need to. This is an amazing software. I will show you after this case. Please remind me. The same CT scan I had shown you, I'll show you both by changing the window setting to bone and soft tissue window. You don't need to order anything else. Fine section 0.5 mm CT high resolution CT scan in DICOM format. That's it. Rest your software will do. And this is very important what boss has asked, because certain structure soft tissues are better seen in soft tissue window settings. And you have to ask for it unless you have a DICOM format. If you have a printout, you cannot see anything. You cannot change it. So forget the printouts, is a past now. We have to move forward to derive more and more information which is, surgically relevant in our practice. This is very, very important, because a single printout patient carrying is as good as useless. See this, what you are trying to say.
Yeah.
See this? This was the axial section. Hello?
Very clear. Very clear.
Now,
Yes, please carry on.
Let me change you window setting. Can you see this? Now the soft tissues have been suppressed. Only the bone settings have been, this is bone window setting. See,
Satish,
no surrounding soft tissue can be discriminated. Can you see?
Yes.
Satish,
Yes, boss.
I notice here that these are 1.3 millimeter cuts. I thought you mentioned they're 0.6 or 0.5.
Yeah. Because this patient had already brought us, so we didn't repeat.
Yes. So ideally we do 0.5 millimeter cuts.
Yeah, 0.5 mm. Always.
Yes,
Once it comes
always.
to ordering, it is always 0.5
And
mm.
those cuts are called the source data. Sometimes you don't even need their sagittal reconstruction or coronary reconstruction. Because you can do it yourself on the multi-planar platform. So
Yes,
all you need is the source data.
Yes. Always desire the source data. So that once you order, and see, this should be a rapport with your radiologist, that what kind of radiology you want, so that you don't need to ask them again and again. This is how a relationship works. See now, so what I have converted this to bone window. All soft tissues have been suppressed. See in the orbit, in the infratemporal fossa, no soft tissue is seen anywhere in the brain. No soft tissues have been highlighted. Only the bones are highlighted. Even the thin bone of the lamina papyracea, you can see. Even the finest of the erosion you can pick up in bone window. Can you see? Now I am converting to soft tissue.
Yes,
Can you
yes,
see now?
please. Yes,
Can you see the soft tissue window now?
clear, very clear.
See the inside of the orbit. All soft tissues, the optic nerve, recti muscles, all have been highlighted. Even into the brain, you can see the areas of the ventricle, CSF, and the brain have been distinguished. Even in the infratemporal fossa, all muscles, parapharyngeal space, everything is distinguished. This is soft tissue window. I just didn't do anything, just change my window setting on this software. So again, I can change to bone window. See this?
Yeah.
See this?
Yeah.
Now it is bone window again. So you just have to ask 0.5 mm DICOM format. That's it. Rest your software. This DICOM viewer Radiant is amazing. Any other question?
Any question from the audience, please? Do
For the
communicate to
audience?
us. We will ask.
For the audience, Dr. Dhamvir Sethi has been working on last couple of years more and more on the radiology to make the surgeon's life simpler, making the radiology more informative from surgical perspective. I have, gone through his presentations, witnessed them, and it is amazingly beneficial to everybody.
Right.
So, in a couple of minutes, we are starting with endoscopic picture. We can continue our questions. You're all requested to interrupt me any point of time to make it more and more interactive.
Sure.
Funny.
Again, my request to the audience, if you have any queries, any question, please pass on the slip. We will ask you on your behalf.
Satish,
Yes, boss.
if you have some time, few minutes, like 3-4 minutes, maybe you can show them all the some of the important features of the Radiant DICOM viewer.
Okay. So, boss, I'm washing up for this case. Once I wash out, I will show you.
No problem.
Definitely. Please, if I forget, please remind me. This is very important.
I'm familiar with that, but I think it's very important for the participants to know the amazing tools that this software has, and and unless you know, you won't be able to use it.
Yeah, that's Dr. Dharamveer. Morning, sir.
Good morning.
Good morning, sir.
Everyone.
Manish here and Dr. Satish Mehta with me.
इधर को on करो. See, radiology, the science of radiology is technology. And technology is, progressing so fast. It is developing so fast, 1,000 times faster than the surgical science. And it is the time to take the full advantage of this technology, radiology, to improve our surgical experience.
Yes, Satish, also the important thing is that these tools have become available now free of charge on the internet. You can just download it. Previously, they were available only to the radiologists who would have the highest end of the DICOM viewers in their stations, and we would be just given us hard copies, which were difficult to read and understand. So these tools are now become readily available, and I think and they're free of charge, and everyone should be using them.
Yes.
Hey, hi Ashish.
Hi. Where is Sati? I don't see him.
He's washing up.
Hello.
Yeah,
Hello.
where are you?
Hello.
Hi, Satish. Hi.
Yeah, can you carry boss endoscopic picture? Lagao. So let me connect you to the endoscopic picture. We have seen a complete CT scan, bilateral pansinusitis with polyposis. And we are all set with the endoscopic picture. I am going to show you at least on one side, left side has more, important anatomy with lateral recess and all that. So probably whatever you ask me to show, let me show you endoscopic picture. Then whatever you say, I'll show you. Which side, right or left? On karo na.
Light off करवा लें.
Endoscopic. यार
Right
तुम
off
क्या
कर
कर रहे थे मतलब?
Excuse
Just
me,
a
could you
moment.
switch off this light? Light off.
Band.
So in a moment, we are connecting to endoscopic picture now. कर क्या रहा था ये?
Online link भी है उसका.
Sati, all right. You want to say hi to him? That conference no, doesn't matter. Yes, sir. Actually, just went down.
कनेक्ट तो करवाते इतनी देर में.
कौन सा link है? भेजा क्या?
लिखा नहीं बस चल रहा है तो ऑनलाइन बता रहा है इसको रसीद में है मुंबई में है तो होगा ही
ये उनको दिया होगा ना.
इतनी देर से
नहीं दिया होगा
बकवास कर रहा है.
सर्जिकल का हो सकता है.
1 घंटे से बैठा हुआ है, 3 घंटे. चेक तो करना था मैं. बस यही करते हो आप.
चलो दिखाओ बिना पैक करके कैसा दिखता है नाक आपका भी अंदर से. हेलो.
पकड़ के रखो.
ये सही नहीं डेलीगेट से कुछ
काफी हो चुके हैं ना.
ऑनलाइन है ना नहीं है तो अपने देख लो आगे नेट
काम करते करते सामने जैसे हम करते हैं. नहीं तो वैसे ही करते हैं. वो तो मूवीज इस पे देखते हैं
सही
है ना. देखे ना जो बच्चे तो देख आईपैड पे मूवी देखी होती है सारी. हमें तो मजा नहीं आता इस पे.
अब टाइम
कहाँ है?
चेंज
कहाँ है?
उन्होंने देखा वही है.
अच्छा छोटे छोटे बच्चे हैं पैदा होते
हेलो.
मोबाइल पकड़
हेलो.
yes please yes we are there yes nice picture we are getting a nice view you can see the polypi on the left side of the nose
I hope the picture is good.
absolutely fine as clear as your voice
Oh,
लाइट ऑफ करवा दो.
okay. So that's the
Yeah.
picture of the left nasal cavity. And what you see here, this is unprepared. And what you see here are multiple polypi.
right
Similarly, on the right side, these polypi with some high deviation. This is what I mentioned during radiology.
Yes,
See,
yes, for
what I
post-op
mentioned,
care.
in spite of, this high deviation with decongestion, I can carry out this surgical work without any hassle. But what can happen? Because of the narrow space, I can make the opposing surfaces row with my instruments passing again and again. So it is always better to correct this high deviation so that your douching goes uninterrupted in the depth of the sinuses. Okay. Now,
Yes,
as
point well taken.
I mentioned in the beginning, this surgery has a very low threshold.
कहाँ से
So,
बात कर रहे हो? हाँ, किससे?
बोलते म्यूट कर दिया अगर बीच में यार
ये हॉस्पिटल के इमरजेंसी का फोन नंबर है, वहाँ पे डॉक्टर साहब सर्जरी करते हैं, बाद में बात करना है।
लो हेलो हेलो
Yeah, Satish, you are quite audible. Please go ahead. Start.
Yeah. So what I am doing is the intraoperative preparation.
Yes, you are using Marocel coated with
Yes.
adrenaline.
Saline adrenaline. This
Right.
is a middle-aged patient. I am using 1:2. वो उल्टी सी आवाज है, म्यूट कर दिया कर, म्यूट कर दिया कर. Hello.
Yes, yes, please.
So I am soaking my marrow cell. See this soft marrow cell
Yes.
in saline and adrenaline to apply adrenaline on the surface. No pressure at all. This is just to apply the adrenaline on the mucosal surface to decongest the capillaries. The source of bleeding in sinus surgery is from capillaries, and in order to improvise your surgical field, which is very, very important, your intraoperative visualization is the most important key to prevent complications. If there is too much of bleeding, it will be difficult to identify the landmarks. And if you don't identify the landmarks, you're likely to land up in complications. So visualization is the key to prevent complication. And this preparation starts days or weeks before surgery. As this is inflammatory disease, we use corticosteroids. And if there is superadded infection, some antibiotics also for short course. Reduce the inflammation. Intraoperatively, this preparation, just topical steroid, no pressure, apply all over, decongest the capillaries. The first single application will prevent the adrenaline getting absorbed in the systemic circulation as it decongests the vessels. So it is
How much dose? Excuse me, what's the dosage of steroid you are using for every patient?
Boss, it is not fixed. Elderly, 1:4. Middle-aged patient, 1:2. Young patient, even pure. I don't mind using pure even one.
No. My question was use of oral steroid for preparation.
Okay, oral steroids, depending upon the days we have for the surgery, but we start with like 40 milligram a day for 3 days, then 2 days reducing, tapering, 10 milligram, and then, stop pre-operatively. Antibiotics have hardly any role except non-polypoidal sinusitis, or there is any proven superadded secondary infection. Otherwise, it is a topical steroid which has a big role. My anesthesiologist is the key. See this. Let me show you the parameters.
Yes.
We never ask for the hypotensive anesthesia. See the normotensive. What we ask is the reduced cardiac output by means of reducing the heart rate.
Heart
See,
rate.
the heart rate is 61, which is key to reduce the overall cardiac output and overall capillary bleeding. This is the key parameter to the surgical.
So, convey our appreciation to the anesthetist.
Great anesthesiologist Dr. Anupam, who has been with me for years, and he has given anesthesia in more than 150,000 cases. So he knows what I want to go together. So finish preparation.
Yes, very nice.
Application, nothing else. This left side. So my surgery now starts with the clearance of luminal polyps to see me to uncover the anatomy. As we go further, we will keep uncovering the anatomy. This is a surgery of landmark. See, keep your cutting edge of the shaver, microdebrider under vision. Under vision, so you don't traumatize the, normal mucosa anywhere. See now the nasopharynx coming into view.
Yes, yes, clear.
My assistant all the time is, irrigating to keep my field better. See the coina?
Very clear. Absolutely clear.
Which side से दौड़ बोला? See all these polyps, even medial to the middle turbinate. Can you see?
Yes, yes.
So I am just clearing these luminal polyps. That's it. To uncover my anatomy.
Do you give steroids even in case of diabetic patient who has to undergo surgery?
Yeah, in low doses, keeping the eye on the blood sugar. We,
Right.
yes, for the initial preparation for a couple of days.
Right.
But see, I told you about the turbinates. Even on the
Yes.
scans, the turbinates were,
Opacified. Yeah.
yes, atrophic because of the pressure of the polyps on from either side.
Satish, you said you give steroids pre-op.
This
Do
is
you ever face,
yeah.
Satish? You said that you give steroids pre-op many times, and that too oral steroids. Would you go in for methylprednisolone or deflagot, or what is your preference?
Plain prednisolone, nothing else.
Plain prednisone. And the second thing is, when you give steroids, many times we see the polyps vanishing, and most important is the patient doesn't come back for surgery. So, what is your take on that?
Yeah, that's very important. See, that can happen. So it is how you counsel and what you counsel. See, we have to counsel our patient that if I give you steroids, the steroids will control your symptoms definitely, and you'll feel much better. You'll not feel like getting operated. But the moment you stop the oral steroid, it is going to come back. It is bound to come back. So, our goal of surgery is to remove all this disease, reduce the disease, and give access to the topical steroids so that you don't need oral steroids in future. And for this surgery, we'll give you a good course of steroid to prepare. The day when you feel like you are absolutely disease-free, that will be the best, time to operate upon. So you have to counsel. As long as your symptoms, as you have active symptoms, you need more steroid to prepare for surgery for a better operation, so that we can carry out the best available surgery, best possible surgery. It is to counsel that. We tell them that next 10 days, we will give you oral steroids, though they are hazardous, but still we are giving to improve the field so that we can carry out a better surgery. You will feel like not going for surgery, but that will be the optimum time to get up. Counseling which matters. See, after
There is
every
enough-
step. Yeah. Yes, boss.
That is, in other words, you want to improve the trajectory or your irrigation pathway post-op. That is also one of the aims.
Yes. So you have to widen the ostia for the irrigation to enter into. Now see, this is the primary picture after luminal working, and see, because of the polyp, there is lots of, abnormal, appearance. See the turbinate, which is here, which is quite, compressed. That is the bulla, which is looking like, hypertrophic. See the turbinates were arising from that. And that looks like the uncinate. The uncinate is the only mobile structure in the lateral nasal wall. See this. If I see, that is going to be my first step. And after massive polyposis, it is not uncommon to see uncinate distorted. See this. The first prominence in the lateral nasal wall, this belongs to the nasolacrimal system. After that is going to be the uncinate process. See the horizontal part of the uncinate there inside. See this? That is the uncinate which is distorted. And this behind uncinate is going to be the hiatus semilunaris, wherein the infundibulum opens. So let me clear a little bit to give you a better picture. See that?
Yeah.
All because of the polyp, everything distorted. So now
Yeah.
I will take a reverse biting here to remove the remnant of this uncinate. See this? I can use sickle also, but reverse biting I feel is more safer. You have to be careful not to damage the nasolacrimal duct while biting through reverse. And this is how I am widening my infundibulum and this ostium to make the middle meatal antrostomy. See this. This is the lower part of the uncinate. I am removing, and that's the middle meatal antrostomy. Can you see?
Yes, very clear.
See, the concept still stands very true what Stamberger and Messerschmitt propagated. For inflammatory disease of the paranasal sinuses, you don't need to do too much inside the sinuses. You just establish the ventilation and drainage and expect the sinus mucosa to revert back. Unless you have a fungal disease or anything, looks irreversible to remove. You don't need to do anything. So that was the initial uncinectomy. And see now what I am reaching. I am reaching this is middle meatal antrostomy. I hope it is very clear.
Yeah.
Now the next step is going to be removal of the upper part of the uncinate, which is a very key step in the beginning. This is one step which will take you to your lateral limit of the entire sinonasal corridor. Entire sinus surgery corridor, it will take you immediately to the lateral limit, that is orbit, that is lamina papyracea. So what I will do, it is distorted still. Here is the upper part of the uncinate. I can see this, I can fracture it. Can you see? Go
Yes,
behind,
clear. Very
go behind and fracture. And if I debride, I can use my through biting as well. I can use my shaver as well for the fine septation. See this. That's the remnant. And that takes me to the lateral limit of the entire corridor in a moment. Can you see this bone?
yes,
Yeah.
yes, clear.
Lamina papyracea.
Yes.
See this thin bone, this flat bone is lamina papyracea. So that gives you, orient you with your lateral limit so you don't cross it and give orbital complications. Now see what I'm doing. Staying medial to it. Staying medial to it, going behind this sand, fracturing this entire thing out. This is a very, very safe movement. Safe in the sense you are away from the critical structures behind. And you can remove all this to orient better yourself. See that? 0 degrees so far. I told you during CT scan the importance of the beak. Okay?
Yeah.
Bulla, the importance of the bulla has been very well emphasized by Professor Sethi long back. Keeping the bulla intact if you do the frontal sinus work, the bulla, which in the majority, almost 98% of the time goes up to insert on the skull base, protects your anterior frontal artery behind. So keeping the bulla intact is a safeguard to your anterior frontal artery. That is amazing. I will show you. So here I am changing to 70 degree for the regions. The region being, wonder kar rahe? Next, Skippy. Microscope laga. So, see now with the 70 degree for the regions. Regions being the feet which are associated with the frontal sinus walk. Entry into the orbit, skull base entry, anterior frontal artery injury. All these are the fears which are there in surgeon's mind while doing the frontal sinus work, along with its location which requires an angle scope. So everything makes it difficult. So what I am doing here now, see with the 70 degree, one has to get used to with 70 degree to make your life comfortable to prevent complications. More. See now with the 70 degree. This is your middle metal electrostomy. You can see well. छोटे रखा पहले ऊपर जाओ छोटे. This is all the time after every step you can apply topical Merocel to improve your field. Topical adrenaline. This is very important. So we never inject. And you know, our field is as good as what you achieve after infiltration. Now, at this point of time, landmarks. Number one, this is your frontonasal process where this turbinate is attached anteriorly, and this turbinate goes behind to get attached to the lateral lamella at the junction of lateral and medial lamella of cribriform. This is your axilla. Can you see? Underneath the axilla, let me bring out the beak. Underneath the axilla, very clear. See, I am using the landmarks which are simplest. Axilla, one can easily identify any point of time. Yes or no?
Yes, yes.
Now see underneath the axilla. Underneath the axilla, this is the thick beak. This is the thickest of the bone in this region. That is beak. I had shown you on CT scan if you remember.
Yes, yes. Clear.
Now I am following the beak. Following the beak. In between my lateral and medial limit. See, my medial limit is turbinate. Why turbinate and medial limit? See my beak. Big bone?
Yes.
This is beak. This one.
Yes,
Why-
clearly visible.
Why medial limit? Keeping in view, chota Merocel. Let me show you. Very clear. As
Do
long
you
as
take
I
the help? Do
as
you
long
take the
as-
help of a extension, head extension at this time?
Pardon?
Extension of the head of the patient.
Not really. I am using 70 degree.
Okay.
So I am taking the help of this turbinate and keeping in my view with the 70 degree all the time. Why? As long as I don't cross the turbinate medially, I am not going to damage the skull base. I am keeping this lamina peperosa. See this lamina all the way?
Yes, very clear.
As long as I keep in mind and don't cross it laterally, I am not going to enter into the orbit accidentally and damage anything. And see the beak, this hardest bone. As long as I stay between these two limits and follow the beak, where the beak ends. See my beak is ending.
Yes.
See my beak is ending. And what is there?
Awesome. Sinus.
See the frontal sinus.
Yes.
See this beak. The divider is. This is my beak. See my axilla. I am following the axilla. This is beak. Where the beak ends, this is frontal. Can you see very clear or not?
Yes, very clear.
This is the simplest way to enter into the frontal sinus one can think of. irrespective of the cellularity, irrespective of the anatomical variation, if you follow the beak, because this beak, God has given us a great landmark forming the floor and the anterior wall of the frontal sinus. And the frontal sinus drains from behind. Where this floor ends, then the frontal sinus drains. This is what we picked up from radiology. So here, follow the beak, where the beak ends has to be frontal, nothing else in any given reverse. See this again. Wash. Wash. मेरे को दे. See this. That is your frontal sinus. See the frontal sinus very carefully. Can you see up the frontal sinus very clear?
Yes, yes, clear.
That is frontal sinus. Now I will widen it behind a little bit to make it, see this. What I am using now, underneath the beak. Underneath the beak, I am using my reverse blade. Under 70 degrees, it becomes a front facing blade.
Right.
And I am widening little behind to make the give me a Marocel for a while. Just show you that. Let me pack for a while and show you everything crystal clear in this region. See the frontal. Give me one.
Yeah, we can see that.
See the polyp in the frontal sinus. As I told you, yes, the frontal was full of, disease, complete whiteout. This is what we have observed here, and that is polyps only. See, I can further widen my limits of the frontal sinus. A lot of people trying to measure it, advising it, this should be this size, that size. It cannot be, it depends upon the anatomy of the individual patient. What you can all do maximum is to reach on limits. See, my anterior limit is beak. I cannot go beyond this. If I have to go beyond, I have to drill the beak, and that will be an extended procedure draft. And that is required in massive diseases, abnormal cells high up, and many other pathology, tumor, CSF leak, but not in a regular sinus disease. See the frontal sinus from is the sinus from inside. Okay?
Yes, yes, clear.
Keeping the mucosa everywhere intact. So this is just widening the frontal. Now widening, I have limits. See where I am widening? Laterally. Lateral limit is what? Lamina. I cannot go beyond. Medial limit is what? Turbinate. I cannot afford to go beyond. Anterior limit is what? Beak. I am not supposed to go beyond by drilling in regular situation. And posteriorly is the skull base behind. Ethmoidal. Behind is going to be the ethmoidal skull base. See this?
Right.
This is how you can see reverse. I can further widen behind and give you a wide opening. We'll show you in a minute's time. See that? Frontal sinus.
Yes, clear.
Yes, I will just place a marrow cell to improvise the field and then come back.
Can you show us the glow sign after the disease is clear?
Yes, we can. So earlier, when 70 degree was not in, frequent use, people would have doubt of frontal sinus and they would confirm by a glowing of the skull at the frontal region to confirm whether you are in frontal sinus or not. But that is the indirect sign. Even the frontal cell can glow. So now with the 70-degree, when you see right inside the depth of the sinus, this is of hardly any use. But since you have asked, I will show you. See the frontal up. Can you?
Yes, clear. Very clear. Absolutely clear.
There is a partition behind which is a cell. This is supraorbital cell. See that cell going up. Then there far behind is the vessel which is running at the skull base. Irrigation is the key. The brighter, 120. Still, if you find, it looks like some polypoidal mucosa, still you can, do something with your shaver. If it is a true polypoidal mucosa, see this? Within the
Yes.
frontal.
Yes, yes.
Though polyp is a more severe inflammatory spectrum. So, if possible, remove. See, this is supraorbital recess.
Orbiter.
This recess is going up laterally above the orbit. See this. Look. Going up and above the orbit. Can you see here?
Yes, yes, clear.
Yeah.
This is, let me show you better. And see the party wall between the supraorbital and the frontal. Let me show you.
Frontal.
This is supraorbital section is. See this? And this is the
Yes.
party wall. If you further want to widen this frontal sinus, if you want to further widen the frontal sinus opening, you can remove this party wall. See this party wall?
Yes.
60. You can remove this party wall to widen the frontal sinus further. Got my point? So it is not difficult. You can widen in. See this? I have destroyed the party wall. See, I am removing this party wall. Just for the sake of demonstration, how we can widen the frontal outflow better. See the frontal and the party wall?
Yes, yes, clear.
The frontal, the most anterior is the frontal, behind is the supraorbital. Okay?
Right.
Could you show the relation of anterior ethmoidal artery with these two spaces?
That's very right. At the right time, you have pointed out anterior ethmoidal artery is immediately caudal to the supraorbital cell. And that's a very important anatomy. Once you find the supraorbital cell, you can easily find the anterior ethmoidal artery. Let me show you.
Yeah.
The moment you find the supraorbital cell, anterior ethmoidal artery is immediately caudal to it. Give me wash. Back for a while. See, all this is irrigation, more and more irrigation. That is frontal sinus, that is supraorbital. Now, leaving this nanocell to show you where exactly I have seen the anterior ethmoidal artery, which is immediately caudal to supraorbital. Once you find the supraorbital cell, that's an amazing anatomy to look for anterior ethmoidal artery. If you have big supraorbital, the anterior ethmoidal artery is more caudally pushed.
Mm-hmm.
See this. This is your supraorbital cell. And this immediately caudal is your vessel. Can you see the vessel?
Yeah.
Yes, very clear.
Let me make it very clear. I will make it crystal clear for you. See this. See this. This is your supraorbital cell.
Yeah.
And this is your vessel.
Mhm.
This is the cell behind the vessel. I am making your vessel more and more prominent. This is your vessel. Can you see very clear?
Yeah.
See this again, all the three compartments. This is your frontal sinus. This is
Yeah.
supraorbital. This is anterethmoidal artery caudal to it. And this is the
Yeah.
part of the roof of the anterethmoid behind which, now see here, this is the ground lamella which is inserting on the skull base, just behind. This is ground lamella. So behind that is going to be the postethmoidal cell. See now the clearance at this region.
Yeah.
Make sure use the sharp instruments, shaver, through cut, whatever, to prevent mucosal peeling. That is very important.
Mhm.
Peeling of the mucosa should be avoided at all times. We are
Yeah.
not supposed to leave the bones bare. If you leave the bone bare, it is likely to invite granulation, crusting, infection, fibrosis, and then it is not going to serve the desired function what we want. That's why we call it functional endoscopic sinus surgery, and the entire
Sinus.
function is going to be served by the mucosa. Now see what we have achieved so far. This is middle meatal enterostomy.
Yeah.
This is your frontal sinusotomy, and this is your anterethmoidal roof work. Can you see very clear?
Yeah.
Frontal sinus, supraorbital cell, anterethmoid. See the anterethmoidal roof. All clear? And it
Yeah.
should be given, it should be widened to the level that, see now the mucosa there everywhere.
Yeah.
Mucosa everywhere. So the solution will reach there to the mucosa, topical steroid, and keep it patent. Okay?
Mhm.
Now, at this point now, I change to 0 degree now back. So we have done maxillary sinus work. We have done the frontal sinus work. We have done the anterethmoidal roof work. And see now, until now, this turbinate has been very floppy, thinned out because of the pressure of the polyps. So I have kept it intact until now as an orientation, for the sake of orientation. See this polyp, the turbinate?
Yeah.
Turbinate, this is very floppy. Having used this turbinate as a landmark, see my anterethmoidal skull base, very clear?
Yeah.
That is anterethmoidal artery just behind. Now this part of the turbinate, we'll take a look later on. This is the remnant of the bulla. See this? That's the remnant of the bulla I am going to take off. And since bulla hits on or attached to the lamina papyracea, see the lamina laterally. Be careful not to damage the lamina. That is the shelf of the bulla, the lowermost part. This is shelf. So this is with a 0 degree now.
No.
See now, we have only two groups of sinuses left now
Live in India.
to decide. One is the postethmoid,
Ah,
and the sphenoid, rest all is done.
Huh?
Sinus surgery, la, my
Okay.
student is I'm moderating from here.
Oh. Oh. क्या हो गया?
See this.
Mhm.
Now you have postithmoid state. Postithmoids and the sphenoid work is left. And my biggest fear is while working in the
Mhm.
postithmoids.
Samavali. Could be a- How are you? One. AC बंद
ऐसे नहीं चल रहा
और करो फिर
Very good sales on this side. For our workshop last week, he operated continuously for 8 hours here in Singapore. He was doing it in
Now we are going to enter into the postithmoid, and what you see is this the ground lamella. This terminate as a first part, turning here into second part is termed ground lamella. The anterior group of cells from the posterior. See now, this is your ground lamella. This is your ground lamella, and this is going right up to the skull base there. See, going right up to the skull base. So now
Yeah.
we'll make, this is our landmark, orbital floor, or the maxillary sinus roof. We call it as a maxillary line. Landmark.
Yeah.
At this maxillary line, here I am making an entry into the ground lamella to enter into the postithmoid. Here, I don't intend to do the postithmoid activity first. The reason being, I may be carried. इसलिए आवाज है बंद कर दिया. As we go in the postithmoid, behind has to be the sphenoid, but this is not always there. If one of the postithmoidal cell goes beyond the sphenoid, one can enter right onto the optic nerve, carried away to the optic nerve by mistake. So, the best is to prevent damage to the optic nerve carotid artery. The safest, whether there is ONOD or not, the moment you open the postithmoid, go medially. See this. I am taking a medial trajectory. This is my superior turbinate now. Superior turbinate, see? Removing the lower 1/3 of the superior turbinate. Lower 1/3 you can remove without any fear of giving any olfactory mucosal damage or anything. I have not completed my postithmoidectomy. The reason being, if I go on doing postithmoidectomy like this, I may enter accidentally into the sphenoid. And I have no landmark to prevent that accidental entry. So here, I am developing a landmark before doing a postithmoidectomy. Go medially, see the superior turbinate which has been trimmed a little bit. This medially is the nasal septum. This is superior turbinate, this is nasal septum.
Yeah.
So now, in between is the sphenoethmoidal recess, which I want to see. And छोटा दे दे मेरे बाप 15 मिनट से दे रहा हूँ कह रहा हूँ. Every point of time use marrow cell. Now see, what I am trying to develop as a landmark. See, this is my turbinate, superior turbinate. This one. This is the septum.
Yeah.
Go along the septum. Go along the septum, not above the level of the maxillary line. See the maxillary line.
Yeah.
And look for the sphenoid ostium. If you see the sphenoid ostium, I can see the glimpse of it.
Yeah.
See, this is maxillary line. You are not supposed to go above the level of the maxillary line to look for the sphenoid sinus. I am in the
Medial to
sphenoid
the
sinus.
superior tongue.
Yeah, I am in the sphenoid sinus, sir. See the wide opening of the sphenoid here.
Yeah.
Now I can come retrograde and carry out the post-sphenoidectomy. See, this is sphenoid sinus. Come retrograde.
Yeah.
For that, staying anterior to the sphenoid sinus ostium, you can carry out the post-sphenoidectomy very, very safe. Optic now, carotid artery, whatever, cannot come anterior to the sphenoid sinus ostium level. This is sphenoid sinus ostium level. Come retrograde and finish off. You can finish off this post-sphenoidal walk where the orbit is going to be your lateral limit, posterior limit, keeping this sphenoid sinus ostium. I am not going behind this. Whatever the ONOD or optic nerve configuration, maybe it cannot come anterior to the sphenoid sinus ostium. Not going behind. See, if I go behind this level, I can go and damage the optic nerve easily. Anybody. And it has happened several times in the literature we have seen. So we have to be very careful in carrying out the post-sphenoidal walk. Out of the entire sinuses, the post-sphenoidectomy involves the major complication, fatal complication, disaster by means of accidental damage to the optic nerve carotid artery if you are not oriented. And while doing post-sphenoidectomy, if you are carried away into the sphenoid sinus and go on and damage the optic nerve once you disorient. So, see my ostium? Staying anterior to ostium. I am doing everything anterior to staying anterior to it. See this entire post-sphenoidectomy you can do without any fear. This is skull base. That is anterior sphenoidal artery. See the post-sphenoidal skull base. Everything. Now, this is sphenoid sinus. Now I'll widen the sphenoidal wall. See this? See now, widening the sphenoidal wall. You can use punch, sharp, Stemberger punch, drill, whatever to remove this septation. See now, that uncovers my optic nerve. Can you see the opticocarotid recess?
Yeah.
See, this is opticocarotid recess. Had I not taken the advantage of the sphenoid sinus and stayed anterior to it, it would have damaged. It could have damaged. I could have carried away inside the sphenoid sinus and damaged the intrasphenoidal structure, where optic nerve and carotid are the key structures. See now the entire sinus field now. Entire sinus labyrinth now. Having opened this, I will show you the panoramic picture. Wash. See, that is the post-sphenoidal skull base. Entire skull base with mucosa intact. Can you see?
Yeah.
That is all sphenoid sinus, intrasphenoidal structures. Can you see very clear?
Yeah.
And this is what we have achieved. This is full house test. See the frontal sinus up. Frontal
Site
sinus.
of posterior ethmoidal. Could you
Pardon?
demarcate the site of posterior ethmoidal artery?
Site of post-sphenoidal artery, your question is valid. But the reason is post-sphenoidal artery passes through the post-sphenoidal skull base. Anterethmoidal
Which
artery passes through the anterethmoidal skull base. Since anterethmoidal skull base is thin, the artery passing through the thickness of the skull base is visible as a prominence. But since the post-sphenoidal skull base is almost always thicker as compared to the anterethmoidal skull base, we generally don't see as the artery passing through the thickness of the skull base doesn't appear prominent. But yes, sometimes if the post-sphenoidal skull base is eroded, you can find it prominent. As far as the landmarks are concerned, The best landmark is use a landmark which is
Partition.
easily available, and see here the landmark which is easily available to guess the course of the postthyroidal artery is optic nerve.
Junction.
Now, optic nerve is almost always easily available. This is optic nerve.
Yeah.
Postthyroidal artery courses the postthyroidal skull base 5 to 6 millimeter anterior. That's it. That's that. Here is. This is optic now, and the postthyroidal artery is 5 to 6 millimeter anterior. The likely position of it, not very prominent in this case, because the skull base is
Extending below.
yes, the skull base is thicker. So this is the final picture. I'll just leave a tag for a while. Now, lastly, this turbinate is floppy. This turbinate is not good. We use the turbinate as a took the advantage of turbinate to orient ourselves. Now I am giving a partial resection for two regions. See the polyps medial to it. Can you see?
Yeah.
We do a planned partial resection if you have a polyps going medial to the middle turbinate to open up this olfactory recess. Open up this olfactory cleft for the topicals to go. This is very, very important. This treats not only floppy turbinates, but opens an uninterrupted pathway for the topicals to reach inside the olfactory cleft. See this?
Yeah.
This is after taking the advantage of the turbinate as a landmark. This is partial resection. That's the final picture. Let me give it a wash for a while.
Olfactory cleft as well as sphenoethmoidal recess.
Pardon?
You cut the middle turbinate, sagittal part, so that you have irrigation or sprays to reach your sphenoethmoidal recess as well as olfactory cleft where you have a recurrence.
Everywhere.
Likely.
See the skull base now. Our goal is to preserve the mucosa everywhere. See this? Preserve mucosa everywhere.
Yeah.
We are not supposed to remove the mucosa. See now, even in my office OPD, I can see with 0 degree all sinuses, and you can train your patient. This will allow your topical solution to reach all sinuses very effectively. Uninterrupted. So in surgery, you have to ensure that post-operatively your douching reaches the frontal recess. See this olfactory cleft very freely. See this? This
Yeah,
is full
wonderful.
of space.
Yeah.
This is full of space, allowing all topicals to reach freely to the desired area. Can you see now?
Yeah.
The frontal is up there. We have seen with the 70. You can see even the glimpse of it with the 0 degree. See that?
Yeah.
The supraorbital recess, anterethmoidal artery, all anterethmoidal, postethmoidal skull base, and then finally, the entire ethmoidal labyrinth. And see with the 0 degree, you can watch, you can see all sinuses exposed, all sinuses are exposed to the douching solution reaching freely there. This is what you have to ensure intraoperatively. See
By
the
the way,
final.
the inferior. Yeah, yeah. Carry on.
Pardon?
Carry on, sir. I was just asking, you had outfractured the inferior turbinate?
Not
In this
really. This
patient?
was not needed in this case. Yes. In case, yes, you can. There are a lot of procedures we carry out on inferior turbinate. Outfracture, sometimes cauterization, submucosal cauterization. sometimes partial resection, sometimes lateral wall lateralization.
So when do you plan what is to be done? When do you want to intervene for the inferior turbinate in these cases?
Yes. So if there is a boggy turbinate where the sinusoids have become boggy, not
Yeah.
bony hypertrophic, then we add on posterior nasal neurectomy and you can do a submucosal diathermy for the boggy ones. If it is bony hypertrophic, then you have two options, either to do a sharp partial resection leaving minimal millimetric raw area, or you can coagulate the pariform aperture and lateral wall laterally. That's an amazing procedure wherein we mobilize the turbinate and the part of the pariform aperture and the lateral wall laterally to open up more space.
Head
So
of the
those
inferior
are,
turbinate.
yeah. So according to the need, we have to choose the procedure. So this is the final picture. Wash. You can see everywhere, and this is how a douching solution will reach everywhere. This is how you can monitor your patients, progress in your outpatient department as well. Okay.
So Satish, can you show the posterior nasal neurectomy? Which region would you identify the nerves?
Okay, that's important question, Ashish.
Yeah.
Posterior nasal nerve need to understand the course and see. Having understood this course, you don't actually need to identify the nerves.
Yes.
These nerves, see what median nerve carries the postganglionic fibers. They are relayed in the pterygopalatine ganglion. Median nerve carries postganglionic fibers to the lacrimal as well, which go to the zygomaticotemporal nerve to the lacrimal gland. So earlier people would do the median neurectomy and unnecessarily sacrifice the lacrimal fibers. Nowadays, these nasal and palatine gland fibers, nasal postganglionic fibers to the nasal gland, are relayed in the pterygopalatine ganglion, and then the posterior nasal nerve emerges from the ganglion towards the nasal cavity. So the location of the posterior nasal nerve is here. Can you see the level of the pterygopalatine fossa behind?
Yes.
Yeah.
So they come out of the pterygopalatine fossa through this perpendicular plate of the palatine bone and through the sphenopalatine foramen, and come in this mucosa. Okay? The fine nerve fibers in this mucosa. And then they go to the inferior turbinate down. So what you can simply do is, rather than identifying anything, give me the coagulator. Just coagulate this mucosa. See this? Between the middle and the inferior turbinate, which is the part of posterior nasal nerves. If I coagulate this 1 square centimeter mucosa, my posterior nasal nerve becomes automatically non-functional. Okay? Hello?
Yeah, I can see and hear. Yes, lovely.
Now, rather than elevating those nerves, let me show you some of the fibers. See this. You don't need to do practically. See, this is perpendicular plate of the palatine bone.
Yes. Yeah.
See the fibers.
Yeah.
Section periosteum. Small nerve fibers which are coming in this mucoperiosteum. So you don't need to elevate and damage them, just coagulate this region. Just to show you. I'm just showing you for this.
So if you coagulate the mucosa up to the bone depth, it is fine.
No. Just see the fibers are going to come in the mucosa.
Satish, your audio is a little bit jerky today. So I think tell the audio guys to get your audio very.
Fibers are going to come in the mucosa. This section See this. So you don't need to go bone deep. You have to coagulate this mucosa.
Okay.
See, there are so many fibers coming out.
Okay.
Small fibers. Small fiber. The moment you elevate, you sever the fibers, basically.
Okay.
What I will do, what I'll simply do, see this one square centimeter mucosa.
Hmm.
See this?
That's it.
That is posterior nasal neurectomy. That's it. Because fibers are going to pass to the inferior turbinate through this mucosa only.
Okay.
Great.
Once you ablate, all fibers destroyed. See that?
Yeah.
You don't
Yeah.
need to look for the fibers.
Okay.
I showed you the territory where the fibers come from.
Beautiful. Thank you so much. Yeah.
So that's the final picture. On this side, this is about the full house face. Now this gives you opportunity for the topical steroids to penetrate in the depth of the sinuses now. The area, the mucosa which requires actually the steroid. Earlier, in the unoperated situation, the only steroids which were safe to use were the topical, which were in the form of nasal sprays. And nasal sprays do not cross beyond anterior 1/3 of the nasal cavity. So, if the disease profile is too less to be controlled by nasal spray, you don't need surgery. But if disease profile is too massive, wherein the steroid is needed in the depth of the sinus mucosa, you need actually sinus surgery to give this ability for the steroid to penetrate. I hope it is very clear.
Very, very clear.
Yeah.
And that is the indication of sinus surgery. So, sinus surgery indication when the appropriate medical therapy fails. An appropriate medical therapy is just topical steroid. Nasal sprays. In unoperated situation, you are only left with a choice of nasal sprays, nothing else. So, when the nasal sprays fails, you have to operate for the steroid to penetrate deep into the sinuses. So, when you have higher inflammatory spectrum, you have to do a sinus surgery. The main goal is to enable the topical steroids reaching to the destination, that is mucosa inside the sinuses.
Yeah.
So, our next case is going to be the stapes one. Before we move on, any questions? The other side I am not demonstrating. See. Huh? What?
Yes.
Adu?
Audience, delegates, any questions, any comments? I think everybody is satisfied. Post op? Yes, there is a question from, can you identify yourself? Dr. Hitesh from? Dr. Hitesh is asking post-op role of immunotherapy in such cases.
Pardon? Yes.
Post-operative
Immunotherapy.
role of immunotherapy.
See, immunotherapy is directed to change the natural course of allergic reaction, allergic rhinitis. Immunotherapy has no role in the management of CRS. Immunotherapy can treat allergy, and that's the only treatment which can change the natural course of allergic reaction. Antihistamines are just symptomatic treatment. Immunotherapy can change the natural. So those patients who have associated allergic rhinitis can undergo allergic testing and immunotherapy later on. So just to treat the comorbidity of allergy, nothing else. Now, before moving on to the next case, is Dr. Sethi there online? He asked me to show the features of the DICOM.
Yes, Satish, I'm here.
So, boss,
Actually, I know the features, but I think you need to explain that to the participants.
Okay, let me show you.
Because I think it's very useful.
Yeah, the features of the DICOM I'll show you. Hello?
Yes.
Yes, just a moment. Features of the DICOM I can show you in a moment.
नीचे जाके बात कर पहले अगर बड़े स्क्रीन पे भी देखें.
See this particular patient. Yes, are you getting the scan on the screen?
Yes.
Yes,
This
yes, we
particular
have that.
patient is a patient of JNA, which I am going to show as a second case today.
Ah,
See the massive JNA. This is CT angiogram. Oi, charge पे लगाओ ना.
बस इनके पास इतनी बुरी तरह से
तुम्हें बैठ के देखना है. ये showing the features of
एक ये और एक दो और है के
अपना बैटरी लो है क्या उनका बैटरी?
charge पे लगाओ. इधर.
हाँ उनका है. Showing CT asking to show us pictures of the diagram.
You'll be around? Yeah. You can see one case, one I see one after. What?
Yeah, उसका बैटरी. I think his batteries run off.
Yes, Ashish, just a minute. Starting. So, I will show you how DICOM can be so useful in giving n number of informations, which can be so surgically relevant. So surgically relevant. Yeah. Are you getting the CT angiogram on screen? Are you getting the MRI on screen? Hello? 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 Am I audible? Hello? 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 Please unmute.
Satish, we can hear you.
Yeah, Ashish, am I audible?
Yes, very nice. Yeah.
Are you getting the scan on the screen?
Yes, we are. We are.
So briefly, I'll tell you what DICOM is.
Yeah.
First of all, you
Hello?
can
Hello?
multiple sequences together. Like, see, I can open 4, 6, 9, 10, see like 4 windows. This is the contrast scan. See this?
Yes.
At the same time, I can run this T2 weighted as well, fat suppress. At the same time, I can run axial here to correspond to the coronal. See this? The bar is where this is the axial level and this is the level on the coronal.
Yes.
Same thing, I can correspond all with the sagittal.
Yeah.
So I can run multiple n number of 4, 8, 16, whatever. Suppose this is the axial. Now, if I want to see the diffusion together, diffusion gives you a good idea whether it is benign or malignant. See this. There is bright on diffusion, no restriction.
Yes.
That means it is benign. It has fluid content. See this? This is, had this been malignant, it would have been dark.
Yeah. Macros.
So you can see all sequences together. So this is regarding Windows. This is regarding, variety of patient data you want to see. Or if you don't want to see, like this data, you can see the name, age, all. I can hide the patient data. See this? I can remove.
Okay.
Sometimes you don't want to show in your presentation the patient name and all that. You
I
don't
think
want-
that is the most important tool because for patient confidentiality,
Yes.
especially when you are, showing it on the internet and all, I think that's a very important tool.
See now, all annotations have gone. You don't know where this scan was done. No center
Correct.
name, no date, nothing.
Nothing. Yeah.
You don't want to disclose. Okay?
Yeah.
Then this is very important. See, sometimes this is the picture and you really want to, change the position from here to there. Sometimes it is going in one corner, you can put this through this. Then this is very important. This is not important in head and neck, but in abdomen, brain. This is windows. If you put a lung CT scan, they will show, it will ask lung window, abdominal window, brain window, whatever. This will ask. This is not for us. Now, this is very important to enlarge. How much you want to enlarge a particular zoom in, zoom out. See this? A particular canal you want to enlarge, you can enlarge like this. Okay, some particular area if you want to see enlarged. Then this is very important, the length. This is so important. Let me give you in this particular patient. This is your, this is your maxillary artery in this. See this maxillary artery here? See this. This is JNA. And see, this is your maxillary artery. This is your maxillary artery entering into the tumor here. Can you see my arrow? Can you follow my arrow?
Yes, we can see.
Yeah, see the maxillary artery behind the posterior wall. Can you see very clear?
Very clear.
While catching the maxillary artery, clipping the maxillary artery, you don't know with tumor how much where it is displaced. Once you open the posterior wall periosteum behind the maxilla, you have to look for the artery. This CT angiogram can tell you where exactly the vessel is. See now, if I take the reference of the floor of the nose, length, see this? From here, I can get to know this is 2 centimeters above the floor.
Right.
Here it is. See this? Here it is. Laterally it is 2.8 centimeter. So you can have a full 3-dimensional, distances you can measure. Distances in millimeters. Distances you can measure. See how is the depth of the olfactory fossa? You can measure. 6 millimeter. Anywhere you can measure the depth, length, breadth, whatever. So this is for the length or polygons, whatever angle. If you want to make an angle, what is the angle between cribriform and the nasal septum? Angle to the orbital nasal septum, you can all make angles, whatever if you want to. So sometimes you want to write anything with a pencil, cursor, you can write over the scan as well. If you want to denominate something, you can do with this. Then you can rotate your picture by any angle. If you want to rotate for your presentation, for anything, you want to write anything on it, you can do this. Then if you want to run the video of anything, suppose you want to send something to somebody else showing the CT scan, coronal CT scan, you can take the video through this your mobile and send. If you want to send me for your reference that what it can be, just shot with your mobile this video. You can slow and, slow down the video or you can fasten the video like this. This is very fast now. See, so fast. You can slow down. You can slow down. You can slow down. Like this. In all planes, you can shoot the video, axial, coronal, sagittal. Then this is multi-planar reconstruction. Axial, if you want to see sagittal, I can see sagittal. If you want to see axial, I can see axial. If you want to see 3D, you can see 3D. See 3D. For any reference, you can go from here to there. This is amazing. Then 3D skeletal reconstruction. See this 3D skeletal reconstruction. This is very important. Sometimes, once you have a tumor which is open, see this tumor is here. Had this been open tumor somewhere on the skull, you would find where the tumor is going, how much the bone is involved, how it is adhered to the outside bone anywhere. Then there are options to cut this bone and see inside. There are options. So this is 3D reconstruction. You can take snapshots. You can export to the email directly. Directly export to anybody. You can email the entire data. See, you can take the bone and skin only. You can take this is for the airway. Sometime you do a CT scan chest, you can convert into virtual bronchoscopy. Means it will show you the entire bronchoscopy like you do. Like you're passing through the vocal cord down in the trachea, then bronchi everywhere, like endoscopy exactly. That is virtual bronchoscopy. You can do through this. Then for the vessels is the angio. Angio categories for the vessels. So there are many things. If you go in detail, there are many more options. But these are clinically useful options you can see on DICOM. Okay? Hello?
Yeah.
Thank you,
Thank
Satish.
you.
Very
nice.
informative.
nice.
Very informative.
See this sinus. See this. You can rotate and see inside the skull as well. How is the anatomy of the skull of that particular patient? You can rotate anywhere. The same patient which we have operated just now. It can give you very useful information for the anatomy. 3D everywhere. See, this is your superior orbital fissures. This is your clinoid process. This is your cribiform plate on either side. This is crista gela. This is your orbital roof on either side. This gives us amazing information, Orbits.
Jason, right?
The more you explore this, more you'll get information. As simple as that. This is vast. There are so many other options even I have not explored which are gone beyond our clinical needs. But yes, I know there are so many options in this. Anyway, coming to the next case. Next case is a patient who is a case of autosclerosis, proven autosclerosis, as the other year has been operated earlier. And this is for the other side. And this patient, so it's a proven case. I'm not going in details of the scans for the autosclerosis because of the time constraints. Iski CD kahan hai? We'll show in brief. CD. So if you want, I can throw some light. But in autosclerosis, you don't need scan for the diagnosis. You need basically scans for the anatomical details to rule out any anatomical abnormality which can complicate our surgical course. Like if there is facial, prolapse, if there is some other fixation of the incus or anteromellular process or the head of the malleus, which is giving you a false diagnosis of otosclerosis, and then if you are not aware of it, then you have to cut a sorry figure. Any other possibility of persistent stapedial artery, any other abnormality, any cochlear otosclerosis, any other obliterative otosclerosis. So it rules out other problems which can complicate your surgery. Any abnormal communication of the inner ear with the subarachnoid space.
Allergies maybe, just a bit of swelling here and there, nothing very much complicated. Well, as an operation for you know.
So it warns you of anatomical abnormalities. So the CT scan is good to have. That's what I can say rather than cutting a sorry figure. Otherwise, what happens? If the patient has an obliterative otosclerosis, I'll be prepared accordingly to deal with that. I have to counsel accordingly because the results in obliterative may not be as good as a blue foot plate. I will encounter more problems, and accordingly you can discuss with the patient, take the final call, or give the option of hearing aid or anything else. Any facial overhanging prolapse, if you see on CT scan, again you can discuss with the patient beforehand, so that you can go ahead with the surgery or wear a hearing aid or take a trial with the consent of giving a, any kind of, weakness in the facial nerve possible, all that things. So our case is ready. If you want me to run the DICOM, I can. Yeah, that is the DICOM series of this patient. Opening. See, another advantage of getting CT scan done in CSOM patients also, you can pick up any associated, significant sinonasal disease existing. This is very, very important. You are getting HRCT temporal bone done. At the same time, you get the, details of the paranasal sinuses as well. Many a time, long-standing ear disease is because of long-standing nasal disease. And if nasal problem remains untreated, you can't expect the good results in long run with whatever treatment you give to the ear. So this is important to pick up and warn your patient for the need of nasal pathology, nasal treatment. Now see, what you need to see on the left side we are operating. See, this is malleus incus, this is suprastructure. Stapes suprastructure. This is malleus incus stapes suprastructure. Now, any abnormal communication with the inner ear you can pick up, which can give a gusher or anything. Here you can see the cochlear aperture, very good. Intra-auditory canal is very good. Any anterior malleolar ligament fixation to the anterior wall you can pick up in the axial section. Then ossicular chain completely. Then on the coronal section, see this. You can see any abnormal fixation of the head of the malleus in the attic, any bony fixation. See this malleus incus stapes going here in the oval window. See this. This is stapes suprastructure going in the oval window. And see, this is facial nerve above. If there is facial prolapse, the facial nerve would come below over the oval window. This you can predict very well on CT scan. This is a very important finding. So it warns you of any abnormal anatomy which can complicate your course. That's it. This is surgery, one surgery in otology, which is most demanding and result oriented as well, where you can give hearing results on table. At the same time, it is sometimes, proved to be a all or none kind of a surgery. Can give dead ear also, with a patient coming with a conductive hearing loss, going back with a dead ear. because you deal with a structure which is few milligrams in weight, and you have to deal with that by means of fenestration, and you open the inner ear, and there is always a possibility of giving SNHL if we are not very, very, diligent. So here, a CT scan can help you further by means of picking up any, anatomy which can complicate your course further, and you can accordingly counsel your patient beforehand. So it is always useful to have it, I would say. Do we go ahead with the surgical part?
Yes, please carry on.
Okay. So after this, the next case is going to be a subtotal petrosectomy and cochlear implantation, same stage, for a patient having bilateral profound sensorineural hearing loss and cholesteatoma. So this case is ready, and soon we are starting this with a get back to you with a microscopic picture.
Right. Can you show the audiogram?
Hello?
Hello. Can you show us the audiogram?
Of this patient?
Hello. Yes, this patient.
Hello?
Hello. Are you getting the sound? Hello.
वो खुलवा दे दूसरा, उसको बोलना मेरे को बता के जाए फाइंडिंग.
Hello. Am I audible?
आप रुक जाना, उसके बाद बोल दो. हेलो.
Hello, Satish.
Yes, boss.
Yes. He knows that. Can you show us the audiogram?
Yeah, I watched the boss. Once I watch out, I'll show you. The patient has a moderate conductive hearing loss.
Okay, no sensorineural element.
No sensorineural hearing loss.
That's good.
And I'm operating on the left side.
Right. What's the age of the patient?
Age is around 40.
Okay.
He himself is a doctor. He's a psychiatrist.
Okay.
I have operated upon his other ear earlier.
When was that? How many years ago?
Yeah. Almost a year now, probably.
Right.
Hi Satish, this is Dr. Raman.
Yes, boss. How are you?
How are you? बहुत बढ़िया.
कुछ जम्मू में कॉन्फ्रेंस हो रही है, बॉस नहीं है.
नहीं मैं आज आ गया आपको मिलने. अच्छा, I was just wanted to ask, what is the minimum period that you wait for the second year? 1 year or more?
Boss, it all depends. There is nothing hard and fast. Yes, theoretically people call it should be 1 year for the middle year to stabilize and all that, but we have done even earlier. So it depends upon the previous surgery, how uneventful it was. See, the findings on both sides correlate very strongly. If you have a one side complicated issue like foot plate, any abnormal anatomy, you're likely to get on the opposite side as well, most likely. So if one side uneventful with no SNHL, nothing, you can do even early.
Okay.
3 months. I wait 3 months for an uneventful.
It depends. Everybody has its own protocol.
Yeah.
ये दूसरा दे, वो सफेद वाला लेके. इतने साल हो गए कराते यार, तुरंत रहेगा तू. सही ना. So Ashish, yours is 3 months?
Yes, if the other side is uneventful, then after 3 months, I am okay to do the other side.
We follow the standard teaching that is there in PGI for 1 year wait, actually. In any case, in either case.
Yeah, so there is different, centers follow different protocols.
Amar, it may be a good idea for you to start following them every 3 months, and then that way you can come to an algorithm that what happened at the end of 3 months, did that change at all over the next 9 months or 12 months?
तुरंत को सारी जिंदगी हो गई इस टीवी यार अक्ल नहीं. Yeah, I'm waiting for my speculum, boss. Just a minute. बड़ा देना.
You use the slotted speculum or normal?
सारी जिंदगी हो गई कराते यार. पता ही रहेगा ना. Hello?
You use the slotted speculum or normal speculum?
Normal speculum, boss, most often. Yes, this is better.
There is
Yes,
an anterior
yeah.
canal hump or what?
Yeah. Can you see the exotic canal now better?
Yeah.
Very nicely, yeah.
Yes. Ketamine. जो करना कर. वो खड़ी कर. I hope the picture is good.
Yeah, yeah.
Very good.
One incision, a lot of people make incisions differently. The goal is same to expose the posterior superior area, the key area. Here, our goal is same. My incision is a simple horizontal one. See, this is the level of the annulus, and that's the lateral end of the Bodhi canal. So I make my incision limiting couple of millimeters above the annulus. So I want to raise a flap which is, I would say, 5 to 6 millimeter in length. Curvilinear incision in the canal. Okay. Just a minute. ऐसा काम पहले किया करो यार उनको. तुम लोगों का. Just a minute. करो.
नहीं.
बड़ा कहाँ है? Yeah, just a moment. Yeah. Look. Hello? Yeah.
Yeah, yeah.
All set now. So this is a horizontal incision. This simple horizontal incision which is little curvilinear anterior. The reason being, anteriorly I don't my incision, I may have to extend it further. For the regions, if there is any other fixation, mallear fixation, anteromalleolar ligament, of anything, I need to go anteriorly, I should have an option. Inferiorly is not our area of interest. So what I can do for my sake of my ease, I can limit my incision inferiorly to prevent flap getting unnecessarily torn. See this?
Yep.
And quickly you can raise and go up to the level of the annulus. So inferior is just a release incision, you can say. Superior area is very important area, key area. See, superiorly, I have not given any release incision, any limiting incision. It's unlimited. I can go far anteriorly wherever I want to. Now, reach the level of the annulus. And, you know, I hope the picture is good.
Absolutely.
Now, see the level of the annulus. This is the reflecting middle ear mucosa. I can see the glimpse of the chorda underneath. This is opening the middle ear mucosa. You can see very well.
Yeah. APDS is also visible.
Yeah, see the long process of the incus, incudostapedial joint. Quickly, circular. And I can further, chota wala, elevate this inferior, flap to keep the flap anteriorly placed so that it doesn't bother us. See this? This is not going to bother us anytime during surgery now. Overhang. There are many ways to remove this overhang. I have seen our friends Ashim Desai and Ashish Bhumkar using a micro gauze and fracture this part of the bone in one stroke, one piece, and remove this. I can use a micro drill as well, or here I am using simply my curate, whatever. The goal is to improve the exposure, and the idea behind this exposure is the limit is, by and large, this is required to manipulate your piston and instrument at the level of the foot plate. You should be able to see the foot plate thoroughly. Chisel hammer, micro chisel. Okay. Yes. Ashish?
Yeah, watching.
Your instrument.
Yes.
Sometimes I'm scared with my assistant not to tap it hard.
But yeah,
You tap yourself or your assistant? Who's
no, I
trained
do
to?
it myself. My
Oh.
assistant is holding the speculum,
De mere ko de.
and there is no suction in my hand. So what we also do is first make a little crack at the bone near the chorda, so that that doesn't get entangled, and then go for the overhang.
Yes. So I'm just showing for the sake of something
Demonstration,
different.
Yeah. This is a much thicker bone, huh?
Yes. So I can do simply with my give me the drill, boss.
Yes, Satish, more and more I have come to drilling it now.
Let Ashish show some other time his technique.
No, but even I have started drilling it more and more. Inspired by your nasal corridor for skull base, I started creating a stapes corridor here.
I can, remove with the curate also. I have a very sharp curate, thick curate from stores. And I can thin out with the drill as well. See this?
Yeah.
See this diamond?
Yes.
Find out. Correct. Yeah. See this?
Yeah. And when you start using the drill, this is where, you know, that inferior incision that you took to park the flap anteriorly, that becomes very important. So the flap does not float back into your surgical
I've
field.
seen you, Ashish, sometime taking the corda along with the flap.
Yes.
Is that always possible?
No, not always possible, but sometimes there are these mucosal bands between the undersurface of the tympanic membrane. So that sort of automatically retracts, and the mucosal bands, they keep the chorda nourished, so it doesn't become dry.
Yeah, that's a very good, thinking.
In this case also, the sinus tympani is not very deep and chorda is superior, quite superior actually. So it's much ease of.
See now what I have done? I
Yes.
thinned out this
Tuned it
region.
out. Yeah. Now the curate can take it out.
Curate. Just, I could have done with the curate, just wanted to show something different.
Lovely. You can see the fallopian now.
Yeah, see the fallopian canal?
Yeah.
My superior limit is, see the superior
The
limit
body
is
of the incus. Yeah.
until you see the body of the incus coming, or this long process starts broadening to the body. This is adequate superior limit. Can you see?
Yes, very nice.
Yep.
Posteriorly, yes, you should be able to see the entire foot plate. See this now? See this
Yes,
entire
yes.
foot plate?
Thoda sa, you need to magnify it.
Yeah, I will show you.
We can see the whole of it.
And you should be able to see the tendon thoroughly. The pyramid giving origin to the tendon. See the sickle. Oh, the man of the man. You know.
Beautiful. Yeah.
Now see, much better.
Yeah. A bit of a glare, but we are fine. Very nice. You can see the pyramidal process, the emergence of the stapedius, and
correct. See now this.
yeah.
This is chorda.
Yeah.
This is your pyramid. You can see the entire extent of the foot plate.
Yes, very nice. Yeah. This stroke also that it did from inferior to superior on the to separate the chorda from the incus is very good, because it doesn't strip the entire mucosa of the incus. Yeah.
See now? Now, at this point, let's check the mobility first quickly. My incus malleus is moving.
Yeah.
Now focusing on foot plate. See, focusing on foot plate. Can you see the blue foot plate?
Yes, very nice.
Yeah, yeah.
And it is well fixed. See this? Those now, at this point of time, there are two most crucial steps in stapes surgery, which prompts us to think of some tools to prevent those mechanical, accidental mechanical hazards. The one is during the corotomy, we don't want our stapes to be subluxated, fractured, or mobilized. Because a mechanical movement fracturing the crura may not be always so accurate, particularly if the foot plate is not adequately fixed. And
or if the crura is very strong. Yeah.
Yeah. And posterior crus is, always stout. So Ashish,
yeah,
once I am having laser, I have no fear.
Yes, of course. Yeah.
I can vaporize the posterior crus. But if not having laser, I did in Nagpur 3 cases this time, demonstration without laser. So I followed your technique of thinning the posterior crus.
Yes, drill and thin it. Yeah.
And the reverse stapenotomy. Reverse means thin the posterior crust, expose the whole window thoroughly, which is hidden otherwise underneath the posterior crust.
Yes.
And if you have adequate space, make the fenestra taking the advantage of the fixation of the entire stapedial arch, including
Correct.
stapedial arch, and fenestra, piston, and then finally disarticulate the IS joint and remove the piston.
Correct. Remove the suprastructure.
That is reverse.
Because now it is a fragile crura, so the mechanical crurotomy is very easy.
Yeah. If I have a laser, then I have no fear. I can carry out without mechanical mobilization. That is what I am going to show you here.
Most ideal, actually. Yeah.
For the audience, Dr. Ashish Bhumkar has KTP laser too. Oh, yes, KTP. So he uses KTP also.
So it's a fiber guided, so I can go to the anterior crest also, which the CO2 beam cannot.
Now,
Otherwise-
Ashish, even the CO2 laser has come fiber guided now.
Yes, yeah, but when I got it, the CO2 didn't have fiber. Yeah.
But I tell you, as far as the inner ear safety is concerned, the CO2 is safest because it is
Yes.
absorbed by the blood.
Agreed. So I only use the KTP for a thick mucosa on the foot plate. Otherwise, I don't use it on the foot plate. This disarticulation also, first puncture the capsule with the tip of the right angle, and now he has gone within.
First see where the capsule is, where the joint is. See now?
Yes, very nice.
Now, next steps, I can vaporize my laser. That's why I use this laser. Let me tell you, laser. So this is a CO2 laser. This is now my 16th year I've been using this.
16th year.
Yes, of this luminous. And the thousands of stapes surgery and made us so secure. Without laser, I feel so insecure that I will mobilize. So last month when I was operating in Nandu's workshop in Nagpur, without laser, I was so scared.
Yeah, I can imagine.
Mobilize, I may give a floater. And you know, the confidence level was shaking because I was so used to laser.
Yes, of course. Yeah.
So I use your technique of,
posterior crust.
Truss and reverse stepedotomy.
Yeah.
See now, there's a blue foot plate. Blue foot plate means a favorable situation where the foot plate is fixed to the surroundings
Yeah.
and the foot plate itself is not involved in the autosclerotic foci.
Sorry, ticket झाले तर please send करा.
जशनला विचारायला.
Message कर.
See now, my beam I will first use on tendon to see whether it is in alignment, whether everything is in order. See this? Karo. See tendon, I can cut this tendon easily. Karo, on karo. Hello?
Yeah, Satish, we can watch.
Here I will vaporize the tendon.
We're not seeing the red dot, but okay. Yeah.
Not seen?
No, see, we saw it. We saw it getting buzzed here.
कहाँ गया वो? लेट गया. हिल गया. हिल गया भाई, नहीं आ रहा. क्या करता है? Yes.
Now I can see it. Yeah.
See? In no time,
Yes.
my tendon is gone.
Gone. Yeah.
Now give me a gel form. See now, since I have laser, I vaporize my posterior crust. I will just cover the rest of the foot plate with the gel foam. See this?
Just to protect it or just for the heat?
Yeah, wet gel foam will prevent the scattered, beam if it is. From the surface of the, posterior crust, the beam may scatter.
Ah, okay, it will get bounced.
Yes. See now? यार चली गई.
So it's charred now. The edge of the crust is charred.
Yeah.
Charred.
Yeah. Yeah. See the posterior crust being vaporized. See the whole posterior crust beam. Can you see? See the posterior crust being vaporized.
Yeah.
Hollowed out. Could you see the posterior crust hollowed out?
Yeah.
Yeah, Satish, yeah.
And now, see, I can break this easily.
Yes.
Right angle then. क्या दिया है? See now, my anterior crust, we all know is fragile. You can fracture it easily. See this?
Yes. The pleurotomy is over, yeah.
And see the anterior crust so fragile coming out. It is the posterior crust which gives you problems being stout. See the suprastructure has come out.
Yes.
Now see at this step. Can you see the whole window region?
Very nicely. We can see now the inferior edge of the footplate also. The entire width is visible.
My site of fenestration for the oval window is in the center of the oval window in the inferior part, which is farthest from the
Secure.
farthest from the vestibular end organs. I hope the beam is very clearly seen now.
You're not going to do the length measurement?
I will do later.
Later. Okay.
See that the beam is very clearly seen?
Okay, yeah.
Not very clear or what?
It was not clear. But yeah, now we can trace it. Yeah, okay.
Yeah, glare बहुत जा रही है यार.
It is reflecting more on the speculum. Once you make the fenestra, we'll be able to see it better.
You should be able to see.
Now we can see. Now we can see. Nice. Yes. थोड़ा कॉर्नर पे जा रहा है हमारे इसमें से. Now.
See now very clear?
Now we can see. Yes, very nicely. Yeah. Very nice. Yes. Perfect. Perfect. Lovely. Fantastic.
See now, I will give a single shot 20 watts in the center part inferiorly. Make the finish.
This is 0.5, 0.6.
0.5, my 0.4 mm piston and 0.5 fenestra. And now see this fenestra very clear? Oh, there's the pic.
Yep.
Very clear or not?
Yes.
Finest. See, this is a discrete fenestra in the central part of the footplate.
Center in terms of the anterior posterior and in terms of superior inferior, bit inferior.
Inferior. See the fenestra?
Fantastic. Yeah.
Never ever suck on the fenestra.
Yeah. You can clearly see that there is a very,
That is
yes.
one thing which invites problems. So never ever suck on the fenestra. Now see, lastly, see very clear?
Very nice, Satish.
Now I will measure with my measuring gauge. Let me show you the measuring gauge, what exactly it is.
The telescopic, yeah.
See this?
This is,
This point comes in and out, and this
yeah.
I'll measure corresponding to the body of incus. Okay?
Yes. To the undersurface of the incus or the superior?
And this length will be shown here.
Yeah.
This length is shown here, the same company course 1, 2, 3, 4, 4.25, 4.5, 4.75, 5 like that. Let's check 4.5. Okay?
Yeah.
Ashish.
Yeah.
Beauty of titanium piston is I don't need to crimp.
Yeah, I know. You made things very easy for yourself. Laser and self-crimping.
Yeah, it is like a video game, I tell you.
Yeah. You use technology to take care of the biggest challenges.
4.25, boss.
4.25. Okay.
Yes.
So you keep the lower end of the thing on the footplate or at the edge of the.
Yeah, this 4.5 doesn't mean 4.5 millimeter. It's a measurement which includes 0.3 mm already going into the fenestra. This includes. This is not 4.3, 4.5 mm, 4.25. Got my point?
Yes, it is for the size of that piston.
Yes. So now, I'll show you how easy now is to place a piston.
So the messages you should have if you're using the Kurz pistons, get a Kurz measuring device.
Same measuring, same company, same manufacturer's measuring device. It should always be. किधर गया? अभी तो The beauty of this piston is the ease of placement. See this piston? Ashish.
Yes, I'm watching. And how that overhang removal sees, if it was less, it would have been a problem, but that adequate overhang removal is allowing him. He can also see the lower end of the piston. See, he can see the lower end going into the fenestra. He has parked it now very close to the long process. This, I think, precision is very important. You must see the lower end as it enters into the fenestra.
Lower end entering into it. See this?
Yes, very nice. You can see it is adequate. There is the width of the fenestra is nice.
See the lower end there?
Yes, very nice. Turning to right angle. Yes,
My
very
lower
nice.
right into the fenestra, you can see.
Yes.
There is a bar.
Yeah.
This is the open end of the clip which is taking on the incus. Now I will push on it and the middle slot on the piston will take the incus.
You can feel it snap. Yeah.
This is now tightly holding like a clip. There is no play between the piston and the incus without any crimping.
Yes.
See that?
दो जिस्म अगर एक जान है हम हो गए.
See the lower end inside.
Yes.
The middle slot is taking on the incus. No play between the incus and the piston at all. See this?
Yes.
It takes on so snugly. So snugly. See this?
Beautiful. Yeah.
I usually
Absolutely.
don't
Yes.
use anything but a drop of blood to seal the fenestra.
Yeah.
That's it.
You can just scratch the mucosa there. You
This
don't really.
piston, with this piston, there is no need of crimping at all.
Right.
Crimping is one step which I am really scared of. The crimping itself can dislocate the incudomedial joint if you are very hard on it. If you are not very adequate in crimping, the piston may be loose and there can be a play between the incus and the piston that leads to sound energies also. If with experience, people get used to, but this is something really, you know, a difficult job. Crimping is always difficult.
Is a piston which has evolved. So it's a new technology piston. Yeah.
Now, you can deposit your flap, the blood.
Okay, end of the story.
That's the end of the story. So what I will do now, lastly, I'll just pour a micro drop of blood onto the fenestra.
You can actually tease the mucosa there and the blood anyway goes there. You don't really need to take a venous blood. You can just tease the mucosa around the foot plate and that blood goes in rather than taking this venous blood. Yeah.
Yes, you can do that.
Yeah.
See now, this occupies the whole window. This has a fibrin, which acts as a
It's just a
sealant
blood
as
clot.
well.
Yeah.
Yes, this is very effective. As long as your piston is not overlong,
Correct.
this direct piston is never going to give any problem. Yes, in demanding patients, those patients who are more exposed to, pressure excursions, divers, frequent flyers, professional flyers, then you have to use additionally a vein graft to interpose between the piston and the, oval window. Otherwise, we don't use. See now, final picture.
Yeah, very nice.
Gel foam रख देना। हाँ, डाल दो। Gel foam रखो. So somebody will put the gel foam रख दो.
James Bond stepidotomy.
This is about the direct piston technique. So laser makes your life easy by means of preventing accidental mobilization, subluxation or fracture of the foot plate during chorotomy and fenestration. That is one thing you have to be, इसका audiogram देना. Very careful during this thing. See this audiogram. दिखाना external camera. This patient has a right 30 dB airborne gap on this side. Can audiogram focus करना? On the left side. Can you see this?
Yeah.
Yeah. Oh, lovely. Fantastic.
और zoom. अरे zoom करो यार.
You can see the right side. Perfect.
Right
closure.
side bone gap closure.
Yeah.
This patient had a more hearing loss on the right side, 5 dB more. That's why the right side was chosen first.
First, yeah. Fantastic. Lovely. Yeah.
So that was the ideal candidate for stepidotomy. Now, ready? Local लगा दिया? आएगा? ये तो करवा दे, मुझसे बोल दे.
Hello. Hello, sir.
Yes.
Sir, this is Dr. Abhay. I have few questions, sir. If you can answer those regarding the
Yes,
safeties.
please.
Sir, Sir, in the setups where the laser is not available,
Just a minute.
what is the next best thing you will advise?
Just a minute, boss. Volume बढ़ाओ. काट लेटो. हाँ बैठो तो यार. और उधर सामान लगा दिए लोकल लगा है ना मारो इसके जल्दी और पैक लोग रखना अनुभव लोकल लगा देना फटाफट थोड़ा पीछे तक है ना हेलो पैक लोग रखना मेरा दिया है हेलो
Yeah, sir. Dr. Abhay, this side, sir. I have few questions.
yes yes please
Am I audible, sir? Sir,
Yes,
in the
yes.
setups where the access to laser is in there, what is the
Yeah.
next best thing, as per your experience, you would recommend to do the stepidotomy, sir?
Yes, we have already discussed what I told you. I follow Dr. Ashish Bhumkar's technique where we use the micro drill or skeeter to thin out the posterior crust, keeping the entire incudostapedial arch intact without dislocating the incudostapedial joint. Thin the posterior crust to make more space to expose the foot plate better, to acquire more space to work on the foot plate, and then keeping the entire arch intact, make the fenestra first. Reverse stepidotomy with a skater or micro drill. Make the fenestra first, put your piston, crimp, whatever if you are using Teflon, and then finally disarticulate the incudostapedial joint once everything is placed, and then fracture the crura. This way, you are not going to, bring the foot plate out in case you have even accidental mobilization. First of all, by means of thinning the posterior crust, you achieve two things. You acquire more space. Secondly, you prevent the possibility of a stout, posterior crust taking out the foot plate. So fracture of the posterior crust will become much easier then. Like anterior crust, it will become fragile. And you can remove fracture both the crura easily. And that too you are doing after placing your piston. So your unit is, already in place, and the chances of foot plate fracture or bringing the foot plate out are least. This is what you can do if you don't have laser. Hello?
Satish, I also have a question. Can I ask?
Yes, boss, please.
One of my patients I did on 4 months ago. There is slight subluxation of the foot plate. Patient has vertigo on touching his pinna, but he has total AB closure. So what do you want me to do? It's 4 months post-op.
Vertigo and
Total AB
hearing
closure.
loss.
Pardon?
Complete hearing loss? Is it?
No. AB closure, complete normal, absolutely normal hearing.
Okay.
But there is vertigo on pressing the pinna or touching the pinna.
Okay, so you mobilize the
Fistula
foot plate.
sign, fistula positive.
Yeah, so you mobilize the foot plate, you mean to say?
Yeah. There's a little subluxation.
Yeah.
So now 4 months post-op, what should we do?
Nothing. Let
It's
it
normal
fix.
hearing now.
As long as hearing is normal, nothing is required to be done.
So, but the patient is bothered about vertigo.
Yeah. So let the foot plate fix on its own.
Okay.
Because any intervention can invite problem. As long as the hearing is normal, nothing is required to be done. Number one, symptomatic, and allow it to fix. If you really want, hearing is absolutely normal. Because of the mobilization, this happened. And if you really want the refixation to expedite, what you can do simply, just explore and pour a little bit fibrin glue over the edges all around. That's it.
Okay, that's what I was thinking to do, but then I still prefer to wait for some more time. Maybe 6-8 months down the line. But patient has forgotten about her hearing loss. She's more distressed about vertigo now. What to do?
Yeah. Vertigo is very bothersome. But as long as the hearing is good, that is not an indication to do anything.
Okay. So we'll wait and watch.
Yes. And then if it is too bothersome and patient really fed up with this, you can pour some fibrin glue to expedite the
fixation.
healing. Yes, fixation. So now we move on to a very important case. We have 2 cases done now, 4 major cases lined up. The first one being a very, very unique situation. And we have been doing this for years together. That is a patient who has bilateral profound sensory neural hearing loss. What's my point? Young patient, 16-year-old, postlingual, female, with good speech. She's a good singer as well, but unfortunately developed bilateral profound sensory neural hearing loss. And the reason is cholesteatoma. Profound means profound, in the hearing aid is not working. And this is a most difficult situation, what to do to rehabilitate such patients. What can you do? Hello?
Hello, yeah.
Yeah, so patient has one problem is cholesteatoma, other is a profound hearing loss. Our technique we have done in numbers of patients now is subtotal petrojectomy and implantation at the same stage. This is a unique technique which gives you the best opportunity to remove the cholesteatoma from anywhere in the temporal bone. Subtotal petrojectomy offers the best exposure, even more than the canal down mastectomy, to remove the cholesteatoma. And obviously, in non-infected ears, after bringing the infection, under complete control. And then at the same time, you can do a cochlear implantation for the hearing rehabilitation. And we have done in numbers and numbers of such patients. And this is the right indication for such patients having bilateral profound sensory neural hearing loss with cholesteatoma. Now, there could be questions. Operating in the situation of cholesteatoma can invite infection to the inner ear. Just theoretically, you can ask. Our insight into this subject started long back when we followed the Mario Sana closely. His series, wherein he published his first, he published so many papers, but the major one in 131 cases, mostly CSOM after canal down mastectomy, cholesteatoma after central perforation, retraction. The challenge is in CSOM is the infection coming back, returning infection. So like for example, if you have a situation of a central perforation, you can do a tympanoplasty, fine. And you can come back for this thing, cochlear implant surgery after 6 to 12 months. When the middle ear is settled, infection free. Yes, you can do theoretically and it can give good results by and large. But, what is the control over CSOM in long run? Even the best of the series in the world have shown results going down over the period of time, even type 1 tympanoplasty. Because acoustic and tube function, long-term hearing results, long-term, CSOM coming back has no control. And once you have implanted, your middle ear is obviously not going to be, of any use as far as the hearing is concerned. So this subtotal petrojectomy is a technique which was initially developed by Hugo Fish in 70s as a lateral skull-based procedure to eliminate the infection from the temporal bone and blocking of all connection of future infection to the temporal bone. What's my point? You have to exentrate. What does the subtotal petrojectomy mean? Exentrate all cellularity from the temporal bone. All cells and the mucosa in it, you have to exentrate. remove the all skin from the temporal bone, from the tympanic membrane, axonotary canal, and block off all connections to the temporal bone. Exterior connection means by means of obliterating the eustachian tube, by means of doing a cul-de-sac closure of the canal wall. You block off all connections coming to the, for future infection coming to the temporal bone, and then obliterate the entire cavity with a fat to create a sterile zone. That can be used in this situation of cochlear implantation in ears who had been infected in the past, who are likely to be infected in future, or can give infectious complications and can have a disaster on the cochlear implant if you use that. If you do a cochlear in a CSOM patient, treat CSOM after an interval, do implantation. What happens if the CSOM returns back with implant in situ? What can you do? You are helpless. With a foreign body in place, many times even the antibiotics do not work and the biofilm develops. Because of the foreign body in the vicinity of the infection, biofilm develops. And that is too resistant to infections. So even your, antibiotics do not work. So what you can do in that situation? In that situation, if you are left with a CSOM coming back and implant in place, most of the time you have to end up explanting it. And that's a disaster. If I have a cholesteatoma cavity, if I have a CSOM retraction, I can do everything same stage, doing a subtotal petrosectomy, eliminating all skin and mucosa from the temporal bone, block off all future possible connections of infection coming to the temporal bone by means of obliterating the eustachian tube, axonotary canal, implant at the same time, and obliterate the cavity with the fat to create a sterile zone all around it to prevent future sources of infection in one go. Obviously, if there is active infection, if there is uncontrollable infection beyond the control, chronic granulomatous, whatever, you can control it first and go second stage. But in a regular situation, when the infection is in control, you can do same stage rather than unnecessarily doing two surgeries. And we have done numbers of such cases and it works amazing. And this is what the situation in this case. This patient has a cholesteatoma. Look at this. See the cholesteatoma cavity? Can you see? Hello?
Yeah.
See the huge cholesteatoma on this side. The other side is not cholesteatoma, has the same hearing loss as well.
Natural
But here
mastectomy already.
you need to treat the cholesteatoma also, which is life-threatening.
Yep.
So here today what I'm going to show is going to eliminate this pathology as well by means of doing a subtotal petrosectomy, which provides much more exposure than a regular canal wall down mastectomy. I'll show you. With that exposure, a good middle ear surgeon cannot leave the cholesteatoma behind. Forget about the cholesteatoma. We are not even leaving the mucosa behind. What to talk of cholesteatoma? And in subtotal petrosectomy, challenge is not, most often, challenge is not the cholesteatoma or skin removal. Challenge is the mucosa removal, exenteration of all cells. And that is what I'm going to show you. Your CT scan guides you. If you do a three-dimensional reconstruction, it will give you complete information about the, cellularity, remaining cellularity in this patient. See this. It will tell you what group of cells are still there. See, what group of cells are there? This is fallopian canal. Can you see the fallopian canal in the coronal section?
Yep.
See all cells lateral to the fallopian canal. Can you see? We have to exenterate. Petrous apex not pneumatize. Cochlea, infracochlear cells are not so pneumatized. This is all marrow spaces. See this supralabyrinthine cells are there. Can you see?
Yeah.
So it gives you full idea what cellularity to be exenterated. We will skeletonize the temporal bone and the intertemporal structures, the facial nerve, carotid artery, the mastoid tip we are going to remove, the tegmen plate, sinus plate, the labyrinth, everything will skeletonize, including the jugular bulb, so that we don't leave any cells behind. Removal of the cells and mucosa is the key. More than that, we will remove the bony eustachian tube totally, so that no possibility of any cells further draining into the eustachian tube, which can be left behind. I will show you that intraoperatively how important it is. If you leave the peritubal cells, pericarotid cells, they can be a source of infection further, which are draining distally into the bony part of the eustachian tube. So eliminate the bony eustachian tube to prevent future connections of all these cells. That is the bottom line, to prevent any cellularity leaving behind. That is our technique I am going to show you. Eliminate the bony eustachian tube along with all sources of aeration or the communication to the exnotory, to the cartilaginous eustachian tube opening in the nasopharynx. So this is what we are going to do. So this is about the CT scan this case, of this case. Now, regarding the candidacy, the most important thing is we need to have the basic functioning unit intact for the candidate to be eligible for cochlear implantation. What is that basic functioning unit? See this? What you need to see on MRI? The intact cochlea full of fluid. Can you see the cochlea in this heavily titulated imaging with a bright spot seeing as a fluid in the cochlea? We need the cochlea fluid filled with a cochlear nerve intact. Can you see the cochlear nerve there? See the cochlear vestibular nerve. And see the cochlear nerve to the cochlear aperture. Can you see?
Yeah.
That is cochlear aperture. That is vestibule. That is vestibular nerve. This is cochlear nerve. That is cochlear nerve. So what you need to see is, you need to have a cochlear nerve and a fluid-filled cochlea to make the candidate eligible for this kind of, cochlear implantation. Let me reconstruct at this end, at the cochlear aperture, to see all the nerves in 3D plane, in the sagittal section. See this? This is cochlear aperture. See where? This is all cochlear. This is cochlear aperture. And see the nerve coming from this is the brainstem. See the nerve coming from the brainstem going to the cochlear aperture. That is cochlear aperture. So the nerve which is anterosuperior is the facial nerve, and the nerve which is anteroinferior is the cochlear nerve, and behind is the vestibular. So we have a good, all the four nerves you can see in the lateral end of the, in the sagittal section. This is the vestibular nerve behind. That the facial nerve and the cochlear nerve. And this is the cochlear aperture leading to the cochlear nerve. See, this is the cochlear nerve. Can you see very clear? Hello?
Yeah.
So MRI is useful to confirm the eligibility for the cochlear implantation in terms of looking at the basic functioning unit intact. And that denotes the fluid-filled cochlea and intact cochlear nerve. That is what the basic need for the candidate to be eligible for cochlear implantation. And here in this case, our challenge is this cholestotoma cavity, and we'll look at that. Regarding the facial nerve and other structure, inner ear structure are normal. See the cochlea, modulus, everything normal. Can you see all three turns? The vestibule.
Yeah.
See, this is labyrinthine course of the facial nerve. This is first JAMMU. This is the horizontal course. Can you see?
Yeah.
Absolutely intact with the bone over it. Can you see the horizontal course?
Yes.
And now this is your vertical course. This is sinus tympani, and this is your vertical course of the facial nerve. Can you see?
Absolutely, yes.
And see, this is the thick facial ridge over it. And see, these are the cells behind the course of the facial nerve. So this is how you have the anatomy, and I need to accentuate all these cells. See my lateral semicircular canal. There is no fistula over it. Everything you need to see. See, this is carotid artery. This is carotid artery with a thick bone over it. Can you see? This is cochlea and carotid. There is a thick partition of the bone between them, between the cochlea and carotid. This is the jugular bulb. See, this is the jugular bulb with a thick bone over it. So neither jugular bulb dehiscent, nor carotid artery dehiscent, nor facial nerve dehiscent, and some of the cells lateral to the facial nerve, and this is all cavity, and some supralabyrinthine cells, which we need to excentrate. I hope the anatomy is very clear in this region, what we need to do. So our goal in this case is to excentrate all this cellularity, skin, everything. We'll do a cul-de-sac closure of the extraartery canal. We'll do ultimately remove the bony eustachian tube and obliterate the cartilaginous eustachian tube, removing all peritubal, pericarotid, all infralabyrinthine, all cell tracts. We'll see one by one. And skeletonize everything. And then implant. Then, once you have this kind of exposure, then implantation is a cakewalk, you know. Just open the round window, extend the round window inferiorly, right under vision, put the implant and obliterate the entire cavity. Then it's pure cakewalk. With this kind of exposure, implantation is the easiest thing you can think of. So I will share you and discuss all the steps of classical subtotal petrosectomy. You can see, and then we'll discuss the pros and cons of this surgery. And I'm sure this child with a profound hearing loss will be able to hear perfect after this surgery. Any questions,
Hello,
any comments before we go ahead?
Sir, this is Dr. Rohit from Bangalore.
Yes.
I have a question. What about the left side, sir? What is the plan for the left ear, by any chance?
Yeah, again, after that, once you rehabilitate the right side, then choice is upon the patient. If you have a profound loss with the aidable with the hearing aid a little bit, you can continue, otherwise implant in the right ear. Here,
okay, sir.
We have two goals, not only to rehabilitate the hearing, but at the same time, you know, making the ear safe from cholesteatoma. Any other question? One. Any other question, please? Or do we go?
So would you think about implanting this patient in case they can go for both sides in the same sitting, or would you first finish off only the right ear and then?
Yes, bilateral same stage can be done. Bilateral same stage is one of the ideal, you know, thing you can do whenever required. Hello.
Sir, one more question. What are the other indications other than the infective etiology and cholesteatoma? What are the other indications that you would do a subtotal petrosectomy and implant?
In between, I'll come with a presentation to answer this. But yes, once you have asked, any difficult situation of the cochlear implantation in terms of difficult anatomy, very regular approach you're finding difficult, subtotal petrosectomy, the final answer after that. Any abnormal malformation which has high likelihood of giving a gusher, CSF gusher, like common cavity, IP1, IP3, I would always suggest to go with a subtotal petrosectomy, because you obliterate the cavity, not only sealing the cochlea, added on to that, you're obliterating the cavity, which gives you the best opportunity to seal the CSF leak forever. Whenever you need, you know, implanting in labyrinthine ossificans where you need a extensive workout, extensive drill out of the cochlea, then the subtotal petrosectomy is safest, as you have all landmarks, carotid artery in control all around. Yes, boss.
Satish, we have the privilege of presence of a stalwart in cochlear implant, Dr. Mohan Kameshwaran, with us.
Alright,
So he's
sir.
going to chair this session and add to the knowledge that we all want to hear from him. And with him is Dr. Rohit Prasad.
Hello.
Satish,
Hello, sir. Good afternoon.
good afternoon. Good afternoon. I'm not going to add to the knowledge. I've come here to watch you operate. It's a real pleasure. Go ahead. We're talking, so I'm listening.
So nice to have you, sir. And your, your knowledge, your experience in this field of cochlear implantation is unbelievable. You are one of the pioneers who have, led this program in our country. And so many of your students are now carrying forward this cochlear implant program in our country. We are blessed to have you here today to have your expert comments and your guidance as well. Thank you so much, and big thanks to you for providing this platform of Indian Academy to propagate academics for everybody.
Thank you, Satish. Actually, it's the other way around. We are very grateful that you could find time to do this. So go ahead. Let's watch your. Everybody is very eagerly waiting.
Thank you, sir. So in a couple of minutes, I'll be there with a microscopic picture. Couple of minutes. And we found the mark involving the microscopic lens. And the facial nerve all around, facial nerve was paralyzed and the part of the connecting canal and part of the features more.
To add on to what Satish said, this is something which is very essential to be in the armamentarium of a cochlear implant surgeon. Subtotal petrosectomy is a fallback when everything else goes south. Then every other approach to the cochlear is spoiled or is impossible. You can always rely on a subtotal petrosectomy to give you the landmarks and be able to introduce the implant. So it's something to have in your armamentarium, and it's something which is very versatile. It's a very versatile procedure, and it can be done for a whole variety of abnormal situations or previous surgical position. For example, somebody's had a previous canal wall down mastectomy, for example, or somebody's had previous glomus surgery or something like that. So, it's always a technique that you can use as a fail-safe and a fallback if everything else is anatomy is disturbed.
So, Mohan sir.
Yeah.
Since I've been doing this technique for cochlear implantation for long, for many indications, what we have found, all patients who have had CSOM, by and large, this is our philosophy to stay on the safer side to prevent return infection. All patients who have had CSOM or who are likely to have CSOM in future, like for example, a cleft palate patient whose eustachian tube was having eustachian tube malfunction.
Yes.
Even a repeated secretory or type media handled with grommet, having bilateral preference requiring cochlear implant, I would always go ahead with a subtotal petrosectomy and prevent any possibility of infection coming to the temporal bone in future.
Yeah. I agree with you.
Yes,
I'm entirely in agreement with you, Satish. The subtotal petrosectomy is not only for infection. It is to prevent a significant retraction due to a malfunctioning eustachian tube also. Because if you have a retraction which is bad enough that it goes into the middle ear with an implant, the implant will come out, definitely. So you have to have a safe, completely safe option. And this is the safest option. So I think this is an
Right.
answer to malfunctioning eustachian tube. Let me put it like this. So if you have a malfunctioning eustachian tube, be it a cleft palate or a chronic secretory dysmedia, whatever, that doesn't mean for every secretory dysmedia you're going to do it. So initially you'll put a grommet, but what Satish is trying to say is that there's a chronic dysfunctioning eustachian tube with recurrent otitis media, in spite of repeatedly managing it, still happening, then this is a very, very safe option to put in an implant and make sure it won't extrude later date. Am I right, Satish? That's what you're trying to say.
The reason behind is not in suppose any patient who has a CM, had retraction, cholesteatoma, somebody had treated with a canal up technique and is doing fine. What is the guarantee for the infection not coming back in future? You know, such surgeries fail in long term quite frequently. Intercanal mastectomies, retractions. You cannot have control or use second tube. The problem is, if you have gone ahead after that surgery, couple of, with an interval of, say, 6 to 12 months, dry year, implanted, regular technique implanted, and if in the implanted year, infection returns, CSOM returns, is a disaster. You must have long series, you must have seen failures of people coming from everywhere to you. With the implant in situ, if CSOM return, it's a disaster.
Absolutely, yeah.
You are not left with many, even if you try the best of the culture antibiotic. We have seen many times patients coming to us with huge biofilms. No antibiotic is working. Infection in the vicinity of a foreign place in the ear. Infection coming in that region is likely to, allow biofilms to form. And then ultimately, you have to end up explanting that patient. And that's a disaster. So if any patient wants status of the possibility of the infection coming back, we on the safer side follow this technique of subtotal. I will share each and every small step to carry out, execute this technique. So this technique, I know it's a little complex one, not difficult, but we have to execute it accordingly to prevent, surgery-related issues. That's a very important technique. This technique we use for many lateral skull-based procedures. I have seen, patients in the cochlear malformations. Cochlear malformations, particularly to give CSF gushers. Yes, you can control the gusher by, sealing the cochleostomy. Like, for example, IP1. I tell you, I give an example at Morwani sir's workshop. Patient having IP1 with a gusher, you can control the gusher. Plugging this, you can still do an implant by prostate tympanotomy. You can experience, anybody can do it. But there is always a foot plate anomaly associated with IP1. The patient at this workshop who presented 3 times with meningitis, found hearing loss, meningitis, was treated by the neurologist all 3 times, didn't bother to look for the ear, the source of infection in the ear, and it was ultimately an IP1 which was responsible for meningitis 3 times and was not diagnosed. The reason being, IP1 has a foot plate defect, had a endosteal defect in the foot plate, whereas, a cyst kind of a thing with a thin layer forms out of the vestibule into the middle ear. It is prone to get infected if the otitis media develops. And that leads to meningitis. Even if you implant such patient, rehabilitate by means of cochlear implantation, you don't prevent, if you don't treat that foot plate anomaly, you actually don't treat the prevention of meningitis. So in order to do that, what we have in our little experience, we have done lot many IP1s, always do a subtotal pituitary obliteration to prevent future infection. One can implant by a posterior tympanotomy and give hearing as well, but implant is not going to future in meningitis. IP1 has the highest incidence of amongst all malformation of giving meningitis because of this anomaly. So,
Yeah, Satish, I could tell agree. See, what you're saying now is more or less standard of practice now. You know, it says is accepted by most people because in you're doing a subtotal petrosectomy, you're completely isolating the middle ear from the exterior. Now you're doing a blind sac, you're plugging the station tube, and you're completely cutting off any.
Because your middle ear is anyway not going to participate in implantation.
Yeah. It's very true. It's the safest option. What you're describing is a very safe option in patients with recurrent meningitis. Yeah.
Similarly, nowadays, we all know the skull science is developing like anything, particularly lateral skull base. After even the lateral skull base procedures, what we believe, if our basic functioning unit, the fluid filled cochlea, the cochlear nerve is intact, you can implant at the same time. This is the basic philosophy now. If this basic functionality is intact cochlear now and fluid filled cochlea, even after the major tumor resections, you can rehabilitate with a cochlear implant.
Yeah.
And subtotal petrosectomy is the key to obliterate and give a sterile atmosphere in that region. Similarly, in ossified cochlears microscope, ossified cochlear, you need to do an extensive drill out, labyrinthine ossificans. Doing a drill out through a narrow posterior tympanotomy is always, full of danger, as the carotid arteries immediately enter in the vicinity of the, cochlea, and drilling through that narrow posterior tympanotomy can invite disaster. So we always advocate doing a subtotal petrosectomy and just take all marks around the cochlea, including control, and you can carry it very, very safely. And you can, more effectively seal what the cochlear, turns you open, sealing with the periosteum and ultimately obliterating with the pads. That is better opportunity to seal the cochlear turns if you do subtotal petrosectomy, because ultimately you obliterate the cavity. So there are so many indications now. Indications for subtotal petrosectomy implantation have been expanding. When the cochlear implant science burst earlier, the implantation was indicated for very limited situations with young prelingual children with this much of word score, this, that. Now, as we have understood this, the results are so gratifying and understood this science much better. The applications are expanding. Now, even after any major resection, tumor resection, whatever, major surgery in the lateral skull base, if the basic function unit is intact, the cochlear now and the fluid filled cochlea, still you can rehabilitate very well with the hearing. I hope you agree with me, sir.
Yes, absolutely.
So one question for Mohan sir and Satish sir. Have you in your practice done a subtotal petrosectomy for a patient who has already been implanted and had some extrusion, and then you had to revise it?
I have done quite a few actually. When patients have had previous implantation, but due to, let's say, infections or something has happened. Yes, we explant, we keep a dummy in the cochlea, we do a subtotal petrosectomy, allow it to infection settle down, and go back and do it.
Once you have placed the fat and then close it down, can you reopen again and then implant?
Yeah, you can. Okay. Do that. And like Satish said, we've combined, for example, we've had acoustics removed with preservation of the cochlear nerve, and then we've done a cochlear implant with subtotal petrosectomy, same thing. So it's also possible. So it's quite possible to do that, today, preserving the cochlear nerve and keeping subtotal petrosectomy is a very safe option.
So in next few seconds, we are getting you the microscopic picture.
Yes, Satish, we're all waiting for it. Actually.
Sir, do you more often see the need to do the subtotal petrosectomy in children or in adults, or you see an even out?
Both. But children more simply because in our country we do more children than adults for cochlear implants. But a lot of children who have, like you said, abnormal partition defects with history of CSF leak and so on. Definitely, these are children who will do very well with patients who had CSF leaks or meningitis, recurrent meningitis. They're candidates who need cochlear implant, but the risk of meningitis means that you have to secure that the risk of infection will not happen again, and this is the best option.
Hello.
Yeah, Satish, we're waiting for you.
Can I add one more point to it?
Yeah.
Now, the indication, as I told you, have been expanding for the adults. And this subtotal petrosectomy, we selectively use for one more specific indication. Post-traumatic profound hearing loss. Post-traumatic profound hearing loss with temporal bone fractures, cochlear nerve intact.
Yeah.
We always do a subtotal petrosectomy implant because the fractures in temporal bone heal with fibrous union, not by bony union. And there is always a possibility of infection spreading to the subretinal. If you
very
do an
important
implant, if you do a regular implant, it's still possibility of ascending infection always there. You don't have the possibility of infection spreading because you create a sterile zone in the obliterated cavity for the implant, so the infection cannot spread there. So that is another very point, a useful indication for the cochlear implant in that group of patients. Now see this patient. Please connect the endoscopic picture, microscopic picture. Are you getting, sir, microscopic picture?
Yes, we're getting it.
Let me
Nicely see.
finding of this patient. I'm focusing to अरे यार ग्लेयर आ रही है वो तो ना दूसरा this also is a glare. Viru? Speculum is glare.
Satish, Dr. Madan Kapre is here. He's also watching you, so
Yes. So, Mr. President, can you see the atic cholesteatoma?
Yeah, we can see it very well. Yes.
This is the atic cholesteatoma.
Yeah, we can see the flakes.
Secondary infection, the impact. So now, let's go ahead with the surgical steps, and I will share you our technique. Number one, this post-auricular incision. See, this patient has failed mastoid surgery earlier.
Yes, we can see this.
See now, my post-auricular incision is a regular one, like any other ear surgery, or little couple of millimeters big, with a little curvilinear extension above.
Yeah.
So that I don't strain the skin. This incision is very, very, safe incision in terms of not violating any blood supply anywhere. With respect all vessels, auricle. Mop. The ear is supplied all around by different vessels, the branches of external carotid. Mop. Anteriorly,
some blood.
Yes,
blood
please.
sticking to the lens, the objective lens of the microscope. We just wipe it.
Can you wipe off? Yes. Thank you, sir.
No, it's still there. Still singing. There's some blood clot or something. It's on the lens, in the objective lens. Yeah. I think we can ask somebody to take a wet gauze and wipe it down.
Yeah. कौन सा ये? कौन सा ये?
Yeah. It's still there, yeah. Okay, go ahead. I think we can see the images.
Yeah, section. हल्का से नरेश. See, what I'm using is a plasma bipolar.
Okay, right.
This is amazing plasma bipolar with the irrigation, inbuilt irrigation into it. Irrigation तेज करो ना.
What is that, Satish? Can you show us the device later?
Yes, I can show you. This is a bipolar. You can see.
Yeah. Plasma bipolar.
That forces, yes, but what's the device?
This is a bipolar with a plasma principle and an inbuilt irrigation system.
Made by whom and when did you get it? Can't hear you, Satish. I think you need to get your audio fixed.
Yes. See, this is the irrigation port. See this? See this?
Yeah.
Bipolar has an inbuilt irrigation. So this is really good. Nice. The first step in cochlear implant surgery is very important. This flap designing, incision making. This all helps in preventing. A properly done technique prevents in, post-operative infection. Less tissue trauma, respecting vascularity, covering the implant properly, all are important in, or inviting. So we use advocate, less use of cautery as well. More work, knife only, avoiding cautery uses to the minimum. See, this is the level of the extraocular canal.
Yeah, you can see that.
In a regular posterior tympanotomy, you don't violate the extraocular canal. That's the biggest advantage over other approaches like Varia and other that. But here, since we are going to obliterate the cavity, we are going to do a cul-de-sac closure. So
yeah, it doesn't matter.
Doesn't matter. I will rather open up the canal. See this?
Yeah.
And do a complete cul-de-sac closure.
Yeah.
I will bring out the extraocular canal sleeve.
You're doing a complete blind sac closure. Yeah.
Yeah, that will help us doing a blind sac closure. See, the more important point at this lateral edge is when you divide the canal in this surgery, not to leave any epithelium inside once you remove. This outside epithelium will elevate as a sleeve and suture it. See, this is the cartilage from where I am separating. Can you see?
Yeah. We can see it very well. Yes.
This is your tragal cartilage from where I am separating.
Yes.
And this is your conchal cartilage behind.
Right.
Once you bring out the sleeve to strengthen this, or from, opening up again, this cul-de-sac closure should not open up, otherwise this can invite problem, this can invite infection, this can invite skin to grow inside and leading to cholesteatoma formation. So we substantiate this skin closure afterwards in a second layer with suturing the tragal cartilage to the conchal cartilage as a second layer. That is amazing to, this cul-de-sac closure opening. Sleeve. I am just elevating the skin canal. Can you see? I hope it is very clear there.
Very clear. Very, very clear. Steps are very clear.
remove. This is tracheal cartilage, this one.
Yeah,
This
we can
is-
see the tracheal cartilage and the This is something that every otologist should be familiar with, this procedure. He's showing it very nicely, and it's something which is
So we
very
will bring
important.
this sleeve out, suture it out. See this sleeve out?
Yeah, very clearly.
We'll suture it and then reinforce below. We'll reinforce this cartilage to this cartilage.
Yeah, right.
Completely to,
Close it.
reinforce. It should not come back. So, till there. Give me suture. This should be abdominal suture. What I'm using, either white color or monochrome, so that you need to remove it. A removal of the suture can invite again the skin going back. So let it be for a couple of weeks. तो उठा इसको उठाइए इसको This is a very, very important step. You can carry out in 2 minutes. That's a common step we do in our practice. Couple of sutures here. Even the skin, so that it should not invert.
Yeah.
Our idea is the skin should not turn back inside. That's it. So here, one is the suture which we are holding. Other one I am doing is a blanket suture. See this. This is a blanket suture which I am doing. This suture is a guarantee that my skin will not invert. Can you see now?
Yeah, very clear.
This is classical blanket suture. This is a guarantee that skin will never going to invert now.
The mattress switches for
Yes.
Sir, post-operatively, do you follow any radiological protocol to keep a watch on any cholesteatoma?
Yes.
Recurrence.
Important. Theoretically very important, but depends upon how you have carried out this subtotal pituitary adequately. We'll discuss this at the end of the surgery. But yes, theoretically, yes, periodical radiology up to 7 to 10 years is essential to see any cholesteatoma or skin coming back. Number one. Number two, in implant, this is a bit challenge because normally on a diffusion weighted MRI, you can pick up the cholesteatoma early. But with the MRI in place, generally, the implant in place, generally you don't advocate MRI. No, nowadays the MRI compatible implants are there, but still you don't know, do because of the artifacts. So what you do, a good contrast CT scan will give you a great idea if some cholesteatoma is forming, giving you as a different contrast as compared to the surrounding fat. And then if you follow on serial basis with enlarging in size, confirm the diagnosis of cholesteatoma, if any. But a good surgical technique rules out. Cut दे. This is the second reinforcement. See, we have a deficient conchal cartilage in this case because of the previous surgery. But still,
yeah,
if you don't have
yes, we can
cartilage,
see
you
that.
can make.
Yes.
Yeah, if I don't have
So
cartilage,
this
I can make.
cartilage approximation would be, cartilage approximation would give you additional protection so that it doesn't give way.
It doesn't give way. Yes, sir. Secondly, if you don't have a cartilage, I can make an inferiorly based posterior auricular artery flap. Anteriorly based temporally fascia pedicle flap. I can bring temporoparietal fascia or anything as a supplement layer to prevent this cul-de-sac closure breakdown.
Yeah.
Idea is to prevent this breakdown. That's it.
Yes. Yeah. Very important. Yes.
See, the conchal cartilage was deficient here.
Yes.
Or I have adequate, coverage.
You got plenty of coverage. Yes.
Yeah, and the canal is hidden now.
Very nice. Yes.
Now, another part very important in cochlear implant surgery, when you raise the flaps, you have to make flaps to secure your implant. Now, there are many ways to, develop the flaps. अरे इम्प्लांट कहाँ है इम्प्लांट कहाँ है और वो टेम्पलेट मेडल वाला है now the next part is making flap to cover the implant. So the rule is your suture line should not come over each other. Number two, the flap should be well vascularized. What I will do some undermining here. There are many ways to do the same thing. This is our classical way we do. See, I'm doing undermining behind. And I will make a superiorly based flap. More and more undermining will allow me to raise a good wide flap. Wide base flap because this is a random flap. See now? I am making the incision like this for this flap. That is the tip of the flap.
That's a nice superiorly based flap. It's perpendicular superiorly.
Yes, sir.
Yeah, very good. You can see it's very vascular.
Yeah, this is the reliable vascularity. And then as you go up, the base would remain wide.
Yeah.
Before you go higher up, the base should remain wide to prevent necrosis.
Base on the temporal is.
That is the flap.
Sir, would you get good flaps in patients who are treated multiple times for chronic otitis media and yet are planning a surgery now?
Yeah, temporal is always.
Temporal.
Temporal is always be there. So. But you can have something based on sternomastocysts.
Obviously.
See this? This periosteum is so tightly tethered to the bone here, cortical bone. And I'm separating this periosteum. Bang on the bone. See this? So this will be, the flap. My flap incision, see? This incision was here, the flap anterior incision here, posterior incision here. So no incision is, falling upon each other.
Yeah, very nice. Very nicely.
And see, such a good, very, very reliable flap, you can say. Yes, Bando, yeah. Knife. More you go high up, go wider. See this? Go wider. Go wider. So as to maintain the blood supply. See?
Yeah, the principle of a random flap. So it's very, very nicely demonstrated. Yes.
That's an amazing flap. Now my next goal, monopolar. For subtotal petrojectomy to prevent any skin remaining medially. यूं रखना यूं पकड़ते तो हल्का सा तोड़ मत देना. You know, I'm intentionally, this is my cut end of the canal. I'm intentionally using my monopolar cautery.
To remove the epithelium.
Yeah, possible so that I don't leave behind.
Yeah.
At the lateral end.
Very important for this step. There is no epithelium left behind. Otherwise, you can get a cholesterol years
This
later.
is the sleeve of the canal.
Yes.
This is the sleeve of the canal. See this? This
very nicely seen.
Section. This is intentionally with the monopolar cautery. I am quite lateral, very safe zone. See the canal. My skin sleeve I am elevating is intact.
That's very important because it's the surest way of making sure you removed all the epithelium.
Lateral, because there is always a possibility of leaving the skin laterally behind.
Right.
So
you want to go all the way to the annulus along with the drum, take it out along with the ossicles.
बैनर है ना यार इसको सही रखो यार. Yes. See now what I'm doing. This is diamond bar. All lateral end of the bone. See now laterally what I've ensured no skin is left behind.
Yes, we can see it very nicely.
Medially we'll clear later.
Later, yes.
Laterally we should not leave any skin at the cut end of the canal behind in any given situation.
Yes, Satish, I've seen very well. Yes.
More than that, now on the bipolar, I will bipolarize the surrounding tissue. See, bipolarizing the surrounding tissue. Tease karo na yaar.
Yeah, so no skin epithelium is attached anywhere. You can see it very well, so that this making sure that there's absolutely no skin left anywhere, which may give trouble later.
Area you have to ensure. Now see, this is cholecystoma here.
Yeah, we can see it's already eroded.
See the cholecystoma here. See this?
Very, yes, Satish, you see.
Now, before, you know, what happens when we raise the flap at the time of the closure in the hand, because the flap tissue retracts a little bit. And there is always a possibility of giving a tension closer in the hand, knife. So what we do, since we do not do any undermining or anything, any dissection after the implant is opened, what I am doing, see this was the flap incision, this was the flap, this was the flap incision.
Yes.
I am doing a training here right now. So that I don't need to do this because I don't want the tension to. Got my point?
Yeah, very well. Yes, seen very well.
If you do undermining, this may invite open the implant. Generally, you are advised by the manufacturer not to use any cautery. This is undermining to prevent tension closure at the end of the surgery.
Yeah.
This is to be done at this time. See this? The
Right.
tissue is more and more tissue is released to prevent tension closure. See this?
Yeah.
So much tissue.
Very nicely seen. Yes.
See, we have this additional tissue now. Ample of tissue now.
Yeah. So later on closure will be easier. Yes.
Yeah, there will be no tight closure at all.
Yeah. Yeah.
This tight closure, if this closure breaks up,
Then
this
it
will
will be.
infection.
Yes.
Infection. So this should never happen. I am releasing the tissue from all around. No tight closure should be there in any given circumstances. Okay, fine. Okay. If
Yeah.
any oozing, bleeding, you can use your bipolar freely now without any hitches rather than leaving it for the end of the surgery where you are supposed to avoid using too much of cautery. Now our bone work will start. Here the aim of the bone work is different. We have to exenterate all this skin from the temporal bone, all this mucosa from the temporal. एक सूचर लगा दे, एक यहाँ और लगा दे. This is mastoid tip. There are rare layer of muscles attached on the tip. The most lateral being the sternomastoid, then splenius capitis, and then medially digastric. And this blood supply to all this tissue comes from medial to the digastric, which is to the occipital artery, which runs deepest of all. So separating this tissue is very, very safe. Now, see my exposure now?
Very nice.
Two stay sutures. One more here, one more here. So I will use stay sutures, not the retractors. That is one more thing which we don't do in implants. Too much of use of retractors ruin the tissue. Too much of use of cautery ruin the tissue. So small things can help a bit. All these are important to prevent infection, right from the pre-operative immunization to the antibiotics to everything. Everything matters. यहाँ लगा यहाँ ये sutures and no need of retractors at all. Two more sutures.
Last one.
Yeah. Two more. One here, one there. One here. इसको मिला लिया दवाई.
Thank you. Good.
So now our bone work is start after the stay sutures. And as I told you, we keratinize each and everything. A classical subtotal petrojectomy I am going to execute. Our next case is going to be a JANMU with a cavernous sinus extension. लो वो दो बुलेट बुलेट retractors. राइट मत कर बुलेट पर बहुत टाइम लेता है एक घंटा लगा इसको Yes. Hello.
Yeah, Satish, we're with
Yes,
you.
sir. So now I'm starting this cortical release. See just. तुम इसको यूं रखना This is the conical bar I'm using here. Conical.
See the wrinkles.
Outer cortical wall which can do faster. See the glimpse of sigmoid sinus. Can you see?
Yeah, again, nicely you've seen. I'm happy to see you using a conical bar because I do it all the time. It's very nice. It's a big advantage. This.
That's the basic conical bar.
Yes, it's very quick, very safe. It's my favorite also.
I am going peri-sinus to accentuate all possible cells.
Yeah.
This is the tip which I am going to skeletonize and remove. See in the tip, in the diaphragmatic ridge.
Satish, your mic, your audio is the problem. There's some interruption coming in your mic. I think there's a...
Hello?
Can you ask them to check your mic? I think your microphone now and then is breaking up. Your voice is breaking up now and then.
Yeah, can somebody ask him to change the audio, please? Can you see the tip?
Yeah, we can see it very nicely.
See this digestic ridge horizontally.
Yes.
See, all air cells behind the sigmoid sinus have been removed.
Yes.
All air cells are
You're nicely skeletonizing the sinus.
lateral to the digestic ridge, all cells removed. See this?
Yes. Yeah, we can see that.
As long as you are lateral to the digestic ridge, you are very safe.
Yes.
This is an amazing landmark to the lower vertical portion of the facial nerve.
Yeah.
Natural landmark given by the god. See, this is digestic ridge and my facial nerve is immediately anterior and medial to it.
Yeah. Right.
Now, coming towards the tegmen.
So for juniors who are present here, this conical burr is a very, very good burr. It's a safe burr. Look at the way he's using it, using the side of the burr. So this way you can work very, very close to the dura and the sigmoid sinus without damaging it. So it's a very nice burr to have when you're working near the skull base. And you can see how he is using the side of the burr.
The point sir is raised is a very important one. To use the side of the burr, not the tip. And never use any undue pressure over it.
Yeah, yeah. And another advantage is you can see very well how he is saucerizing the whole thing. Sloping it. Is one of the paradoxes in otology. The more sloping the cavity, the larger the cavity, the more sloping the cavity. It cannot roll down. Eventually, the smaller it will be because of the collapse of the
Eventually
soft
the surrounding tissue falls in.
collapses. So it's a
So
natural law.
ultimately, even if we make a bigger cavity, the ultimate final size will be
Very
lesser.
small. Yes.
See the sinus plate, the dural plate.
Everything is nicely defined. You see a sinodural angle being opened.
I told you the word I mentioned about skeletonizing each and every crucial structure.
Yes.
See, I am working at the level of the zygomatic root.
Yes, and you can see the tegmen very well. You see the dura seen through the bone. The
Thin
bone is
bone is
intact,
there.
but it,
Thin bone is there.
yeah. I'm here. And you can see the cholestoma flakes now, and you can see the dural vessels through the bone.
This way I can expedite my procedure.
Yes. And you can see how he is removing the remaining skin from the extra-aortic canal. Now he wants.
Yes.
The lateral part is already removed, so the medial part also is now being removed.
Yeah, more and more, going bone deep automatically takes care of the skin.
Yes. The important thing is that you
This is
remove
uncovering
every
the
bit of skin.
hypotympanic area.
Right.
Bipolar. This is in regular bipolar भी रख लेंगे. पूरा अपनी रख. This is the pre-auricular soft tissue.
No.
Diamond. Medium size. See now the cavity. Now, if somebody asked, with this technique doing same stage, can you leave the cholesteatoma behind? With this kind of exposure, if you can leave the cholesteatoma behind, then you cannot do ear surgery. Boss. See, this is absolutely open book. This is much more a wider exposure than your canal down mastectomy. Can you see?
Yeah, it's seen very nicely. Yes.
This is my labyrinthine block. This one. And
Yes, the
I
labyrinthine
have to-
block. Yes.
I am skeletonizing the labyrinth from all around.
Yeah. The retrol labyrinthine cells are being removed now.
Yes, all these show me where exactly I have cells which I can leave behind. Bipolar.
Sir, could you reorient the landmarks again as you're going more medially?
Diamond. Diamond. See the perisinus. See mastoid hair cells, perisinus hair cells, peridural hair cells, sinodural angles, and now perisinus. retrolabyrinthine, retrofacial. This is the tympanic bone. See the hyperexposed.
Yeah. Yeah.
I can see the glimpse of the malleus.
Yes, you can see the galleys now very nicely.
This side,
See the tympanic membrane completely retracted, adhered to the promontory there.
Right. This is the tympanic membrane,
Yes.
which is on the promontory.
Yes, it's stuck to it.
This is I'm elevating the medullary space. Use second tube.
Yes, you can see the tube now.
Ladies and gentlemen, a very short announcement. Post-lunch session has been started in Hall C.
See all skin removed.
Yeah, you can see the annulus being removed.
Bipolar. आप tube लगा दे. See what I am doing.
Yeah, all the skin remnants and everything is gone now.
Mucosa, I am bipolarizing first. See this mucosa.
Yeah.
Even if you leave a millimeter of mucosa, that is made now. What man? There's a way to remove the mucosa. So I will do everything.
We can see that there.
See, bipolarizing making mucosa non-functional. See mucosa everywhere. Now, drill.
Mentioned in your comment, you have to drill away the bony eustachian tube, Satish.
Yeah, I will remove the bony eustachian tube. Leaving the bony eustachian tube, you know what happens? All these hair cells tract ultimately open in eustachian tube.
Which hair cells?
Yeah.
Many of them open distally in the eustachian tube, bony eustachian tube. If that pathway remains intact in the distal eustachian tube, again the infection can come into temporal bone.
Yes.
I will show you. That is the key.
This detail I didn't know because I don't think it was taught.
This is what we have been propagating. That prevention, I will show you. That is the key. See now,
We used to only block the tube here. But
supralabyrinthine cells. See now, this supralabyrinthine cells.
Yeah.
Completely skeletonized. Can you see the eustachian tube? Sorry, the facial now.
Yes, very nicely.
Yeah, we can see that very well.
Hi, Mohan. Hi. I forgot to say hi to you earlier.
Yeah, bye.
See you tomorrow. I'll come tomorrow.
Yeah, sure. So this is important. What he's doing is very important. That is, he's completely removing the cells, the cells around the tube, and then
See what I'm doing? Removing the bone lateral to the eustachian tube to wider it.
Yes. And then to seal it. Yes. You have to remove the mucosa from the needle end of the eustachian tube. Yes, that's the whole point of subtotal. See, subtotal petrosectomy has initially started, looking at it historically as an oncological surgery for temporal bone malignancies, but now it's used more and more in indications which Satish laid out very clearly. So,
see, I am widening the lateral lip of the eustachian tube.
Yeah.
My direction of drilling is medial to lateral. See, open up the eustachian tube.
Yeah. keeping in mind that the carotid is just medial to it.
I will show you where the carotid is as we are going to remove the pericarotid hair cells.
Yeah.
See in the medial wall. I am now in the medial wall.
Skeletonize the TM joint completely. Remove the bone.
Not really, not really. That is not our aim.
Okay.
No, not the TM joint, but he's removed the skin completely.
Uncovered the eustachian tube, widened, thoroughly widened.
Yeah.
Yes, Satish, you can see it. So I always, Satish, I always tell my...
My burr is on the lateral wall. Removing the lateral wall of the eustachian tube completely. See this?
Right.
Lateral wall completely. Bony eustachian tube has to completely go.
Satish, I always tell my residents, that a good otologist is somebody who can take a foreign body from the nose through the ear.
See this? Eustachian tube opening. Forceps,
Yes, we can see it very well. Yeah.
So widened. What a forceps there. What कर रहा है? हिला मत इतना यार. बोल के कर. अब मत हिलाना.
Yeah, so the mucosa from the... Yeah.
Bipolar. कर. This TM joint is lateral to the eustachian tube. See this?
Right. You can see that, yes.
And we are not violating the TM joint capsule unnecessarily.
Yeah.
See the medial wall? That is the lateral wall of the eustachian tube. Ruk rahe yaar. Can you see?
Yes.
Yeah, we can see it very well. Yeah, very well.
See all this mucosa. Now, retractor. यो पकड़ यो रख यो रखिए इसको कैन यू सी द अरे हाथ तो हटा अरे यार पेटवा 2 मिनट इधर
We can see the bone. Yes. Eustachian tube still.
Yeah, we can see that well, and we can also see the area of the carotid.
Carotid is medial to here.
Medial to it, yes.
I'm working on the lateral wall.
The canal for the tensor is what you are basically following.
दूसरा section दे. Quick. See, I am superior to the eustachian tube.
Yeah.
That is tensor tympani canal.
Yeah.
Yeah. Semi-canal for tensor tympani.
Why don't you use that irrigation drill as an osteodoc?
Yeah. What?
That drill which comes with the irrigation, which is what we all use.
Yeah.
Why you don't use that?
You can use that.
It will make your assistant's life easier.
Assistant will become useless then.
You will find some use for him or her.
See this. See the lateral wall of the eustachian tube.
Very nicely.
Yeah. We can see it nicely. You open it up nicely.
Honestly, I didn't know subtotal petrosome you had to drill so much of the eustachian tube. I used to.
This is the first problem.
Yes.
But that's why I told you the exact proper execution of subtotal petrodectomy. Otherwise, this will become the source of infection later on.
Mohan Satish might as well inspect the nose now if there's a foreign body there.
I think you can see that.
He's just about there.
Game elevator. See now, let me tell you the course of the carotid artery, and I have gone. My limit is to go anterior to the carotid artery.
Yeah. We can see that very well actually. You outlined it.
This is cochlea here.
Yeah, and that's the carotid.
Is here. See the carotid.
Yeah, we can see the color also, the bluish color there.
Yes.
Yeah.
And this is all the bony tube ending. I can feel the cartilage of the Eustachian tube now.
Yeah.
That's the cartilage.
Yeah.
The bony
For-
Eustachian tube is 1 centimeter or 10 to 12 millimeter. The cartilaginous is double.
24, 24 and 12. So you can see the bone over the carotid. It's very thin bone. It's very easily can be, eaten away in cholestoma.
So I have reached the level of the cartilaginous tube. I can feel the cartilage.
You can see that, yes. You can see that.
Drill. So now with no bone left, no bony, track are left to communicate with the Eustachian tube. Got my point?
Yes.
Yeah. Yes.
That's the bottom line.
You can see it very well now. Incidentally, the carotid in this place is very thin walled. It's not like the carotid in the neck.
Yeah.
So it's very thin walled. And the reason is, of course, that it's well protected by bone. In the neck, there's no protection. So the wall has to be thick. Here, there's a bony canal. So the wall is like almost like a vein, very thin.
See, these are pericarotid hair cells.
Yeah, you can see that.
Now, this is cartilaginous Eustachian tube. See the Eustachian tube cartilage. Now, this is all cartilage, no bone left behind. That's the lateral wall only, which is allowed us to drill. See now? Everywhere.
Yes.
Now, give me bipolar. See the prominent carotid artery. This is carotid, this one.
Yeah, we can see the color very clearly.
Now, carotid is in the center of the field. We have gone far anterior to the carotid. See?
Yes.
Yeah.
See, the carotid is here and we have gone far there. Cauterize everything. Don't leave any mucosa. Cauterize everything. Carpet cauterization.
To devitalize whatever is.
Yeah, bipolarize. See this? Drill. I told you skeletonization is the key. See this bone over the carotid, I am skeletonizing. This is anterior to the carotid in the infratemporal fossa. See the carotid very clear to everybody?
Yes, Satish, it's seen very well.
Beautifully seen.
Now, lastly, the more important area, hypotympanum and retrotympanum.
Yeah.
For this. Now see the hypotympanum.
Skeletonized the jugular bulb and.
Yeah. This is all hypotympanic clearance. Fortunately, in this patient, because of the chronic infection, the hypotympanum is not very pneumatized.
Yeah, sclerotic, very sclerotic.
Point all.
Irrigation.
That's the carotid artery. This is the jugular bulb.
Yeah.
That's the jugular bulb. Now, coming to the retrotympanum. Key area and the facial nerve. See the facial nerve, the horizontal?
Yeah, and you can see
This is the bone anterior to the facial nerve.
This is very important. The removal of this bone is the only way you're going to expose the windows clearly.
Any complicated anatomy for cochlear implant, rotation of cochlea, rotation of canal wall, anything you are finding difficulty, subtotal petrojectomy is the answer. It opens up like a book.
Yeah.
See now, my round window is here. It is opened like a book. Now the implantation will be child's play.
very clearly seen. This is a very crucial step, removal of the bone anterior to the facial canal, thinning it out. The more you expose, the more bone you remove, the more you expose the round window area.
See this, this is all anterior thinning of the facial canal. It's all anterior thinnings.
Yeah, very nicely seen. Yes.
Remember the word skeletonization. This is jugular bulb where I am running. This is the last part and then our implant process will start.
And Dr. Satish.
Satish, Naresh Panda is here. Who's Naresh
Hello,
Panda
sir.
from BJ?
Hello, sir.
Hello, Dr. Satish. Wonderful demonstration. Yeah, good. Very nice. I just wanted to ask you, I mean, like, would you like to remove a little bit more of the tympanic bone? Because in order to expose the jugular foramen well,
Yes, sir.
you
Yes,
need to
sir.
remove a little bit more of the tympanic bone. Would you like to remove that one?
Absolutely, sir.
Yeah, that one. Yeah.
Our goal actually is not to remove the tympanic bone. Goal is to skeletonize the jugular bulb. Goal is to accentuate all the hidden cells here.
Correct.
So that's why I am using this word again and again, skeletonization. And tympanic bone, since being lateral to the jugular bulb, you can leave the cells underneath. I will not leave any cell, possible cell inside. Fortunately, out of all parts of the 4 parts of the tympanic bone, temporal bone, tympanic bone per se is never pneumatized.
Yes. So therefore, it's not
correct.
mandatory. There's no mucosa there.
Correct.
Has anybody had a chance to do a cochlear implant in an atresia case?
Yes,
I have done quite a few.
Why not?
Quite a few, actually.
There also you would need to do a subtotal vitrectomy, no?
Yeah.
Not necessary.
Because
It depends upon the anatomy, Ashish.
Yeah.
Absolutely.
But by and large, I think everything is too crowded down there.
Anyway, if you have an atresia, then that's almost half the job done.
See, if somebody asks me in cholecystoma case that you can leave the skin behind, believe me, with this exposure and everything, leaving the skin behind is least of the possibility. The challenge is leaving the cells and mucosa behind.
Yes, that's right.
That is what we are tracing. So that's a pure theoretical question of no value. One cannot leave the cholecystoma with this kind of exposure. This is much bigger an exposure than a canal down mastectomy.
Yeah. Thank you for leaving the facial nerve behind. Thank you.
See the retrotympanum unfolded.
Yeah, you can see it very nicely.
I'm opening up the retrotympanum like anything.
So this is the important thing, the important step, the crucial step. Removing the bone in front of the facial is the crucial step. The more bone you remove, more exposed.
This is called anterior thinning of the facial now.
Most people remove the bone lateral to the facial, but leave the bone in front of the facial. But this is important. Yeah. More anteriorly you take out, the more you expose the round window and the whole window and the sinus tympani region. And for the implant, to really have a much better more or less the same. More or less the same.
See the cavity coming in shape?
Yeah, very nicely. Very nice.
Skeletonization.
Very nice. The labyrinthine block is organized. Everything is nicely seen.
See this. This is sinus tympani mucosa, which I am removing manually. Intact.
Yeah. Yeah.
Give me the
Stiffy suprastructure you removed?
Feinberg. What?
Stiffy suprastructure you removed already?
Already gone in the cholesteatoma.
Gone in the, okay.
Sapli bilkul. Now, I am working around this retrotympanum, around the round window area. I love this Ben air. What a drilling.
Sorry, say it again.
See this?
Yeah.
This is round window region.
Yeah, I can see that.
Satish and Mohan and Dr. Naresh Panda. If at all, I mean, because I do atresia cases and I have many times the oval window where the facial is running over it. Which would be the location to do a promontoral window, Satish? Do you mind showing, just pointing out?
Promontoral window for what?
In atresia cases, when the facial is running over the foot plate, if you can't make, yeah.
Okay, for fenestration of the promontory.
Yeah.
Yeah. You have a lot of space. You'll still be able to see it very quite clearly. It's never a situation where you.
I am removing, uncovering the round window niche region.
Yeah.
Yeah, you're removing the superior lip of the round window, the operculum, so that you can see the membrane now. You can actually start to see the membrane.
Sir, in some cases, you have a large infracochlear tunnel. So we need to trace it out also and then clear it.
Not really.
Not
Do
really.
you mind increasing the magnification?
You're more worried about the upper lip of the round window.
Do you mind increasing the magnification a little bit?
Trace it.
You want me to increase?
Little bit, yeah.
Okay.
Yeah, okay, fine.
Yeah, you can see it nicely. You can start to see the membrane coming up, and you can see a fibrous layer on top of it. This is very typical of round window. Round window always has a pseudo membrane, a false membrane on top. You can see it very nicely. Yeah, that's it. He's depicting it out clearly.
What's it?
Dr. Naresh has actually got a publication on the, the grades of round window, which is very, very well recognized internationally. So that upper lip, the upper lip which is taking out, operculum, is very important to that, so that you expose the round window membrane. Would you say this is a grade 2 or 3? Yeah.
And one more thing, particularly, I mean, I don't know about the history. You said it's a cholesteatoma case. And when you have a chronic COM, long-standing COM, there is sometimes, the basal turn there, you may have some ossification. So you may have to little bit drill more compared to the other. But
Yes.
I think CT scan will give you an idea.
That's what
if there was.
yes, you're right, sir. We confirmed earlier on
Right.
our scans.
Right.
See now the round window there.
Yeah, we can.
We can see the membrane very well now.
See, this is all infracochlear tunnel. This was infracochlear tunnel, which I marsupialized, opened up. Dhire dhire, yeah. Number dull.
Here you have to be careful, Dr. Satish. For the youngsters, when you're drilling the inferior part, particularly, the inferior cochlear vein sometimes come and then you will have continuous bleeding. So
Yes.
one has to be really careful when you're drilling the inferior
Let me
lip.
tell you exactly for everybody where does the inferior cochlear vein comes and what is the location of cochlear aqueduct. See, both these things are inside the window membrane. Number one. In the median wall of the round window. See, all this mucosa I am removing. See, this is round window niche.
Yes, yes, we can.
Yeah. एक पेन कागज भी लेके आना. Once you see the round window niche and go inside the round window, never ever drill on the medial wall. Very close to the round window in the medial wall are two important canals. One is for the cochlear aqueduct and the other one is for cochlear vein, inferior cochlear veins. Yeah. Drill. See, because of the in a regular situation, the round window appears like a blue membrane. You know?
Yeah, but here is a lot of loss of newborn formation.
Yeah, because of the inflammation.
Yes. And you have to expose it to make sure there's no cholestoma or no
No,
epithelium
cholestoma
inside.
is no more an issue here. Here there is no cholestoma.
Yeah, and the epithelium or mucosa, anything, you don't want it.
No cholestoma, epithelium, mucosa. It's absolutely clear.
Yeah. It is.
Can you see the lumen?
Yeah, we can see it. Yes.
Let me in a minute's time. Oh, steroid enough. Yes. That's a cochlear tunnel. Can you see?
Yeah, we can see that.
What I always do to make it a straight one,
You're taking out the.
I remove the inferior edge.
Yeah.
See this now. Wash, steroid.
Yeah.
I'll give it a steroid wash. Patla de.
You can see the scala now very well.
Yeah,
There's always a small bend there. This is what he's doing. He's extending it inferiorly so that it makes it straight.
Long axis of the scala tympani.
Yeah,
See
you
the
can see
long
that.
axis of scala tympani?
Very well, yes.
See where the implant is going to go? Can you see very clear?
Yeah, sir. You can see very.
So now implanting in this will be a cakewalk. See this?
Yes.
See the scala inside. This is I am washing with the steroid. Okay? Now leave some gel foam. I am leaving some gel foam here, soaked in steroid for a couple of minutes until we make the well. Okay?
Right.
Yes, this gel foam soaked in Steroid. See this? Got this, no? So now our area is ready to be implanted. Only thing we have to do some exercise of making the well. Hello?
Yeah, yes, sir.
So now that's a mechanical job. What I will do meantime, see, yes. So meantime, my associate Dr. Ananya and the team will make the, base for the implant. This will drill the base for the implant and make the tie down holes, make the gutter, keep the things ready. This is a 10 minutes mechanical job that is left, and then finally we'll implant. So now implantation will be, you have the straight tunnel.
Yeah, it's very
tunnel
easy.
in the long axis of scala tympani.
Yeah,
You just have to push implant in the length.
absolutely. It's very easy.
Tunnel. Why it is a straight tunnel? If you go through the round window, straight, it will hit the modulus. Removing the
True.
inferior wall of the round window made the anterior inferior tunnel very straight to you. It's a three-dimensional tunnel now. You just have to push the implant. That's a child's play. So just 10 minutes. Meantime, they make this thing. Drill the base. I will take you to a small this 10-minute discussion on subtotal petrojectomy through my presentation. Just 10 minutes. Meantime, they just हो जाए मेरे को बता देना. Hello. Hello.
Yeah.
So we are not showing this drilling of the gutter base
Yeah, it's
and all
okay.
that thing.
That's okay.
Meantime, I'll just apprise you with some of the important aspects of this subtotal petrojectomy implantation. You have seen the basic technique now. You have seen the basic technique now, sir?
Yes, Satish is very clear.
Oh. So this science of subtotal petrojectomy has amazing indications to rehabilitate all those difficult, poor, unfortunate patients which cannot be rehabilitated by regular implantation because of the reasons. So there are certain indications. Just in 10 minutes, I'll summarize. Meantime, they drill the base. क्या हुआ यार? Yes, I think it will come. At the time. What happened? One laptop, है ना? आ सकते? हाँ? नहीं आ रहा नहीं. दूसरा लैपटॉप पावर पॉइंट लैपटॉप. Hello, sir.
Yes, Dr. Satish.
Yes, so that is the picture after the drilling.
Yes, we can see
The bed
that.
is
Very
ready.
clear.
Now we are all placement of the implant.
Yes.
This is the time to see if any bleeder. Remove wound. If any consultation is needed, we can carry out. And we ultimately after this, before entering the implant, switch the cautery. Was there. Implant. Huh? Madam. Madam. Plant. उठा लो आया 2 मिनट उठा एक लगा के दो आरसी चलो जो नोट लगा मेरे टाइम मिलेगी और कहाँ हेलो
Hello. Yes.
This is regarding fixation. So what we are doing, we have made a tie down holes and this will be figure of 8 fixation. This migration of the implant is a disaster. There are many ways to do the same thing. But this what we find is a very secure way. The implant should not migrate.
Correct.
The last part will be last 1 minute will be cakewalk. I told you. Non tooth there. So just on tooth. Threads. I don't want them to come to skin. They can poke into the skin and invert. First is invert them into and surgery cell to invite fibrosis there. They will not
Yeah, that's a very important step for the benefit of the young surgeons, that the prolines you just use to secure this receiver stimulator unit should not be protruding, because if it protrudes, long term it may just pierce through the skin and appear in front. So it has to be ensured that it is facing downwards into the holes.
Now see, we have a straight tunnel. See the straight tunnel. Patla, patla. Forceps. Yes. We have a tunnel. See this tunnel. This is superiorly skeleton. In the inferior tunnel, right into the tunnel, so easily without any obstruction. This is what we want. That's it. The entire electrode array is in periosteum. Can you see? Hello?
Yeah, we can.
This was the
We
simplest of all steps.
I think Dr. Satish, I think few electrodes will go in more, two or
No,
three
no,
are
there are
still
no
there.
electrode. No electrode. Right, sir. See this. All electrodes in, sir. Hello, sir. Hello?
Hello, yes.
Yeah, all electrodes are in. This is the outside cable. Now I will patla this scissors. Seal this opening with a periosteum. इसको ये रख, इसको ये रखो। कहाँ गया? वो दे पिक बंद है यार। वो दे, वो दे। Wrapped around the electrode array, can you see?
Yes.
Or snugly at the bone. This is snugly occluding the bone. See this. Not be displaced now. Me small pieces of fat. Now obliterating one by one. Chota de, chota. All size. Scissors. Pakad. Chota de. This is my obliteration of the Eustachian tube. Since we have reached the cartilaginous tube, so it is so easier now to block it. See this? Never a challenge. Once you drill away the bony Eustachian tube, hardly any challenge. बना देते तो ये छोड़ गया यार बड़ा दे नहीं छोड़ा दे scissors give me scissors Yes. Now I will use a big piece to cover up everything. This fat I have soaked in rifampicin to prevent airborne infection and autolysis. It works very well. Rifampicin is one of the best antibiotics against the airborne Staph aureus infections. See this, everything has been, can you see?
Yes.
Now our flap will come back. Yes. We have a flap which is going to cover everything. See this? We'll suture the flap, we'll remove all this. We have a good, undermining. So we'll cover this completely. Now we'll do NRT. Okay, quick, Lado. Gloves there. Gloves. See, the implantation was the easiest of all the steps. Could you see? With this kind of exposure, there was hardly any challenge. You you have the cochlear tunnel in front of you. Connected or not? Madam, bolo. Connected? Huh? External camera. उसको बोलना external camera लिया. This was threshold. Hello. So impedance is good. Hello.
Yes, Dr. Satish.
So NRT being taken. Any questions meantime? Or we move on to the next case?
Okay, I mean, like if you have an external camera, if you can see the NRT.
Okay, I'll organize because this is another case. So let them take. This was all about this particular situation of cholesteatoma with subtotal petrojecmin implantation.
Thank you, Dr. Satish, for a wonderful demonstration.
Thank you, sir. Thank you for your valuable time. Let them take NRT. Meantime, hello.
Yes, Dr. Satish.
Yeah. So our next case is a interesting case of JNA. That's a very interesting situation. Either connect karna.
Next case is angiofibroma. I will request Dr. Amit Kestri and Dr. Manzoor Lattu to kindly moderate the surgery.
Hello.
Hello. Hello. Hello, Dr. Satish.
Yes. Hello.
Hello, Dr. Satish, Dr. Manzoor from the auditorium here.
Yes, sir.
Can you kindly brief us about the patient and his radiology also?
Just a minute, just a minute.
Okay, sir, we'll be waiting.
Hello. Hello. Hello.
Hello. Hello, sir. Good afternoon.
Yes.
This is Dr. Amit Kesri, this side, sir.
Hi, Amit. How are you?
I am fine, sir. We saw the very beautiful subtotal petrosectomy with cochlear implant, and now we are ready to watch the next treat of JNA with.
Great. So, are you getting any picture there on screen?
Yes, yes, yes.
So, you can imagine this is a child, 12-year-old child
Yes, sir.
with classical history of nasal blockage and intermittent bleeding. And you can see this enhancing mass lesion. If I come from
Yes, sir.
anteriorly, look at the maxillary sinus, all good. And behind the maxillary sinus, all classical extensions. Can you see?
Yes, sir, yes.
This is
ITF,
the
pterygopalatine, ITF.
arising in this pterygoid vein, going in the nasopharynx like a cricket ball, ascending in the sphenoid sinus through the
Sphenoid
floor.
sinus.
Through the floor. See this? This is ascending in the sphenoid sinus from here.
Yes. And eroding plenum also.
Elevating the posterior ethmoidal dura.
Plenum. Yes.
You can see and see lateral extension through the pterygopalatine fossa, in the infratemporal fossa.
And superior orbital fissure.
This is inferior orbital fissure. This is pterygoid process in the pterygoid fossa. This is in the pterygoid fossa. Then as you go behind, this is in the superior orbital fissure.
Yeah, superior orbital fissure. Going to the cavernous sinus,
And
paracavernous.
superior orbital fissure is a continuation of cavernous sinus. That's the cavernous carotid.
Yes, sir.
So that is in the cavernous sinus. If I put my axials, see this. This is the carotid in the parapharyngeal space. This is the horizontal. This is the carotid at the foramen lacerum. See this. This is pushing the posterior wall of the maxilla anterior.
Yes,
See
the whole one below.
the maxilla is there. Posterior wall of the maxilla level here, and see the posterior wall of the maxilla level there. Can you see?
Yes. Yes. Yes.
This is pushing and going in the infratemporal fossa. Classic Hallman-Miller sign.
Yes, sir.
Very clear?
Yes. Yes.
Then see
Going to the other side also, sir.
how it is coming from inferior to the superior orbital fissure and then in continuity towards the cavernous carotid. Can you see?
Sinus. Yes. Yes.
That's the cavernous carotid, anterior band. And this is how it is coming through the orbital fissures into the cavernous sinus. But see, this tumor expands everywhere. Primary tumor doesn't actually invade. So you have to understand the philosophy and pull it out the same way it goes. What my point?
Sir, what is the difference if this is a 12-year child and if it had been 16, 17 years? So when you are looking at the children below maybe 11, 12 years, so what put extra challenges from the 17, 18-year-old?
Yeah,
Especially,
see, as the age grows, the lesion becomes more and more fibrotic
fibrous. Yes.
as compared to the younger children. Now see, this is diffusion weighted to rule out any other malignancy or any other lesion. No restriction, bright, means there is a lot of
Yes.
fluid in the tumor rather than
Tumor.
malignancy, which would show otherwise diffusion restriction. Many a time patient referred to as nasopharyngeal mass as angiofibroma and diffusion shows huge restriction, turned out to many a time rhabdomyosarcoma, lymphoma,
Rhabdomyosarcoma.
malignant tumor.
Yes.
So the diffusion is very, very important investigation. Then comes the, this is this is T2 weighted. T2 weighted has a value in defining the relationship with the carotid artery. See this. This is contrast.
Yes.
This is T2. T2 weighted. See, there is a enhancing. T2 is where the fluid is enhancing, inflammation is enhancing. See, all around the carotid artery, this tumor and the carotid has a distinct separation. Can you see?
Yes. Yes. There is a plane.
There is
Fat
a plane. See, what is this tumor coming into the cavernous sinus? Has a plane of separation from the carotid artery.
Yes.
Which sequence can show better than this? No one.
No.
This is simply amazing. This is pure fat suppressed T2 weighted imaging which distinctly identifies whether it is truly invading or there is a plane of separation. The contrast will never define so easily as compared to this sequence. See this? Very, very clear. Here in the sphenoid, the tumor is away from the carotid. See, the carotid is here. And here in the cavernous sinus, there is a distinct separation of tumor from the carotid. I hope it is very clear.
Yes. Clear, sir.
Now, another important value of fat suppressed imaging. See this. This tumor has a tendency to recur, so-called recurrence. It is never recurrence. It is a tumor which is left behind and regrows. And where commonly it is left behind, it invades the, the cellularity of the bone. It invades the Haversian system of the bone. And see here, what is this? This is pterygoid
Inside
process.
the pterygoid.
Now see, on the opposite side, see this is fat suppressed. Let me show you. This is very, very important, sequence. Let me tell you, this is a regular T2 weighted MRI on this side and a fat suppressed MRI on this side. Fat is suppressed.
Fat.
Now see, this is pterygoid process where there is fat. Can you see?
Yes. Yes.
And that marrow fat is suppressed in the fat suppressed imaging. Got my point?
Yes.
What happened on the other side? What happened on the other side? Whereas, unlike this, where is the marrow gone? That marrow is replaced by the tumor.
Tumor itself.
That gives you clear-cut idea that this tumor has invaded the pterygoid bone. If you don't
Is it
remove
the
the
Vedian
pterygoid
canal
bone,
where it's invading?
huh?
Is it the Vedian canal where it's invading?
So pterygoid wedge, sir.
Yeah, pterygoid wedge means Vedian canal is involved. This arises
Yes.
in the close vicinity of the Vedian canal. So what does it mean? If the pterygoid marrow is absent, means tumor is invaded. And if you ignore
Inside
this
the
fact,
marrow.
if you ignore this fact and don't drill away the pterygoid, it is bound to recur. And that is the commonest cause of so-called recurrence. People see pterygoid process from outside looking normal and the marrow is infiltrated inside. What my point?
Yes.
So
Yes,
this,
yes.
this T2 weighted fat suppressed imaging picks up so easily, so clearly. See this, how this tumor is coming in the infratemporal fossa. See this, how this is invading the pterygoid, the greater wing of sphenoid here, and how it is ascending into the inferior superior orbital picture.
Yes, sir.
All these classical extensions make this tumor unique one in terms of diagnosis by radiological means, because we don't take biopsy because of propensity to bleed.
Bleeding.
So because of its classical extensions, this is diagnosed on radiology without the need of histopathology.
Also, sir, when the child is very small, the allowable blood loss, we have to keep in mind. So when we do children 12, 10, 11 years old, we try to reserve more blood, especially for these tumors who have the skull base extension, sometimes they bleed. So as compared to 7, 18 year where there is allowable blood loss is more, so you can do with reserving 2 units. Sometime for skull base extension, you need more blood, especially in young children.
Yes. So young children with blood loss, with less blood volume, have give unique challenges, and you have to be very careful in dealing with them in terms of blood loss. And now there are many techniques to, deal with that kind of blood loss with the help of anesthesiologist, and that's what we also do. So in this, as compared to the sinus surgery, the bleeding is pure arterial. Here, hypotensive anesthesia has a big role. We load the patient with almost a liter of, fluid, starch, whatever. So whatever blood is lost is diluted one.
Exactly.
And it maintains the pressure as well. So you don't transfuse in the beginning and allowing the diluted blood to go off. Then intraoperatively, coagulator is the key to deal with the blood loss, to
Yes,
minimize
mucosal and
to
all
the
small
surface coagulation to deal with that, minimize the bleeding. But bleeding is maximum on the surface rather than on the periphery. So our goal in this case is very clear. Now, let me tell you, we will go by the Danker's approach. See, this Danker's approach is what?
Yes.
Let me show you like
Yes.
this. I will remove this medial wall, as well as part of the anterolateral wall like this here.
And part of septum also.
Remove this anterior wall, open maxilla, remove posterior wall, and the tumor will be there. And then we'll catch the maxillary artery. Okay?
Yes.
At this point, I will divide the tumor here at the lateral wall of maxilla. See here?
Pterygoides.
And remove the medial part first. And open up the nasal space for the lateral part to bring in the nasal cavity. That will give us a space for the lateral part to deliver in the nasal cavity. Got my point?
Right.
So we'll put the nasal part. So first part will be this Danker's exposure, modified Danker's, and catch the vessel.
Sir, won't a hemorrhage be a concern that time once you separate it into 2 parts?
Pardon?
Won't hemorrhage be a concern that time a problem once you divide this tumor?
That's why I told you, after this exposure, we'll catch the feeding vessel. The main feeding vessel is internal
Maxillary artery, which is there.
And then...
What about the venous sinusitis which will be bleeding?
Pardon?
What about the venous sinusitis which will be bleeding?
Venous sinusitis?
Yes.
Venous sinusitis bleed, and that you can't help by means of, either packing or whatever you do. Now, another important investigation you must keep in mind for all JNS, we always do, is this CT angiogram. This gives us clear idea about lot many things. Let me tell you one by one. First of all, see, this is my external carotid. See where my cursor is. Following
Yes,
the
yes.
external carotid. See where my external carotid is.
Yes, yes.
Following the external carotid, internal carotid. This is internal carotid. This is external carotid. Internal jugular vein. And this is external carotid. See this. This is leaving this facial artery. This is giving lingual, superior thyroid. See where my cursor is?
Yes, yes.
External carotid. Now behind the mandible is dividing into two. See, dividing into two. This is superficial
Yes,
temporal,
yes.
and this
And
is
this is
maxillary.
maxillary.
Now see where my cursor is, following the maxillary and going in
Yes,
the
yes.
see, this is tumor.
Tumor, yes.
See this, where is the maxillary artery? Here. Now
Yes.
let me reconstruct.
So it is antero-inferior to the tumor in the posterior maxillary wall.
Yeah, I will reconstruct and show you. See, this is maxillary artery. I will bring my cursor here, and this maxillary is here now. See this,
Yes.
where the cross edge is. This is maxillary artery.
Yes, yes.
This is maxillary. See the level of maxillary.
Yes. Yes. So it is
I have to catch
antero-inferior
my
to the tumor in the posterior wall of the
I
maxillary.
have to catch my maxillary artery at this level. See this level?
Yes.
And this level is roughly from the hard palate around 1.6 centimeter. See this? From
Yes.
the level of the hard palate, my artery is 1.6 centimeter high. Can you see?
Yes.
There I will catch my vessel. This is the site where my vessel is going to be. Now, in relation to the tumor, in all planes, how this vessel is? Let me pick up again. Let me pick up, reconstruct. See, you have to see in all planes. This will give you complete insight into this vessel. See, we are going to catch this vessel over here. Now see in the anteroposterior plane, in the sagittal plane. See this?
So
Can you see
exactly in the posterior wall on the antero-inferior surface.
See, just behind the posterior wall. Can you see?
Yes.
Hello?
Yes,
This
yes,
is
yes.
where when you open the posterior wall of maxilla, open the periosteum, this vessel is right there. And this is the level where we are going to open up. So this is 1.6 centimeter above the level of the palate.
Palate.
This is what we are going to catch. Number one, this is vital information. Secondly, what we see, all other branches of external carotid, if they are supplying the, see this, one of the branch from the,
Ascending pharyngeal.
they are giving from behind, that you cannot catch. That
Yes.
means you have to anticipate little bleeding from behind. That is behind the tumor, you cannot catch before. Okay? Third is the carotid. Most important in the
Carotid.
sphenoid. See the carotid artery
The
in the
median and-
sphenoid sinus. See this?
Yes.
MRI doesn't pick up bone. You cannot say on the basis of MRI whether the bone is eroded or not, whether the carotid is surrounded by bone or not. Now see here. See here.
Yes.
All the time carotid is surrounded by bone. See this?
Yes, yes.
See this?
Can we identify the median artery here, sir?
Yeah, median artery you can identify lower down. Yeah, this is median artery.
Yes.
This is the level of foramen lacerum.
Yes.
So now, what you see, this carotid is covered by the bone all around. See this here. This is
Yes,
very, very
yes.
important to know. Lastly, and not least, the most important thing about the cross flow. Regarding the cross flow, see now. See this course of carotid here, parapharyngeal. Can you
Yes.
see? Follow.
Follow, yes.
in the temporal bone, what you saw just
Petrous,
now in the
yes.
last case, this is horizontal petrous carotid.
Yes.
Rising up, this is cavernous
And
carotid.
lateral.
See everywhere
Lateral
the
and
bone.
then
See everywhere is the bone. Can you see the plane which is separated? This is vessel
yes, yes, very
separated
well
by
seen.
the plane. Everywhere it is separated by the plane. Can you see?
But it will definitely have some feeder from the inferior lateral trunk and median
Now
trunk. sir.
Now see, the carotid is dividing into two branches. The middle cerebral, anterior cerebral. Can
Yes,
you see
Reverend
both sides?
ACA.
And see this both anterior cerebral forming anterior communicating. Can you
A
see?
comma.
Similarly, this is middle cerebral. Okay? And
Yes.
if you go behind, see this, let me show you. Behind. This
Vertebral
is
and
vertebrals forming
yes,
basilar. See
forming
this
the
basilar
basilar
dividing into two
PCOM.
posterior cerebral.
PCOM.
And see these PCOM giving rise to communicating. This is communicating branch here going to the middle cerebral. See this here.
Making circular
Posterior
village.
communicating.
Yes,
See this
yes.
posterior communicating. See this is the branch. This is posterior cerebral. Keep an eye. Here it is communicating branch. See where my cursor is.
Yes, sir. Yes.
See where this communicating branch is going. See this. Going to the middle cerebral. Can you see?
Middle cerebral. Yes.
That means has a good cross flow as well. Both anterior and posterior circulations are intact.
Intact.
See this carotid in the cavernous sinus. See it is well surrounded by the periosteum everywhere. See this. And this bone is involved below.
So there is, we can also see the enhancing tumor
this is
lateral
the
to the carotid in the
pterygoid
yes.
process which is eroded. That is the
Yes,
great wing of the sphenoid which is eroded. Radiology gives you amazing, insight about the details or the surgically relevant information which are required.
A good radiology is 1/3 the surgery done, sir.
Pardon?
If you read the radiology well, 1/3 of your surgery is already done.
Yes. So it has to be dynamic, full information by means of MRI and CT angiogram before you deal with such, vascular tumors.
So, suppose sir, if there is no intracranial and intraorbital extension or in any fissure, only in the paranasal sinuses, then also you will recommend an MRI, or will you go ahead with CT angio?
Only MRI only when it invades the skull base.
Right. Perfect, sir.
Once it invades the skull base, then only.
Only.
Correct.
Yes, sir. The patient ready, sir?
वो लगा दिया लगा दिया हाँ चलो आ जाओ और लगा दे आ जाओ
Sir, sometime while using coblation to decrease the anterior path of the tumor or to make it less vascular, even in coagulation mode, sometimes some vessels open up. So what is your tip to avoid that?
Pardon, can you repeat?
Sir, actually, sometime when we use even the coagulation mode on the surface of the tumor, it starts to bleed sometimes.
Yeah.
So how do you, any tips to prevent that from happening?
It happens. I will show intraoperatively.
Yes.
Use always coagulation mode, not ablation.
Yes, yes.
Ablation is dangerous.
So do you anytime believe in embolization preoperatively?
Not really.
Sir does not.
Pardon?
Unless your regular blood supply is violated by means of previous surgery, or you have some extensive feeders coming from behind, abnormal feeders like middle meningeal, major ascending pharyngeal feeder, which you cannot control before removing the tumor. Then only.
So actually, sir, there are a few vessels which cannot be controlled. Like if there is an anterior cheek extension, there is sometimes branches from facial artery. Ascending pharyngeal, if the tumor is going too much into the nasopharynx and oropharynx, then bilateral ascending pharynx. These all cannot be dealt by this. And if, as sir said, that if there is a recurrence tumor, then entire pattern changes.
Order the angiogram.
Yes. So on the angiogram, you can decide about if you want to do embolization or not. We tend to embolize if anything it is beyond 3 to it's like 1 or 2 usually, because we have the facility.
In my practice, I embolize less than 5% cases.
Yes, I know, sir.
Embolization is not risk-free, not problem-free. Either le lo.
Yes. And there are some limitations. They cannot embolize the branches of ICA. And
ICA branches cannot be embolized.
Nice.
Venous bleeding cannot be embolized.
Yes.
What all you can embolize are the external carotid feeders. Most of the time, the principal vessel is internal maxillary. That you can control, before.
And sir, there are also blood supply from contralateral side sometimes.
Yeah, that's why nasopharynx show you. While reaching to the nasopharynx, we cut off the contralateral blood supply. Whenever it is attached in the midline, anywhere, the contralateral blood supply may come. Maybe attachment to the septum or attachment to the
nasopharynx and oropharynx.
Live picture. So after
So
this
you will
case
also do a septectomy here, sir?
Pardon?
Septectomy, posterior septectomy.
We'll expect.
So we can see the tumor with. Yes, we can see the tumor with leach of blood vessels over the tumor. Inferior and middle turbinate.
Sir, any pre-op precautions you have taken, pre-op workup you have done besides this radiology? Before
We have
surgery?
given antibiotics, steroids for 3-4 days, only 5 days to this patient to reduce the inflammation, to reduce the cause of bleeding.
Okay. So do you also give antibiotics to reduce the infection?
Yes,
Because of stasis,
recommended.
because of stasis of the secretions.
Pardon?
Do you give pre-op antibiotics to reduce infection from stasis of the secretions?
Yeah, because of this such a big lesion, always sinuses are blocked, associated secondary inflammation is there.
Right.
We always give. See the initial picture.
Yes. So for the juniors, never does the tumor touch the tumor before you have done your exposure all around. That is the key. It has to be done.
So the
exposure is the key.
First principle is not to enter into the tumor. See this. What do you mean by surface coagulation?
Yes, sir.
See the
So
intense
start bleeding
vascularity.
sometime. Oh, you are able to handle it. So
See the intense
using coag mode,
vascularity on the surface.
okay.
So you are using coag mode of ablation, coag bladder.
Coagulation, always coagulation.
Sir,
I will
coag is on how much? 5 or 7?
Oh, but I will keep on full.
Full. Okay, right.
नहीं है यार तू कौन है यार गधा है तो
So actually, it's a good thing to do this. If you do not have a coagulation, you can use a bipolar cautery with a wide base on a high current setting. Because suppose if you touch this tumor while doing your procedure, it should not bleed. The idea is that, and also decrease the anteroposterior extension. So if you do this, even if you touch it during your exposure, this does not bleed. Am I correct, sir?
Pardon, can you repeat your question?
Sir, I am saying that the advantage of this surface coagulation on the interior part is that when you are handling the tissues around, even if you touch the tumor, it does not bleed, and also decreases the anteroposterior diameter.
Yeah, this is one big advantage. Secondly, it shrinks the tumor.
Yes.
It opens the space much more.
Especially if there is a lot of interior extension.
It is, see the way it is shrinking the
Yes.
tumor. It gives more space to work around. So wherever you expose the tumor, during the process, whatever tumor is getting exposed, keep coagulating.
The surface.
See this? Now, I told you about anchors you have seen number of times. Quickly, we have one more case after this glomus tympanicum and one more JNA with massive extensions all over, bigger than this. See, I am just coagulating the lateral
The
wall.
interior end of the middle and inferior turbinate.
Yes, staying a centimeter below the level of the axilla.
Yes.
This is all coagulation, not ablation so far. Inferior turbinate, this the separate bone, now in the inferior meatus until flush with the floor and anteriorly coming till the level of the piriform aperture.
Piriform aperture. And exposing it.
Now we have to remove this mucoperiosteum. See this? And now I
Yes.
will ablate.
So we'll be able to see the piriform aperture. Yeah. So the interior and medial wall junction is our concern.
That's the level of the
Interior end.
see the piriform aperture bone.
Also, sometimes the feeling of the bone give you the exact location of the piriform aperture. Yes. Now we can clearly see the piriform aperture. So now we'll expose the interior also.
Yeah. See, this is the bone.
Yeah,
This is the
piriform.
anterolateral wall.
Here. Yes.
Depending upon how much you want to go laterally, you can raise it. There's all anterior superior alveolar neurovascular bundles, severed.
That's the orbital, inferior orbital. And
That is far laterally.
Yes, unlikely.
Unlikely. Later, we are little lateral.
See this?
Yes. Yes. Yes.
Now the second is this medial mucoperiosteum. See what a tool. Only one tool is doing everything.
Yes, of course. Wonderful tool.
This is inferior meatus. Now I'm elevating this. See this?
Bone, inferior trapinate bone.
This is a separate bone. This is the inferior meatus mucoperiosteum, which I've been
Yes, sir.
coagulating and removing. See this?
Yes.
Entire bone is exposed. See this?
Yes, yes.
Your bipolar cannot do this work so fast,
No, sir.
so efficiently, so under vision, without any collateral damage, because it is all the time, irrigated. So this tool is something revolution. That's a separate inferior trapinate bone. See this?
Yes, yes.
Sir, how far will you remove this mucoperiosteum?
Again?
How far will we remove? Given the
Till the
tumor being
posterior wall of
nearby at
maxilla.
level of military.
Till the
Oh,
posterior wall of maxilla.
So the interior 2/3 can be removed, posterior 1/3 will be very close to the
Close to
tumor.
the tumor. That's
That can be removed later under vision.
So till the posterior wall of maxilla, where the
We
sphenopeltine is
can
coming
enter
out.
maxilla also from the inferior meatus if required.
Hello, Satish.
Hello, sir.
I'm back.
Hello.
Satish, I'm back.
Hello. Hello.
Sorry, Satish,
Hello.
I'm driving. I'm driving, Satish.
Oh, Dr. Sethi.
Yes.
Hello, boss.
I was just listening to
you.
No problem.
Arey,
Always a
boss,
pleasure to watch
once
you.
sparing
Always
your-
a pleasure. Always a pleasure to watch you operate, man. No, I had surgery, so I had to leave for a while. You remember that inverting papilloma that I discussed with you?
Yeah, I did today.
Yeah, I just did it. It just came out very nicely, all complete. Frozen section is negative, though. I mean, negative for any malignancy, but we got to wait for the full specimen.
That's great.
Yeah. So
Oh,
let's see.
this was a JNA, sir. I'm doing.
Yes.
This has some good lateral extension as well as going through the orbital fissures into the cavernous sinus.
I'm waiting to watch.
And inverting the pterygoid bone, the greater wing of sphenoid.
For you, it's a walk in the park.
No, it's always a interesting situation.
Yeah.
JNA.
Yeah, GNA.
Can't take it lightly anytime. Now
Yeah.
see, I have exposed the medial wall as well as part of the lateral wall, anterolateral wall. And this is my favorite, Yes,
Hybrid diamond.
yes. So coarse diamond, this stylus 4.5 mm, 15 gauge, and I'm using at a very high speed now. See, now
70,000
first I'll make an opening.
into the maxilla.
Section. ऐसा नहीं करता.
So
एक हाथ से
one can imagine that there are 4 instruments in any nostril, one nostril. So that's the amount of
See, I'm in the
assistance.
maxillary sinus.
Yes.
This is interior of the maxillary sinus section. See the secretions.
Yes. That is why I was telling you have to be pre-op antibiotics.
See, that is the maxillary sinus and that is the bulge in the posterior wall.
Yes. We can all see. So the good part about this drill is that it also does the hemostasis.
Now this opening, I have to flush superiorly with the orbital floor. See now, this opening.
Yes, we can appreciate.
मुझे लगा नहीं है. हाँ. This will
Tracking
go till roof.
with the elevator so well that there is such a wide view.
The beauty is this drill.
Yeah, sir, but the assistance is also important because continuously there is irrigation, the suction is working, the endoscope is there, and somebody is also
Shaft
retracting
is
with
not
a
coming in the way. That's the beauty of 15 degree.
yes. Oh, it's a 15-degree upturn. That's why there's a good view with the endoscope. 0 degrees, it's a problem. So now we can have the glimpse of nasolacrimal duct. Yes.
Yeah, the duct is behind.
Yes.
That
No,
was
no,
the duct. See, here up is the duct. Yes, here up is the duct. See that?
Yes, yes.
That is the duct.
Yes.
So,
You will cut it as high as possible.
I will go around and cut it flush to the computer. Flush to the orbit, the floor. So now, this soft tissue is falling, so cobble it.
Yeah, then it stays in that position.
Yes.
And you will also coagulate the mucosa inside the sinus.
Now, give me the drill. नीचे क्यों? हाँ, चालू रख, सक्शन इधर रख कैविटी में.
This floor removal is very, very important.
This bone removal is important. Otherwise, it will not allow us to
Give you
push our
control over the
instrument in the
pterygoids
depth.
and this drill is amazing, sir. It's cutting like butter.
Such a thick bone it is.
Yes.
After this exposure, our first goal will be to go and catch the vessel.
Actually, yeah.
Yes.
It's 4.5 years.
I could have done quickly with the Gaussian hammer also.
Yes, yes, we have seen it being done by you, sir.
What do you advocate? Drill or a hammer or gauss?
This is more precise.
Okay.
Or you can say more elegant also.
Exactly. More elegant.
That looks so crude.
That looks crude. Outdated.
Even the medial wall is quite thick.
See, more and more medial wall being removed. The nasal cavity and maxillary sinus becoming a common cavity.
Yes.
So we have to remove this medial wall until the posterior wall. See, this
Till
is
the
posterior
attachment
wall.
of the pterygoid.
We have to go
This
till
is the
there.
posterior most part of the inferior turbinate.
Now here is our duct. We have to cut it sharp above. See the duct behind?
This is, yes, yes, yes.
Oh, what I will do, I will flush.
Remove some more bone and then plus, cut it plus.
Drill there.
Yes. This is the best instrument to do this.
Drill, drill, drill. वो reflect करना.
This is the Stowe's 4K or it is the Image 1 HD, sir?
Hello?
This is the Stowe's 4K or Image 1 HD camera system?
Image 1 HD.
Image 1.
See, I am opening this duct.
Yes, sir. Yes, yes.
Yes.
Up above. Also, if you, there are two problems if you cut it below the first is that the chances of epipora and also it comes in your field. So if you go up as interior high as possible, then it's both the things are solved.
See how high I have gone.
Yes, almost the sack level.
See, this is the roof.
Yes.
Yes. There is.
I don't know. I mean, in JNS, we have not faced issues of epipora, but sometime in inverted papilloma, doing Denkers has caused problem. I don't know because the A's problem is there or presbystasis is there. Have you seen that, sir, in your practice?
What happened?
Sir, sometime even after going high up in old age patient, especially when we are doing for inverted papilloma.
Cuttings up. This is my duct now above. See this?
Yes, yes.
There is no more coming in the view, debrider. See now we have a straightforward axis now.
Yes, yes.
This is
Now only the posterior wall is left and mucosal part of the medial wall.
yes.
No, because of the continuous irrigation, the is not being soiled.
Undone. अच्छा भी देगा तुम्हें. पता नहीं है. This is the uncinate process I am removing now.
Yes, yes.
Behind the duct is the uncinate process.
Yes.
Slowly reach towards.
So sometimes the tumors come into the maxilla itself. Every maxilla thing is destroyed. So then also you localize it through the angiography that where is the maxillary artery.
Yes, yes.
The position remains same or it is little different in that cases.
Artery is always anterior to the tumor. Why? This tumor arises from behind.
Behind.
As it grows, it pushes the anteriorly.
Okay. Sir.
So more the tumor, more the artery is pushed anteriorly.
And
So
it
artery,
goes little inferiorly also, sir.
so by and large, artery is always anterior.
Yes. So now we can see the impression of tumor behind intact periosteum of the posterior wall. The bony posterior wall seems to be gone already.
Yeah, all this has to go, all intervening.
Medial wall.
Part of the medial wall. See carefully.
Yeah. Post part will be supplied by the spinoperator.
So why not to use gallbladder there?
See, laterally the maxillary sinus and medially the tumor. This big tumor occupying the nasal cavity.
So now you will cut the middle turbinate or the posterior wall and maxillary artery.
Yeah, a little more expand.
Okay.
See, this is part of the unseen.
Bulla.
And the middle term.
This is
so the lowermost part of the middle turbinate is usually attached to the tumor. So one has to be careful in that area. So you are removing the mucosa of the maxillary sinus.
More bulge from behind. This is part of the turbinate. See this part of the tumor, medial tumor. Basically, all tumor is same in continuity.
Yes, yes.
Debrider.
So won't you use gallbladder there?
Pardon?
Won't you use gallbladder there?
What is?
Gallbladder.
So, sir is saying in place of debrider, why not use a gallbladder?
Here I have to remove the bony partitions.
Okay.
Gallbladder cannot.
So that will give more hemostasis.
No, but the bone will keep on clogging the gallbladder because there are some ethmoid cells.
The gallbladder over the bone, it will ruin.
So sir is doing a kind of enteroethmoidectomy and
lot of tissue septation, bony septations I am removing. Part of the turbinate bone.
Anterior and posterior ethmoid being removed to get exposure to the sphenoid area.
Now, this is, see through and through exposure. This is the tumor which is coming from behind here. See this behind. This is the tumor.
Yes, sir.
In continuity. So now my first goal is to improve the field and then catch the vessel.
For hemostasis and improving the field, the gauge base is the best. In JNA at least. Sir, are you using cold saline or ringer lactate solution for irrigation?
Really?
So what is the solution being used for irrigation? It is a ringer lactate or cold saline?
Ringer.
Ringer. So who is holding the endoscope?
Me.
Oh,
See this now.
okay.
That's the exposure of the posterior wall of the maxilla.
Posterior wall of
See
the
this?
maxilla. Yes, yes.
Now, as the tumor is pushing from behind, bone is getting thinner and thinner.
Yes, yes. Maybe peppery thin bone.
सर ये एक ही तो चीज मांगता हूँ यार क्या प्रॉब्लम है तुम पता है मंगा so as the tumor pushes more and more it becomes makes the bone more and more thinner. See, this is tumor popping out.
Yes, yes.
The mucosa being removed.
Yes, sir. Is the bone there or it has been?
Yeah. Thin bone is there still.
Thin bone is there.
Bone is there. क्या है?
Superior part the bone is.
Yeah, circular type. चल पकड़. This is thin bone.
Yes, yes, yes. Still there. Thin bone.
Thinned out because of the tumor pressure.
We can see the taut vessels behind this. Yes. Always little. I know if you just back laterally and still breathe, you need to have a good control.
And the area from which you have to sum it up there.
See how the
So the good part is that behind the bone we have the healthy periosteum.
Yes.
And after the periosteum, the vessels come usually. So the first layer is vessels, then we have nerves. So the artery comes first, then the veins, and then the all neural structures.
See the periosteum?
Yes, sir. Yes. So as you told that just above the hard palate, 1.6 centimeter above.
Yes, that's the level of the hard palate.
Yes. And maybe I'm seeing the glimpse of maxillary artery.
See,
Here,
this is
yeah.
periosteum.
Yes.
Yeah, to end time to the all progress. This is periosteum. When you see periosteum, पकड़ना. When you see this being elevated,
Yes, yes, yes.
this has opened up the perigopalatine fossa now.
Yes, sir. Subperiosteal space. That's a tumor. Yes. And here should be the vessel.
See the periosteum. See the tumor. What a tool coagulator is.
Yes, yes.
It coagulates the periosteum, coagulates the surface. See, makes the field so good. Yeah. And I can see the vessel now.
Yes, yes. That's the sphenopalatine end. Yeah. Yes. So sometimes the descending palatine artery is also a problem. If someone goes too medially.
That is far medially. That is far medially.
So exactly at the same spot as you saw in the NGO.
Excellent demonstration, sir.
This is my vessel. Give me other one. Loose. Loose.
Yes.
Coagulator.
So you're eating away the medial end.
Dividing.
You have embolized the tumor. That's the pterygopalatine part.
Yeah.
And that's the sphenopalatine vessel, sir? Yeah, that's the sphenopalatine. So you're trying to divide in that area, sir?
I am trying to See the two branches.
Yes. So that's area of the narrow neck.
I am just looking for any other vessel.
Okay, sir.
Medially in the pterygoval and fossa.
Right. Because supply to the tumor from other side, ascending pharyngeal are still intact. So.
You know, the aim was to devascularize it significantly. See this? Now we'll expose the tumor from all around and then divide from here.
So the septum end and the sphenoid end.
All sinus above, medially septum behind, everywhere, and that will free the medial part. Okay. For audience, after this will be glomus tympanicum and then another JNA. See this? Now, the brighter. So this is first goal. Okay. Now coming into the see this tumor is up in the ethmoids. See this?
Yes, sir. You have removed the middle turbinate.
Yeah, middle. See, this tumor has a tendency to take attachment to the middle turbinate,
Yes.
to the nasal septum. It doesn't take attachment in the paranasal sinus mucosa. Later. See the movement? You touch the surface, it bleeds. See this? This is the surface bleed. You were asking Amit what to do. See here, my lateral limit is lamina.
Okay.
I am in cavity.
So supposing it enters sometimes angioplasty enters the eye anteriorly. What will be your approach that time?
Enters the
Eye.
Yeah, it enters the orbital fissures. But it compresses, never invades. You have to same way pull it out. Wash करता रहना यार क्या कर रहा है?
Suppose it presses the lamina papyrus. That time pushing the eye laterally. What will be your approach that time?
Yes, yes. See this tumor?
Yes, we can see.
Rising in the ethmoids. So I am pushing it down and removing. Freeing from upper section there. कुछ नहीं कर रहा. Wash कर. Right, hello. Keep washing, my man. Yes. See this tumor rising
Yes,
up
we
in
can
the
see it. Yes, we can appreciate.
see this.
Yes, we can appreciate.
It doesn't take attachment in the paranasal sinus mucosa.
Okay.
Never.
Niche na?
See, this is the posterior wall.
Yes.
This is ethmoid cavity.
Yes.
Removing this bone. And tumor is ascending there in the inferior orbital fissure. See, this is my lateral wall and this is where I am going to divide later.
Okay.
See the bottleneck?
Yes, we can see.
मतलब this. So we have seen the ethmoid lateral limit. See this all the way.
Yes, we can see it going into the nasopharynx.
So we are defining our boundaries. You know. This is my boundary here. Tumor is rising high up. I told you it is reaching towards the ethmoidal. Ethmoidal roof. Towards the post-ethmoidal roof it is reaching. You have seen on scan.
Yes, we have seen that.
See, this is the surface which is bleeding.
So you are using debrided this time?
Yeah, dividing the paranasal sinus septations.
Okay.
Away from the tumor. See, tumor is there.
Yes.
I am around the tumor.
And which instrument you are using?
Pardon?
Which instrument are you using?
Which instrument? Micro debrider.
Yes. Debrider, okay.
This is all surface oozing. See this?
Yes, we can help. So what coagulator help there, this surface bleeding?
Yes. See, this is in the sphenoid sinus. This big. This big tumor in the sphenoid sinus. See all around?
Yes, yes, we can see.
Coagulator. Now I will use on the surface. Section. See this, what I am doing, I am coagulating
The septum.
the septum there where it takes the blood supply from.
Blood supply.
Yes.
That's what I was telling.
And sir, it is going to the other side also. So some part of septum removal will be prudent to deliver that.
This is so massive, so big.
No, this is a very big JNA, sir. There is the entire sphenoid.
ये block हो गया, coagulator block है. Coagulator block, give me a pack. Coagulator clog. दे दे यार, बड़ा दे. चौधरी, आधे टाइम. In the meantime, you can pack with the ribbon gauze. Open up your instruments again, reorganize, irrigation, and then get back to the same thing again.
Same thing again. Sir, at this point, would you like to go and control the other side blood
Yeah,
vessels?
I will. सीन नहीं आ रहा क्या? क्लैरिटी नहीं है. Wheel control, yeah.
So the endoscope is a little foggy, I guess. Yeah, better now.
Well, same लाना चाहिए था ना. दीवार है ना उसमें वो था.
Yeah, much better.
Better?
Yes, sir, much better now.
See, this is lateral part.
Yes.
This lateral part which you have packed, this is superiorly because of the oozing on the surface. This is the nasopharyngeal component. Above
Yes,
was the
sir.
sphenoidal component. Okay. Now we'll go behind. We have to widen the sphenoid axis as well. From where it has entered into the sphenoid, through the floor, we have to widen it so that we can pull it back. See here. Here it has gone into the sphenoid. See this here? Later. क्या कर रहा हूँ?
So the junction of interior and inferior wall of sphenoid is still intact, which you are removing, sir. Then we can have the single cavity.
We'll remove. Widen the inferior wall opening through which it has gone up.
Yes.
So that we can pull it back.
Yeah.
Now see, before going that, see the tumor anterior extent.
Yes, yes.
Here I am doing a septotomy behind that. See that?
Yes, yes. So you are in coagulation mode now, sir?
That was ablation.
Ablation, yeah.
When you remove the, see mycoperiostem, I am removing it as ablation.
Yeah, yeah. Yes, yes.
Be careful not to go into the tumor with ablation.
Yes, sir. Otherwise, it will not forgive you.
Start bleeding like anything.
So the direction of the wand is important.
Yes.
So you have almost reached the lateral part of the tumors behind the septum.
See, this is the posterior edge of the septum.
Yes, 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 yes.
From here, I will go to the opposite side. The brighter. See now, I am opening the बोल रहे भी See the opposite cavity?
Yes, yes.
Ovulator. Shut up. See, I am in the opposite nasopharynx. See, in the nasopharynx, opposite side. Hello.
Yes, sir. Yes, we can see. So there is one instrument coming from the other nostril. This is probably the sphenopalatine supply on other side. Maybe ascending.
See the opposite side.
Yeah. We can see the nasopharynx now.
Poblatus. See, such a huge component.
Yes.
Hardly any space. Challenge is there is hardly any space.
Yes, sir. And the nasal cavity is also not that big. Small child. Everywhere there is tumor. So that's the posterior part of the posteriormost part of the middle turbinate. And
yeah, that is the posteriormost part.
Yes. And here the sphenopalatine gives the supply. Yes.
Now I am dividing the supply.
Yes, sir.
Coming from the opposite side. See?
Yes.
That is the sphenoid.
Yes. Yeah. And we just saw the glimpse of some adenoid tissue there. So have you used the vessel sealant? They say that is useful.
Right. See, I am freeing the medial attachments.
Yes.
The last medial attachment. See in the floor.
Yes. So that is supplied by the sending current. We've already controlled the sphenopalatine opposite side. Yeah. Yes.
This phase will become. So there is attachment from the
nasopharynx. Yeah. Now it's separated the inferior parts. Sometimes due to the repeated bleeding, the packing also takes a lot of synechia and
see this is the
mucosa is attached to the tumor at many
attachment
places.
from the posterior part of the septum which I have divided.
Yes.
With the tumor surface.
Yes.
Septum it is free. We have made free from the opposite side as well.
Yes.
Lastly from the sphenoid we will widen and then we'll divide and remove this medial part. So time has come now to free this medial part once the sphenoid opening is widened.
Yes.
Until clear.
I remove like and then there is interruption.
See the tumor? No, the problem. See this widening of the sphenoid opening is essential to yahan rakhna.
So I think the sphenoid is now widely open. It is connected with the nasopharynx.
Yeah, it has been widely open. That's why tumor entered into it.
Yes.
But once tumor enter inside, expands. So in order to remove the expanded tumor, you have to widen the
Sphenoid.
opening of the sphenoid. See, that's what I'm doing.
Yes, yes.
See, there's such a wide opening.
Yes, yes.
Right. Last part.
That's the bone.
Is bone.
That's the floor of the sphenoid.
Yes.
Awesome. Also in the just little bleeding. Also, sometimes we should not operate a patient when already hemoglobin is 8 or 8.5. Always either give blood or give hematinics and build up the patient, especially the younger ones.
See this bone.
Yes.
Making the sphenoid and the nasopharynx
Single cavity.
This was entering and now this will open, come out through here. See this?
Yes, yes.
Khulna. मौके पे So now I have a wide access. See this? You have to ensure that the opening is wide enough
Please change the battery.
to push the nasopharyngeal sphenoidal component back in the nasopharynx. Okay? Right. It is done. And now we large medial component. Once this large medial component is out, removal of the rest will become much easier. See this?
So again, this will act as a goalkeeper.
Now we will divide the tumor here at the medial edge. I told you from the medial wall.
Sir, can you clean and focus the scope for a moment?
Yes, yes. This is component. This is nasopharyngeal component below. Can you see very clear?
Yes,
very
yes.
Clear. Very clear.
And this is the bottleneck at the lateral wall. See this?
Yes,
yes.
This is what I am going to divide now.
So can you focus the scope or just to avoid balance so that we can. It's blurred just a bit.
Better? The copy.
Yes.
Less. I divide. See now the edge where I'm going to divide.
So in the line of pterygoid, that's a good part to do is in the line of pterygoid, all feeders are either laterally or medially. In the midline, it's a waterside area also.
Yeah. Bipolar is it? See, this is the, I am showing you with the bipolar. This is the bottleneck.
Yes.
Look at the section there. See the demarcation between medial and lateral part of the tumor?
Yes. 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 Clearly seen.
Now I will divide here. Find out. Can you see the tumor
now
being
divided?
divided?
Yes. Yes. Yes.
I have reached the posterior wall.
Yes.
Means the anterior wall of the sphenoid. See, this is the anterior wall of the sphenoid.
Yes. Yes.
This is medial tumor. This is lateral tumor. This is medial tumor now.
Yes. Yes.
Very clear?
Yes. Are we taking care of ischial tube orifice there?
Use.
Sir, are we taking care of?
Brought down. Now we
Sir,
have
are
to
we
bring
taking-
down. Hello?
So it's actually, we are still submucosal. The periosteum, mucosal and the periosteum is still intact. So
See this.
we need to.
This whole tumor
Yes.
has to come down now.
Is sphenoid.
This is sphenoid component.
Yes.
See the sphenoid component?
Yes. Yes. So we can see the planum, the bone is eroded. Now the sphenoid component is coming out. Yes, that's the part of sphenoid. Yes.
See the sphenoid component coming
Yes.
out?
Yes.
Yes, the planum entire bone is eroded, sir.
Yeah,
Seems.
yeah. अटक रहा है वो एक जगह.
Yes, these are the lacquers. Yeah, now it's delivered from the.
See, I am pushing in the nasopharynx.
Yes. Because the size may be too huge to come out through the nose.
Yeah, yeah. See the anterior wall nasopharynx.
Yes, yes.
पानी तमाशा देख पानी. Section. Show the sphenoid. Easy. See the sphenoid behind.
Yes, yes.
It has come out of the sphenoid.
Now
And
it's from the
entire thing-
basisphenoid and roof of the nasopharynx attached.
Entire thing being pushed into the nasopharynx.
Oropharynx.
Yes. Too big. Got this. See, being pushed. Sorry. See, that is a pterygoid component.
That's a good name, that's a.
Okay. See, this has come out. See the pull, which has brought the
Yes,
tumor
yes,
down.
yes.
Can you see?
Yeah. Yes, yes.
Excellent.
Sometimes this is the most difficult part because the nasopharyngeal attachment is so push and pull works here. Yeah.
That's a huge nasopharyngeal component. Utha. That's the only periosteum attachment which I am going to divide. See, the whole tumor in the midline has gone down. Could you see?
Yes, yes, we can see.
Hello.
Yes, yes. Dr. Satish, we can see, yes.
See, this is the periosteal attachment which I am
Periosteal
dividing.
attachment, yes.
See, the tumor has gone down.
Gone down, but this is the last attachment. Basisphenide and the proof of the nasopharynx junction periosteum. That's the ascending pharyngeal most probably.
It's branches from that, not this.
Yeah.
Because, no. See, nasopharyngeal roof.
Yeah,
Periosteum.
the tumor is dissected, yes.
This is the nasopharyngeal roof.
So usually you have adenoid persistent over there. Do they cause trouble once you dissect over there?
Adenoid surface is always free.
Yes.
Tumor doesn't take attachment. Okay, Chaudhary, 2 minutes.
So it's the superior surface of the adenoid where it is attached. Yeah. So you have to just separate from the periosteum. Sometimes you can damage it if you are a little harassed, then just do bipolars.
Tumor is out. See?
Somebody can pull from the oropharynx.
It looks like a little bit of attachment there.
It's part of adenoid also.
Section right there. See now what we have achieved. What a massive tumor. See this? This is the lateral component. Can you see? This is the sphenoid sinus. This is all medial component which is pushed back in the
Oropharynx.
oropharynx. Can you see very clear?
Yes, yes.
Panoramic view. Hello?
Yes, sir.
Am I audible?
Yes, yes, you are audible, sir.
Hello?
Sir, you are audible. Maybe you are not getting our voice.
Hello?
Yes, sir, you are audible.
Yeah, can you see this? The entire
Yes,
component has been pushed behind.
Yes, yes. And this is the pterygoid marrow which is expanded and containing the tumor.
Yeah.
It is
So we
a
have
bit
pulled
bleeding.
out from there and now rest of the tumor lateral component we will remove.
Yes.
So
and
now
then
we have,
running the
see
pterygoid.
now how much of the space we have acquired now.
Yes, yes.
The rest of the component will pull in the nasal cavity. Now see this, everything open up. See this, huge. Look, look. Oh my God. The tumor size was much, much bigger than his original nasal cavity and nasopharyngeal size. It has expanded. Sorry. Hello?
Wow, it's a very big, sir, very big. A big round of applause from the auditorium.
But this was, see this was the,
Yeah,
this
we
was
can see that
sphenoidal
the white
component
portion
and
is
this
the
was
sphenoid
nasopharyngeal
portion,
component.
sir. The white portion is the sphenoid one, and this is the nasopharynx and oropharynx portion.
Now coming back. Now to remove the rest of the extensions.
Just pull it and
It
deliver into
doesn't
the
take
nasal
attachment
cavity.
in the sinus anywhere. See this.
Yes, yes. That is the
Doesn't
beauty
take
of
attachment
this.
on the nasal floor. Doesn't take attachment on the adenoid surface.
Yes.
Wash. So, and now the interesting lateral component. I hope it is very clear.
Yes, yes, very clear, sir.
See the adenoid surface.
Yes, yes.
It never takes attachment on the adenoid surface.
Yes, the only the periosteum superior to it is attached.
तो देख काला और कुछ मंगा दे
The good old suction monopolar.
See this adenoid surface is
Yes,
absolutely
yes.
free.
Yes.
What a massive tumor occupied. See this? Now, coming to the lateral part of the tumor, we know the lateral extensions. So what? There is one.
So this is the posterior part of the posterior and inferior part of the orbit.
Yeah, this
So
is orbital fissure.
yes, because we have to remove the inferior orbital fissure and
See this
superior
tumor
orbital
going
fissure.
up in the inferior
Yes,
orbital.
yes. Yes, this the medial part is inferior orbital fissure, and then laterally it will take us to the superior orbit.
मंगा दे कुछ खाने को फटाफट Move. Okay. The periosteum I am see all these tumors
into the inferior orbit.
rising towards the superior orbital fissure. Ajay, see this tumor rising towards the superior orbital fissure here. Can you see the pterygoid process?
Yes, yes.
And this is all tumor. Okay.
Fat is there.
Now we will
Infratemporal
pull this
fossa fat
tumor.
is there.
See this. That's the
You
lateral
pull
component.
towards laterally and then dissect.
Vessel line. Clip रखना रे. See this. Pull this tumor.
Yes, sir. And we can see the fat behind, yes. So once you see the fat, that's the lateral extent. Yeah.
दूर से पकड़. See, pull. Advance pull. Advance pull. See this?
Yes, yes.
This is the way of dissection. See the vessel going laterally?
Yes.
Give me one clip here. See the vessel?
Yes, yes.
Yeah, just put it there.
नहीं उसको मत छोड़े आप. उठा सकते यार तो भी.
That's the branch of maxillary artery also, sir? Or
Yeah, that is continuation of the maxillary only. That is continuation of the IMA.
yes, that's orbital portion is being, so you will remove it later.
Debrider.
Eat up the fat.
Yes, see the vessel behind cord.
Yes. Yes, pulsating also.
See, this is periosteal attachment.
Yes.
That is the vessel. The fat. Can you see the vessel much clearer now?
Yes, yes, yes.
Also. See the specimen is hanging on this vessel only.
Yes, yes. And it is also pulsating, sir.
See this vessel. That is the main trunk.
See, actually, the system.
Main trunk of IMA.
Tend to keep doing what you are doing, even if there is some problem.
See this vessel?
Yes, yes. This is like, guess the maxillary artery only. Sir has cast it. You can see that where the previous clip is. So it was traversing through this tumor. You can see the previous clip is in continuation almost. Now you can divide it here.
पर छोड़ क्यों नहीं है यार? ये तो है। अच्छा वाला पकड़ा हुआ था यार। ऐसा नहीं होता यार।
The dust component is going up, sir. Yeah. Now separate. This portion is going into the pterygoid marrow, greater wing. No,
see.
This small tumor is there.
This is all removed. Okay.
Yeah, that's the tumor in the marrow going inside.
See what I want to show. Show them.
Orbital fissure.
This tumor is
Superior
going in the
Yeah.
Yes.
Yes. Yes. Pull it down. Yes.
Gently. See.
What is intraorbital and lateral?
Don't. It's coming out,
Yes.
coming out.
Yes, yes.
From the cavernous part.
Yes.
That's a huge component coming out.
Yes. Intracranial extradural. Now we'll have cavernous bleed.
That is bleeding and the tumor is out.
Yes.
See, that's a tumor.
Yeah, big component.
See, it has come out intact. Could you see?
Yes, yes.
It has come out intact.
So because it has gone through the superior orbital fissure, it has widened it.
Wow.
And
So you have to pull
then
it
went
accordingly.
paracavernous, intracranial but
Never
extradural.
press tightly. So never press tightly because their nerves are arranged in a very, very dense manner.
Yes, yes.
To each other. Hello? Now the entire tumor is out. Now what I will check is wash.
Sir, what
This is the superior
sometime
orbital fissure.
like in one case, I did pack it tightly, and I faced with the 6 nerve palsy. It was recently, I think, 2 months back. There is partial recovery. So if some patient have 6 nerve palsy,
yes, 6 nerve is
immediately
common
after
because
surgery,
this passes through the lumen of the cavernous sinus.
yeah. This is into the marrow, pterygoid wedge and marrow. Just please rotate it. And
See,
this
the
requires
entire
drilling.
tumor. दिखने दो यार, screen पर. Yes.
This is the marrow infection, which is most important part to prevent any recurrence. We after drilling, we can remove. Okay, right.
See the tumor contained in the pterygoid. I told you.
Yes, yes. So the pterygoid and also going laterally to the greater wing.
Right.
Yeah.
This is the component. See that?
Yes. Yes.
And accordingly, this has to be. See this
Removed
component?
and then drilled around.
See, I am opening up.
Yes. This is a beautiful instrument to remove the bone. There is one need to drill it.
Yeah.
Maybe, sir, can we drill and then it will be removed?
Yeah, yeah. Hmm. Hmm.
Yeah.
Hmm.
The marrow bleeds here, the pterygoid marrow, once the tumor is removed.
Just a minute. See how big the tumor here.
Yes, tumor is going inside the
Pterygoid fossa.
big component.
Oh, they up front. Quick.
Can you use a ball probe, sir, to just dissect it around?
I will pull. I will pull so it doesn't break.
Okay.
This. That is from the pterygoid fossa.
Yes. Yeah, now we can see. So once we remove the tumor, we have press bleed from the
This is
pterygoid
pterygoid muscles. This is
marrow.
nothing but muscles. Ovulator. Ovulator.
But I was
See the tumor coming from where? Coming from this narrow space of greater wing of sphenoid. See this?
Greater wing of sphenoid. So laterally we have the greater wing and inferiorly we have the pterygoid.
Infiltrate this narrow space.
Yes, yes. And drilling this is very, very important to prevent any recurrence.
That is the narrow space all over. See this? Completely cleared off. Proceed now. Give me the rider. See the narrow space everywhere.
Yes, yes,
yes, sir.
From such space, the tumor is never broken, you know.
Yes, yes.
Always gently, gently pulled. Even if you leave a bit of it, it is
That's
bound
going
to come
directly.
back.
Using the writer there. Sometimes this extension goes very deep, sir.
Now it is completely. Now give me that. Go there. Look. Now I will show you what to do with this narrow space. How to ensure that no tumor. You can see
Yes, yes.
this is all pterygoid. See,
Yes.
above is the superior orbital fissure where you have packed the cell. Entire space.
This is the most important step of the entire surgery. To drill this.
Though we have removed, but still.
So there is some rotation of the endoscope. Can somebody just
close by. उधर चल जा.
Yes.
See the narrow space.
Yes, yes. So the color changes once you drill it, it's become white, and then you are sure that you have tumor and any extension inside.
See the entire pterygoid skull base.
Yes. Greater wing of sphenoid.
No tumor has been left behind. See this?
Yes.
And that is all shining bone. मेरे को पानी दे सेक्शन को.
That's the video.
With it.
Yeah, yes.
See the skull.
Yes, yes, we can appreciate.
Entire You know, that is the sphenoid flow.
Yes, yes.
Everywhere. That's the panoramic view of the well, see this. Hello. No bleeding. See the complete tumor removal. Of later. Complete tumor removal.
Yes, yes, Dr. Satish.
Yes, sir. Thank you very much for a very
Excellent
good, nice,
demonstration.
good round of applause from the auditorium.
Thank
You
you.
made the most difficult surgery look so simple, elegant.
See, by and large, what I believe.
Can you just show the V2? If
Yes,
there's
there is a question from the audience. What
just
about the
if you
V2?
can see the V2.
V2 was superior.
I think the internet connection is unstable.
I am just removing this periosteum of the nasopharyngeal roof. See, the adenoid surface is absolutely normal.
Yes, yes. So there is a question that can you show the V2?
V2 I didn't see because it was lateral. V2 is, see here. See there. See here.
There's
Lateral.
the inferior orbital nerve will continue as V2.
Yeah, that is
Yes.
here laterally going up.
Yes, yes, yes.
So that was not our area of interest.
So the best way to find V2 is follow the inferior orbital nerve. It takes you to the V2. And usually that's the superior limit of the tumor. It does not invade V2 by some time. It can wind around the V2. I think that's up there. Just above the this surgery
This is
cell.
the final picture.
Yeah, that's the.
Amit,
Yes, yes.
so that's the final picture and we move on to the next case.
Yes, yes.
Thank you very
Thank you
much.
very much, sir. Thank you.
So the case had interesting extensions everywhere. ये दूसरा अंडर कर दे.
Yes, sir. All possible extension.
किसके?
I now request Dr. Abhay Singh to kindly moderate the next session.
Oh, Randa. Oh. Hello.
Hello, sir.
Yes, please. Hello. Yeah. Are you getting the pictures?
Yes, sir. We are getting the picture.
See this patient. This patient has a reddish mass on the promontory. Can you see something on the MRI? Hello?
Yes, sir. Clearly visible, sir. Nicely
This
here.
reddish mass
One.
on the promontory and going anteriorly towards the Eustachian tube. Prolapsing in the Eustachian tube. Can you see?
Yes, sir. Very well, sir.
And on coronal, this mass is going little up towards the atic as well and little towards the hypotympanum.
Yes, sir. Clearly seen, sir.
Yeah. And see, this is not going anywhere in the mastoid behind. This is
Yeah,
right
absolutely,
on the promontory, and that is what a classical picture you see.
Very typical of glomus tympanicum.
The tympanic membrane, glomus tympanicum. So, interesting scenario. Interesting case. These are the cases which are rewarding as well, as they can be removed by a simple, post-auricular approach. There is a classification what Mario San has given according to the need of extensive approaches. The small one on the promontory limited to the big one involving the mastoid everywhere, involving the petrous carotid. This is simple A2 kind of a tumor, which is from the promontory going towards the beyond the confines of the otoscopy, prolapsing in the eustachian tube and going high up in the atic, and little bit in the mesotympanum. So this is classical of
Glomus tympanicum.
tympanicum. This is classical of a glomus tympanicum. If we look at the CT scan, see this CT, what CT will show? Some mass lesion on the promontory. Can you see?
Yes, sir.
But the jugular bulb is intact. See, the jugular bulb is below.
Yes, sir.
It is intact. This is limited to promontory. This is tympanicum.
Sir, is this patient having a concomitant mastoiditis also?
Yes.
Same side.
Always. Once it goes towards the atic or retrotympanum, it blocks the aeration and develops a little bit of the haziness.
Sir, in your experience, how frequent you have seen the dehiscence of jugular bulb also, case of glomus tympanicum?
बड़ा कितना आ गया था?
रेटिंग आ गई थी 69।
ये क्या है? इसी का है क्या?
ये तो आप चालू करो, ठीक हो जाएगी। इसमें कोई दिक्कत वाली बात नहीं। वो तो एक बार अगर इतना हाई जाता है ना एड्रेनालिन के कारण तो गिरता भी है।
दो घंटे का।
हाँ, वो ऐसे एक्टिवेट हो जाता है।
पोस्ट खोल दो।
सर्जरी दोनों करो, वैसे ही बढ़ जाएगा। ठीक,
खोलो पोस्ट।
एक जरा हाँ भाई क्लोज करके
कुछ खाने को करो। कहाँ है? हेलो।
हाँ sir, you are audible, sir.
So
Sir,
this is what is.
There is a question, sir. How frequent in your experience you have seen glomus tympanicum associated with the dehisced jugular bulb, sir?
Glomus tympanicum associated with high jugular bulb.
Dehisced, sir. Thinned out jugular bulb. Is it frequent or it is most of the cases it is well maintained, sir?
No, I didn't get your question. Glomus tympanicum associated.
Glomus tympanicum with the dehisced jugular bulb or bone, sir.
With high jugular bulb.
Dehisced, sir. Dehisced. Thinned out.
Dehiscent.
Dehiscent, yes, sir.
Oh, yeah. Dehiscent jugular bulb. The dehiscent jugular bulb is a different entity. This big tumor compressing on the jugular plate can lead to dehiscence. But mostly tympanicum is a different path of spread and jugular is a different path of spread. So it generally doesn't lead to erosion of the jugular bulb. So that's a very, again, an interesting scenario. See the tumor prolapsing in the Eustachian tube doesn't have any attachment. Similarly, you have to pull it out.
Yes, sir.
Coagulate, pull it out, it will come out easily. No attachment. Only attachment this tumor has is towards the hypotympanon.
Yes,
The
sir. Very well seen in these images, sir.
vessel is coming from below. Vessel is coming from below here.
Yes, sir. Quite below, sir.
Yeah, vessel comes from here. So, and see, it is occupying the atic. So, we will coagulate and pull from the atic down. It must be engulfed in the ossicular chain sometime leading to tinnitus. Similarly,
Yes,
we will devascularize and pull it down. Attachment is inferiorly, there we will coagulate or drill away the canal. This is how glomus tympanicum are dealt with.
Yes.
Can you see this scan?
Yes, sir.
Hello?
Yes, sir. We can see, sir.
That's the next DNA.
Very extensive, sir.
This is like a bag. This is like a bag, the huge parapharyngeal component.
Yes, sir. Very well evident, sir.
I can't think today, but I can think.
So, in a couple of minutes, we are getting back to you with a microscopic picture.
Okay, sir.
Oh, no, really.
इधर ही लूंगा, बहुत बड़ा केस है ना, तो इसको बाहर ले ले भाई। जल्दी ले ले, दूसरा लेना है। ट्रॉली अंदर गोदी में ले आएगा क्या? बड़ा है।
Hello.
Yeah, sir.
Yes. So we are all set now. So just we are connecting to the microscopic picture.
We are all waiting, sir.
Yeah, my team has already opened the post-auricular area, already opened the canal. So now
These
rest time.
days, many people attempt to do glomus tympanicum endoscopically, sir. Do you also prefer, or you straight away prefer microscopic?
You can try, but see, is that going to give any advantage with a vascular tumor?
Naturally, no, sir. Naturally, no.
Vascular tumors needs both hands free, binocular vision to control the vascularity, to bipolarize. All the time it needs bipolarization.
Absolutely.
It requires drilling also for exposure. All these things, I think endoscopy, endoscope can be used for everything. People are trying for everything. But any rationale, I don't understand for this.
Microscope is naturally better, sir, in dealing such situations, both hands free.
Can you see the picture?
So the same picture, now we can see the picture, sir.
फोन किसका है? देख लो ना यार.
You can see the pulsation also, sir. Not a typical rising sun appearance as of now.
Yeah. Typical this, reddish hue behind the tympanic membrane. So there are many ways to deal with this. You can raise the post-auricular skin. If accessible, you can remove it with that. If not, requiring more drilling for exposure, you can remove this cup of canal wall out in the saline, out in the saline, and then remove and then can replace. All depends upon the condition. क्या किया? बंद कैसे हुआ?
Sir, what will be the cotton ball adrenaline concentration you will be using in this case?
In this case, topical?
Yes, sir.
Pure adrenaline.
Pure adrenaline.
See this? I'm raising the flap on reaching to the level of patla de yaar. एक मिनट रुको. Reaching to the level of annulus. See the tumor underneath.
Yes, sir.
Oh.
It's quite a big tumor, sir, as shown in the CT going towards the attic and ossicular area superiorly.
Yeah, as
And
it explained.
very well inferiorly also, sir.
Yes. Here in the tympanic membrane, sometime due to cautery, sometime due to elevation, can be dealt with.
TM grafting.
Yeah, and see this around ossicular chain. I told you.
Yes,
This
sir.
is pushed superiorly. See this is the incus.
Yeah, sir. Incudus stapedial joint is visible.
Yeah, but it has no
Tumor is
attachment
absolutely
superiorly anywhere. Generally, it doesn't have any attachment superiorly. Cotton ball. पतला है यार क्या दे रहा है forceps और पतला पतला दे और too big a cotton ball. Yeah. एक जने और बुला देते हैं कॉटन वो now bipolar is the key किधर है right side इधर इधर ये क्या shear bipolar.
Yeah, sir. Sir, what is the setting? 10, 15? What is the setting of bipolar right now, sir?
Pardon? Pardon?
Sir, what is the setting of bipolar right now? 10, 15 or 20?
कितनी है भाई बता दो 20
20.
धीरे धीरे scissors look at that. He is such a huge component.
Yes, sir.
You can shrink the tumor by means of bipolarizing it.
It's nicely shrinking, sir. Can we expose the superior region a bit more, sir? Like towards 1 o'clock position?
Yeah, we'll do that.
Yeah.
Great. See, the vessel is coming from below.
Yes, sir. Tympanic plexus and Jacobson plexus is the main area of concern for the supply to happen.
Yeah, see, because of the close proximity of this lesion to the ossicular chain, they frequently present with tinnitus.
And tinnitus absolutely resolves, sir, in most of the cases if we remove the tumor nicely.
Yes. I pull some more tumor from the atic side.
Yeah, sir. Malleus looks all engulfed so far. No glimpses because of the tumor.
Force. बड़ी नहीं आप क्या दे रहे हैं क्रोकोडाइल लेना क्या दे रहे हैं ये लो क्रोकोडाइल I'm just trying to get over the superior limit.
Can we use a cotton ball here, sir, to establish the plane of cleavage?
I have the cleavage plane.
Yeah, now we can see that, sir.
Cotton ball. Yes. See the plane? Hello?
Yes, sir. The plane of cleavage is nicely seen now. The promontory also. The superior part.
What I was trying to see, if superior wall can be pulled out, you don't need to do episiotomy.
Yes, sir.
That is what I was trying to see. Now, we will devascularize it from below. And the vessel is coming from below.
Yeah, below also it is extending quite deep, sir, as in CT.
Yeah. So, he elevating the tympanomeatal flap. Forceps. Trying to get. See, all around the tumor is beyond the confines of the tympanic cavity.
Yes, sir. Too much into hypotympanum.
$1. And in that situation, I may have to bring the cuff out.
Yes, sir.
Circular. See the lower limit?
Yes, sir. Nicely seen.
I am trying to elevate it. See this?
Yes, sir.
Here is the vessel.
Yeah, sir. It's bleeding.
Cotton ball. Cotton ball. क्या हुआ? Just wait for the
Just continuously bleeding, sir.
see my feeding vessel is here below.
Yes, sir.
ठीक है?
Yes, sir.
ज़्यादा थोड़ी ना. See, I am just acquiring space to see the feeding vessel.
Yes, sir. Sir, there is a malleable ball probe cautery, which is really helpful in dealing glomus tympanicum, especially at these areas, sir. We can
बंद हो गया.
bend the tip and can straight away cautery the bleeding zones, less space occupying than bipolar.
Yes. If you don't find any big vessels,
Yes,
come under
sir.
control. Have patience. Side knife.
Side knife. Sorry. Side knife. Side knife.
Section दे इससे बड़ा थोड़ा. Give me a bigger section. क्या हुआ? फिर क्या किया? Cotton balls. See, I am elevating the tumor from all around.
Yes, sir. Now the bleeding area is also very much accessible, sir. Very nicely. The bleeding area also seems very much accessible, very nicely exposed, sir.
It can be. There are no much bigger vessel in this. Circular. Circular. For sure. Cotton ball.
Cotton ball. Cotton ball.
So slowly, I'm looking all around.
Yes, sir. Almost we are accessing the eustachian tube orifice also, sir. We have.
That is easiest to remove. That you have to just pull.
Yes, sir.
कैसा है वो पूछना? We carry the vessels. Carry the vessel.
Yes, sir.
लगा इसी को लगा दे. यूनिक. हल्का हल्का. Yes. Yeah. One more. Say this.
Yes, sir.
ये बंद हो गया. See the feeding vessel.
Yes, sir.
आ रहा है भी. दिखा दे. Pause. See everything under control.
Yes, sir.
Okay.
Malleus still needs to be denuded a little, sir. Looks all engulfed still.
See hypotympanum. Very clear.
Yes, sir.
Retrotympanum very clear.
Mm-hmm.
Epitympanum very clear. See this?
Sir, superiorly, a little bit of component in the anterior-superior quadrant. Is it so, sir?
Yeah. This is not tumor. See, it's been removed.
It's because something is there, sir.
You know, I will show you. No tumor. Now the anterior part, which I have to carefully elevate and see. See the tympanic membrane.
Yes, sir.
See the anterior-most part now. See the
Yes, sir.
anterior annulus.
Yeah.
That's the anterior annulus.
Yes, sir.
Elevating up. That's the anterior-superior region.
Yes, sir.
And this is the entire tumor left.
Yeah, sir. That is exactly I was.
टूट के गए.
Now it is almost coming out of the superior
That's
zone.
the second tube. अरे उठ गया क्या? बोल नहीं रहे क्या? बोल. चौधरी यार. See the promontory. And that's the anterior component. See this?
Yes, sir. Very nicely.
And see now how the eustachian tube component is going to come easily.
Yes, sir.
वो तो बड़ी वाली मोटी वाली से. See, I'm pulling it. See this?
Yes, sir.
It has come out.
Very nicely, sir. Very nicely it is out, sir. We will be drilling the attachment over promontory, sir.
Yeah.
At last.
This I'm going to coagulate.
Post coagulation drilling, sir, like many people recommend, sir.
Yeah. Now see, all stopped.
Yes, sir. We'll be drilling a bit, sir, the suspicious attachment.
Not really. I don't see anywhere eroding the bone. Hear this?
Sir, can we get a little more focus?
Yes. This is Eustache and tube. See this?
Yes, sir.
Touch. Can you see the Eustache and tube orifice?
Yes, sir. Yes, sir. We can see, sir.
See the Eustache and tube
Yeah,
orifice?
better, sir. Better, sir.
Now see one by one all quadrant. This is anterior. Oh, side note. This is anterior Eustache and tube. I have removed. It has come out.
Yes,
So
sir.
never attachment in the Eustache and tube.
Yes,
This
sir.
is anterior superior. See this?
Yes, sir.
Absolutely clear.
Yes, sir. Absolutely clear, sir.
Now see inferior. That is the annulus and this is the inferior compartment.
A little bit of ooze is there, sir, from the hypotympanum, nothing else.
Mucosa. That's it.
Yeah.
Hardly any. See, hardly any.
Mm-hmm.
No ooze rather. Now coming to the posterior compartment. This was the main vessel. See, this was the main vessel. This one.
Yes, sir. Yes, sir.
So I will put one more. Yeah. See, this was the main vessel.
Yes, sir.
Okay. Now coming to
Yeah,
the
it is.
posterior compartment. I'm showing you all corners.
Yes, sir.
Absolutely free. Where the round window is.
Yes,
Now
sir.
see, this is posterior superior. See the includostepidial joint.
Yes, sir.
All well.
Yes, sir.
Absolutely fantastic. Give me all pro. This is some redundant mucosa, nothing else. All opened up.
Yes, sir.
See that? So all corners you have seen, it has come out. Give me a form a little bit. There is a small tear in the tympanic membrane which will repair. See now the entire middle empty.
Yes, sir. Malleus is still, sir, attached with the mucosa. We elevated in the TM flap.
Pardon?
Malleus, sir. Malleus will be leaving the mucosa over the malleus.
The mucosa malleus is intact. Let me show you.
Yes, sir. One of the audience wanted to see that, sir.
Yes, see the malleus. I am rotating anteriorly.
Yes, sir.
This is malleus, this one.
Yes, sir.
See the malleus. Yeah.
Yes, sir.
See the malleus there.
Yes, sir. It's seen, sir.
This one is malleus.
Yes, sir.
Could you see?
Yes, sir. Yes, sir. You can see, sir.
So lastly, what you have to do is deposit the flap and repair with a small graft. See this?
Yes, sir.
और एक ग्राफ लगा देना.
It would require temporalis fascia grafting, sir. Otherwise, very nicely handled all the quadrants and all, sir. Hardly anything as a rent.
One point you have to be ready for, entire cup removal.
Yes, sir.
But we didn't find. We'll just put on underlay patch. That's it.
Yeah, sir. That's it, sir. Very nicely done, sir. A round of applause from the audience also in the hall, sir.
This part, it was tightly adherent to the tympanic membrane, this part.
Yeah, sir. It was quite well understood.
That's why, that's why.
Yeah, sir.
See this?
Yeah, sir.
See the middle ear entirely free of tumor now?
Yes, sir.
Graph लगा देना.
You never drilled, sir. Last a bit of drilling over the Jacobson plexus.
No, no needed.
Okay, sir.
I just cauterize over it. That's it.
Okay, okay, sir.
So we move on to the last case. If you want to continue, you can.
Okay, sir.
So what?
Line कौन है?
अंडर कर दिया? अभी भी है? वही होगा टेटवा. So the last case is soon going to come. Are you? उसके ग्राफ लगा.
Did you finish it here?
So in couple of minutes, we'll be back with a very, very interesting case. Massive JNA. If you want to continue, you can. I know the time is. Oh.
Sir, there is a question regarding glomus tympanicum from one of the audience.
Yes,
hello,
please.
sir. Good evening.
Yes, please.
Sir, I want to know that is that vessel is always present, because usually when we are raising the flap in tympanoplasty, there
Pardon,
is
pardon?
brisk bleeding at that point always.
Pardon, pardon?
Sir, the point we cauterized, the feeding vessel, the point where the feeding vessel was, is there a vessel always present? Because usually when we are raising the flap during the tympanoplasty even, there is always some brisk bleeding at anterior inferior point while raising the tympanoplasty.
That is in the canal. That is
Okay.
a branch of anterior tympanic artery. Here,
Okay.
this is on the promontory.
Yes, yes.
This is
So-
on the promontory. This is a branch of inferior thyroid artery.
Okay, okay, right.
Inferior
So-
tympanic artery. Inferior tympanic artery, which is a branch of inferior ascending pharyngeal artery.
Okay, sir.
What you encounter
Yes, sir.
in the tympanoplasty while raising the anterior inferior part of the flap is
Yes,
a branch of anterior tympanic artery, which is a branch of maxillary artery.
And how to tackle that, sir? Just cauterize, just like with the suction, and just touch the cauterize.
Just keep an adrenaline ball for a while, it stops.
All right, sir. Thank you so much.
Welcome. So probably you have seen the last case with
Sir, I have one question about using a bipolar cautery when you are near to the facial. What
Yeah.
precautions should we take?
irrigation. Constant irrigation. Bipolar is much safer than unipolar, obviously. So there is not an issue, but yes, you have to be very close. Careful. Now see, can you connect this? The last case is the MRI. See this? The tumor occupying the anterior part of the nasal cavity one. See this? Coming far anteriorly, going here laterally. See this? That's the vessel here. See the vessel? Now going behind, this is the entire, infratemporal fossa and pterygoid component. This is in the greater wing of sphenoid. And this is like a ball, bag. See the big bag going down in the infratemporal fossa, in the parapharyngeal space. Can you see? This is the classical extension into parapharyngeal. What we'll do? We'll divide at this level. We'll divide the tumor at this level and remove this parapharyngeal component separately. Parapharyngeal, infratemporal fossa, all these components separately. First, again, our goal will be to remove this midline component. This is very, very massive. And see, regarding, see the carotid artery. See, it looks like the carotid is involved here. Can you see? Hello?
Yes, sir.
Or it is not. How to confirm? Because MRI doesn't pick up the bone. Let me show you the bone. See this. See, this is horizontal petrous carotid.
Yes, sir.
See, there is a thick bone all around. Can you see?
Yes, sir.
Which MRI doesn't pick up. That's the value of CT angiogram. See, all the way bone is there. Can you see?
Yes, sir.
So the carotid is pretty safe. Tumor is occupying the sphenoid sinus massively. See, such a ball. Such a big ball in the sphenoid sinus. Huge, like a cricket ball. But it is not attached anywhere in the sphenoid. The bone all around is intact. See this?
Yes, sir.
That is seen on CT scan, not on MRI. That's why whenever you get MRI for the vascular tumor, get the CT angiogram to complete the information from all aspects. So that is see this. This is the parapharyngeal component going behind the pterygoid process, and it is going towards the parapharyngeal carotid artery. Can you see this?
Yes, sir.
That is far behind, pushed far behind. See the parapharyngeal carotid level on this side and level this side. It has changed. See this. Level this side of the artery, and see the artery is pushed behind by the, can you see?
Tumor. Yes, sir.
By tumor. And see, this is a huge bag. Huge bag. Let me show you again. This bag, which has pushed the carotid behind, and we have to pull this bag completely. It's going to be massive. So where it is behind the pterygoids. Let me show you in both aspects. In CT scan, see where it is. See this bag which is going behind?
Yes, sir.
Hello?
Yes, sir.
This is behind the pterygoid plates. And this has pushed the carotid artery just behind, running just behind that.
Yes,
See,
sir.
this is the bag which has gone behind the pterygoid process. So in this case, we will drill away the pterygoid completely and then go behind to pull up this bag. This bag, huge. And the carotid is immediately behind, and there is a thick tissue in between that. Can you see this?
Yes, sir.
What tissue is that? Anybody? This is thick stylopharyngeal aponeurosis. And I can show you on the coronal as well. See this bag?
Yes, sir.
This bag going behind, and this is the parapharyngeal carotid. This is the parapharyngeal carotid, and a thick stylopharyngeal aponeurosis is pressed in between. So when we remove this, when we pull this, we can run our cobblator over the surface to separate this aponeurosis and the carotid behind. That's the cavernous carotid going behind, and tumor is staying little anterior to it. And there is a good plane. See, there is a good plane between the tumor and the vessel. See the good plane between the tumor. So different intensity of the tissues on CT and MRI in between clearly demarcates the involvement of the vessel, invasion of the vessel from vessel being pressed against. This is very useful information. If the vessel is involved, then the situation is altogether different. Then it requires a DSA, intervention radiologist help, everything. See the entire course of the carotid. See the carotid artery here. See this?
Yes, sir.
Everywhere coming down, and nowhere the tumor is, invading the carotid. Can you see everywhere? There is a tissue everywhere which is separating the carotid from tumor.
Yes.
So you don't need to terrify about the carotid. Carotid is pushed behind because of a tumor, but not involved. But there's a huge, massive tumor occupying everywhere. That's the posterior wall of the maxillary sinus, and this is where this vessel is. That's the internal
Yes.
maxillary.
Yes, sir.
That's the internal maxillary. We can do 3D. See, this is the maxillary artery. And now you can see in all planes this maxillary. See the maxillary artery there behind?
Yes, sir.
See how tortuous it is. This is internal maxillary.
Yes, sir.
We are going to pick up this maxillary
Hard button.
somewhere here, over 2 centimeters above. See this?
Yes, sir.
This is how you can have a fairly good idea about the location of this vessel on CT angiogram. See this? Another important information. This tumor looks like eroding the skull base completely. Can you see here?
Yes, sir.
We don't know whether the bone is eroded or not underneath the temporal lobe of the brain. Now, let us confirm on
CT scan.
fat suppressed MRI. See this. This shows you the clear distinction of the dural layer in between. Can you see?
Yes,
Dural
sir.
layer in between. That means it is not invading the dura. See, all this information you have to derive. The radiologist is not going to tell you all this.
Sir, can't we confirm that erosion on CT
Information
scan?
you want. Huh?
Can't we confirm that erosion of skull base on CT scan?
Yes, that's what I'm coming to. Now, the third thing I'm bringing along with these two. See this? The dura is not involved. Here looks involved because you cannot separate. And now see, this will completely clear everything. Now see, can you see the thick bone over it?
Yes, sir.
All the way. See the bone all the way. Can you see everywhere?
Yes, sir.
That means the bone is still intact. That's the value of CT angiogram. It's not when you get an MRI done, it is adequate information. Certain informations are best derived from the CT angiogram. Now see how this tumor is invading the sphenoid sinus. See this?
Yes, sir.
This is the part of the floor intact. Rest of floor is gone.
Is
The
eroded,
tumor
yes.
is ascended from there. See, we have to divide this tumor to the full thickness there, and it is going to bleed a little bit. There is no way you can help it, but it will. This will bleed,
Yes, sir.
but we have to tolerate that a little bit and pack. So this is now lastly, the CT angiogram is important to see the cross flow. See the anterior cerebral, middle cerebral.
Yes, sir.
Both anterior cerebral in the midline forming. See this? ACOM. See, this is ACOM.
Yes, sir.
Now, as we go behind, this is basilar artery, this is basilar, dividing into, see this, posterior cerebral. And this posterior cerebral is joining, see this, joining the middle cerebral. It has a good cross flow. Looks like good cross flow. See this
Yes,
on
sir.
axial. See, this is posterior cerebral, both posterior cerebral from the basilar. This is basilar, both posterior cerebral, and this is the posterior communicating going toward the carotid, middle cerebral. This is posterior cerebral.
Yes, sir.
Both sides. So it is a good cross flow completing the circle of Willis. Ready? क्या हुआ हो गया So in a couple of minutes we are starting now.
Yes, sir.
Okay. Yes.
पूरा भी साल में
Hello, can you hear me?
कनेक्ट कर दो ये अरे मॉब पैक कर गुरु इसमें क्या बैठी है तेरे वो उनको हॉल खाली करना हेलो हेलो कनेक्ट करो दोनों तरफ हेलो
Yes, sir. We can hear you, sir.
आर यू गेटिंग द पिक्चर हेलो
Yes, sir. Yes, sir.
आर यू गेटिंग एंडोस्कोपिक पिक्चर सर
Yes, sir.
So we have already started and about to connect you. This is what we have done. Since we have already shown the Denker, so I got it started. See the maxillary sinus. This is the nasolacrimal duct you can see. See the nasolacrimal duct? That's the maxillary sinus and that is a tumor inside. Is Rohan there? Dr. Rohan?
Sir, giving mic.
Sir, Dr. Rohan has gone outside. I'm Dr. IP Singh speaking. Sir, your surgeries were truly mesmerizing. The audience was spellbound. But we have a time constraint. We have been told to shut the auditorium so as to start it tomorrow morning at 8.
I know. So you can continue your evening, your dinner. All the best to everybody.
It was a wonderful evening, sir. Thank you so much for such a wonderful surgery.
Thanks to everybody for being part of it, giving attention to it, and big thanks to the organizing team who really arranged for everything. Big thanks to Dr. Kotwal, Dr. IP Singh, Dr. Rohan, and the entire team for making this event memorable. And all thanks to the Indian Academy for giving me this opportunity to interact with you all. With a special thank to Mohan Kameshwaran sir, Madan Kapre sir, Dr. Vijay Krishnan and everybody. And wish you all the best for the conference. See you all on Sunday.
Thank you very much, sir, for such a wonderful day of good surgeries.
Thank you.
Thank you so much, sir.
Thank you. Yeah. डिस्कनेक्ट कर दो अनुपम डिस्कनेक्ट करा दो कहाँ से आ रहा है